morning. I am Vinay Dhir, and on behalf of the Asian EOS Group and the IDL Care at SL Raheja Hospital, I welcome you all to this Train the Trainer meeting. It is being taken. We have started it, I think, 3 years back, and because of COVID, there have been some changes. Normally, we have about 15 or 16 participants who come to a center, and then we give extensive training over 2 or 2.5 days. But because of the COVID travel restrictions, this meeting and some other meetings have been modified, and we are doing it in webinar format. So we are very happy that we have trainees from all parts of the world who are participating in this meeting. About 80 odd people from USA, South America, Europe, Asia, all parts of the world are participating in this meeting. And we hope that over the next 1.5 days, all of us who are attending will learn something, will learn some practical tips. The focus is going to be interventional EUS, and we have planned the program in such way that it is more practical. So we start with accessories, where you will learn what accessories are needed when you start your interventional EUS at your center. Of course, you need a trained person to teach you wherever you are working. You need a good equipment, good accessories. Cases are less all over the world because this is an evolving technique. So models are very important. So we have kept one session on the models where we teach on models, but we also have lectures from renowned faculties. Professor Mitsuhiro Kida is here from Japan, and Dr. Sandeep Laktakia, Dr. Rajesh Puri, Dr. Matthew Philip from India would be giving us lectures, and we have live cases. So we have almost all common varieties of cases which we encounter for interventional EUS, and about 10 cases we will show today, and tomorrow a few cases. So this is how we have planned. The whole program is very practical. I want you all to actively participate in the program. Please ask lots of questions. So if you want to ask any question at any time, please type it in the chat box, and we will ask the relevant speaker or the person who is doing live your question, and it will be answered. So be very interactive, ask lots of questions, and because this is your meeting, we want you to learn something from here. And let's hope that over the next 1.5 days, we make you more confident in this wonderful technique that is interventional EUS. So without much ado, I will pass on the mic to my colleague at IDL Care, Dr. Priyanka Udawat. She will run the course. Priyanka?
Thank you, sir. I welcome you all for Train the Trainer course. So the first topic today is introduction of accessories, needle types, guide wires, dilators, stents, etc. And I would like to invite Dr. Rahul Shah. He's senior gastroenterologist and interventional endoscopist at Institute of Digestive and Liver Care. He'll be presenting first the slides, and after that there will be direct demonstration of all the accessories. I over to Dr. Rahul Shah now, and then there will be some demonstrations from our endoscopic technician Bipin Matthew also.
So good morning, everyone. Can you hear me?
Yes, Rahul, please go ahead.
Okay, thank you. I'd like to thank the Asian EUS group for this opportunity, Dr. Vinay, Dr. Sandeep Laktakia, Dr. Matthew Phillips, and Dr. Rajesh Puri for this opportunity. So what I'm going to do today is to first give you a couple of slides about needles, wires, cystotomes, and stents, and then we'll go on to some practical demonstrations. Feel free to stop me if you want to ask any questions.
Rahul, your video is frozen.
Okay. Okay, just 1 second. Deepak, Bipin ko bola. Just 1 second.
Yeah, yeah. Take your time. No hurry.
नहीं नहीं
So,
नहीं frozen हो गया. Video
common
is frozen.
is in this next 45 to 50
Suddenly हो गया.
use at our center and that are commonly utilized at all.
प्रियंका को बोलो लैपटॉप लेके आओ उसका प्रियंका.
Um, so there seems to be some technical glitch, so please hold on for a minute.
Zoom meeting में.
Basically,
Zoom meeting not responding.
accessories that we use, some of them are borrowed from ERCP. Some of them are new.
वो नहीं नहीं it just went off.
And as you all know that this
I'll log
is
on to it.
all based upon a simple technique where you have a hollow needle which allows the wire to pass. That is the basic technique. You need a needle through which you pass a wire, then remove the needle, and then you over the wire, you can dilate the tract, place a stent, or do other interventions. So it appears very, very simple. Most of the interventional endoscopy techniques are like that, where we first put in a wire, like for example, here, or dilatations and other things. So you use a needle, then pass a wire through the needle, and then over the wire, remove the needle, over the wire, to pass the exercise. There are some interventional EUS techniques which you don't need the wire. These are the injection techniques. Yes, Rahul, I can see you now. Please start.
Yeah, sorry about the little technical problem.
Go ahead.
Okay, so I hope I'm audible and visible.
Yes, yes.
Okay, so what I'm going to divide this program is into 4 parts. So we'll talk about, first of all, the needles, wires, accessories with the EUS exostome balloons, and about choosing a stent. So we'll divide in 2 parts. The first part is going to be needles and wires, and the second part is going to be about cystotome balloons and stents. So what do we really need in this needles is essentially we want the needle to be extremely sharp. So when you're doing a EUS guided intervention, you want the needle to puncture, say, transgastric or transdural. You want a sharp needle, which is smoothly puncturing the lumen into the lesion, and we can access it very well. So we have 3 needles here. One, which is the Boston Scientific Expect needle. We have the Olympus Easy Shot 3, and then we have the EcoTip from the Cook company. So it has to be sharp, it has to be precisely targeting the lesion, and really the needle has to be visible on the endoscopic ultrasound. Because we're targeting small bile ducts, small pancreatic ducts and lesions, if the needle tip is visible, then it really helps the endoscopist to achieve the precise targeting. So like the Expect needle, it's sharp, it's precise, it's got a cobalt chromium construction, and it's very good in our opinion in places like pancreatic ductal interventions. When you have a fibrotic, tough pancreas, this needle helps to target the dilated pancreatic duct very well. Then we have the Easy Shot 3, which is made by the Olympus. Sorry, 1 second. My screen is frozen, so bear with me. So Easy Shot 3 is made of a tough nitinol construction and a Mangini tip. And Easy Shot 3 is very good for deep-seated lesions like the uncinate process of the pancreas. It's very good for liver lesions. and it helps to target, and it's very flexible. So this needle is very good for interventions where you want to target deep into the extraluminal organs. My screen is frozen. I'm really sorry about this.
It's okay. It's okay. Go ahead. The third is the cook needle.
Yeah, third is a Cook needle. The Cook needle is also extremely good. So it's got a very nice dimpling at the tip of the needle, and that dimpling on the tip of the needle helps us to make it very visible on endoscopic ultrasound. So that's the most important part. It's a sharp, precise edge, cutting edge. It's smooth. It glides very easily past the lumen, and it's got a very nice visibility. So all these three needles have a very good uh, sharp needle edge, and they're very good at targeting different pathologies. For example, Cook is very good for biliary intervention. The Olympus is very good for deep lesions, and the Boston Scientific Expect is very good for pancreatic lesions. Then I'll come to the next slide. So we've skipped all this. Then we have the three wires. So the first wire that we use in initial intervention is either a Terumo glide wire 0.032, or we do use a VisiGlide 0.025. So the Terumo is a very beautiful wire. It's a single construction. It's a single piece construction. It's got a hydrophilic coating, which helps us to lubricate, less friction, and easily slide across into the strictures. It's got a polyurethane and tungsten jacket, which makes it very good for torque control and manipulation. And it's got a super elastic nickel titanium tip. And that makes it very good for tight strictures, very good for selective biliary cannulation. So there are three types. One is a straight tip, angle tip, and a J tip. We often tend to use the J tip wire, which prevents vascular intimal damage and is extremely easy to glide across tight strictures. So the beauty about the Terumo is high lubrication, less friction, smooth navigation. The tungsten jacket helps us to torque control it. It's very less traumatic to the vascular intima of the bile duct, and it's got an excellent memory tip and durability. The tapered tip single piece construction helps us to really have one-to-one talking between the technician and the tip. You have a beautiful control of this wire. Then we have the VisiGlide 0.025. This wire too has got a beautiful combination of core, which is made of a special material, and that gives a beautiful talkability to the VisiGlide 2. The tip is smooth, it is hydrophilic, it helps to navigate very tight strictures like the ones with autoimmune cholangiopathies, patients with benign strictures, and really tight malignant strictures. It really glides it. And this wire is really visible very well on endoscopic ultrasound and fluoroscopy. It's got a beautiful coating. And this really helps to prevent trauma in the tissues and negotiate complex strictures. So the third wire that we use often when we cannulate the strictures, we use the VisiGlide 2 or the Terumo. And when we want to exchange from a soft wire to a stiff one, we often change to a Dream Wire 0.035 made by Boston. This has got a 10 centimeter hydrophilic tip, which has got a very smooth, soft axis. It helps us to form the alpha loop in the targeted lesions. It's got an endoglide coating, which makes a very smooth movement of the wire and helps us to, again, torque the wire in the intrahepatic ducts or wherever we are. It's kink resistance, and it's got a special nitinol thick shaft, which really helps in manipulation of the wires. Then we have the track dilators, the cystotomes, which is 6 French and 10 French. We often tend to use 6 French because the moment you have a bigger dilator, it tends to cause bile leaks and it tends to cause more tissue trauma. So we tend to prefer a 6 French cystotome over the VisiGlide or the Terumo. And then we do use sometimes 6 millimeter biliary balloons to dilate these systems. The importance is that in the past we use sphincterotomy knives to make a cut in the lumen, but that was not a coaxial system, which caused more bleeding and perforation and problems. So now we have a coaxial system. So these cystotomes are coaxial, they go along the wire and do not cause any trauma to the gut, and they're much, much safer in these circumstances. So like I said before, the combination of a right needle in the right track. So pancreatic interventions with the Boston needles, the Olympus are very good for deep lesions, and so is the Cook needle, very good for biliary interventions. What is important to know is that when you put the wire in the needle, is that sometimes you get shearing along the wire. So if you're putting the terumo wire along a needle and you have jerky movements or to and fro movements along the needle, then the wire can get sheared and then you lose the wire. You have to take the wire out and a small piece of wire can be left in the intrahepatic duct. So it's very important that when you're manipulating these terumos or vesiglides through the needle, that you have gentle movements, you have slow movements and not jerky movements. And this really helps us to selectively cannulate the desired intervention. So I'm going to move on to practical demonstrations, and then we'll come back to stents in a minute.
Thanks, Rahul. Thank you.
Thank you.
So you heard about the basics, the needles, the wires, and the track dilator. These three things are very, very essential for you to start your interventional EUS procedure. And you should have all kinds of needles. Some needles are good in some areas, some needles are good in some areas. So, as Rahul told you, if it is a, for example, if the segment 3 duct that I want to puncture is very far away from my scope, then I sometimes use the easy shot because it works very well for deep-seated lesions. On the other hand, pancreatic duct, if this is a case of chronic pancreatitis and I want to puncture the duct, the pancreas is fibrosed and hard, so you need a really sharp needle. So I prefer the Boston Scientific needle. The Cook needle, as he said, is our go-to needle for most of the biliary interventions. So have all the needles with you because you will find sometimes one needle works better than the other. We always use a Terimo for our interventions, but VisiGlide works equally well. It's a great wire. It's a fantastic wire, and you don't need wire exchange because it is a stiff wire. For Terimo, it's very good to find a path, but when you want to push a stent, it doesn't have the enough strength. So VisiGlide has the strength. So if you want a single wire which works both ways to find the path as well as to place a stent, you use the VisiGlide. Yeah, Rahul, please go ahead.
Yeah, thank you very much. So the first, can you see my needle?
Yes.
Could you focus a bit on my needle if you can? Okay, so this is the Boston Scientific Expect needle. It's very important as a beginner that you have to know exactly what the needle components are. So this is the shaft of the needle, which has got two things, which has got a control for the sheath and control for the needle.
Focus,
So
focus, focus. I don't want to see Bibin now. Please show only Rahul. Focus. More, 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 more. Yes, more, more. Yeah.
So the first control that you have is this sheath control. So we'll show it to you in a minute. We'll put the needle into a scope, and this particular control at the bottom helps us to get the sheath out of the scope channel to target the lesion. So this is the most important, and that can be fixed very easily by the endoscopist. The second thing is the needle control, which is very important. As a beginner, if you are not confident, you can fix your needle movement according to the size of the lesion and extend the lesion from the lumen into the lesion. So the needle which comes out from the scope, as you can see at the tip here, it all depends on this control here. And the movement that you do is with your right hand, with your thumb and the index finger up and down. And that controls how much needle comes out from this sheath of the needle into the lesion. So as a beginner, you could lock this particular thing to see how much you want to come out. But if you're an experienced endoscopist, you can quite easily judge how much the needle comes out. Then we have
You use your thumb, index finger, and middle finger. So what I do is I use my middle finger on at about 4 centimeters. I keep my middle finger. If you can show Rahul. So
Yeah,
that
so that's what I am. 4 centimeters, if you can see on the sheet, that's 4 centimeters.
you keep
My
middle finger there. The middle finger if you keep there, and with your thumb and index finger, you push the needle out. So the middle finger works as a lock. So you don't, the needle will not go beyond the 4 centimeters. So that lock may not be needed always if you use your fingers judiciously and use them as a lock. Please go ahead.
So the importance is when you have a biopsy, it's different. When you have a biopsy that you're doing, you want the stellate to be a little bit out. So when you are punching the lesion, you don't want tissue outside the lesion to come into your needle. When you punch the lesion, you can then push the stellate out, so it'll take the other tissue out, and then you can target the lesion in a fanning technique. But with EOS guided interventions, where we're talking about, you do not need to have this sheath. What we do is we attach it to a syringe, which is needs to be air free. So if you have air in the needle and then you puncture the lesion, then you'll have air in the bile duct or air in the lumen, which will make your EOS images very fuzzy. So it's very important that you prime the needle with water, saline, or something similar, and this should be airtight and with a Luer lock syringe. So this is the expect needle from Boston, which is got a soft sheath, as I said, very sharp edge, and helps to really target lesions like the pancreatic duct that we do. So then we have the easy shot, echo tip Cook is already was what given me. So next is the echo tip Cook needle, which has got exactly similar construction. So it's got the sheath control here, and it's got the needle control, which is exactly similar to all the three, Boston Scientific, Cook, and Olympus. It's got a soft sheath again, and it's very easy to target lesions in the same way. So we're going to put it into the scope and show you so you understand what I'm talking about.
So a 19 gauge needle is what we need for interventional EUS. Sometimes if the duct is not very dilated, you can use a 22 gauge needle, but for most of our interventions, we use a 19 gauge needle. So this is the Olympus needle, Rahul?
Yeah, this is the Olympus needle.
Yeah.
So the first thing when you put the needle into the channel is you need to lock the needle on the channel. You remove um, the suction channel and you put this needle and fix it in a clockwise movement. Once you have it fixed, you have this needle with your scope in the patient. My colleague Bipin will show you. So first is to adjust the sheath, which is the second knob at the bottom. You release it and let the sheath come out. So if you can see on my camera here.
Magnify.
Yeah. Yeah. Can you see my sheath coming out?
Yeah. We can see it.
So I'll make it a little bit easier for you to appreciate, but you can see the sheath coming out of the working channel. So once you have the sheath out, you adjust your sheath according to your preference, and then you can release and you tighten this lock so that sheath gets fixed. Then you unlock the top part, which is the needle control, and depending on how confident you are, you can either lock your needle according to the centimeters you want to go in, or you can hold it controlled with your right hand. So as Dr. Dhir said, approximately 4 centimeters. You have your thumb, this is thumb, index finger, and the three little fingers on the sheath. So as you can see, I'm puncturing the needle, and you can see the needle coming out according to your desired centimeters. So this is the movement that you can do to puncture the needle. Again, the sharpness of the needle, the smooth gliding of the needle, and the precision of targeting is very important in these cases. Okay, so I hope that was clear. And once you finish the intervention, you go back and lock the needle, and you can unlock in an anti-clockwise fashion, and the needle can come out.
Remember to bring the needle back to zero always. That is very important. Shanil Kadir is asking, is 19 gauge the go-to needle? Yes, for vast majority 19 gauge is the needle we should use. A very few small number of cases where the duct is not very dilated, use 22 gauge needle.
So now we're going to the Terumo wire. My colleague Bibin is going to show you. So as I said, the Terumo has got it's a single piece construction. It's got a super flexible nickel titanium tip. We tend to use a J tip wire, which is much more flexible to access tight strictures and complex strictures. So we have, could we focus on the model Terumo, please? Yeah, thank you. So here we have a model, classic model of the bile duct. And what we see here is that we have a model which shows a tight stricture in the right intrahepatic ducts, and the left duct seems to be open. So when you have a wire like a Terumo, it has to, the tip control is very important. So from the endoscope or the technician's hand to the tip, it's very important that you have two movements. You have forward, backward, but most important is your torquing movements by the endoscope is two fingers, the thumb and the index finger, that you can manipulate the wire into a desired duct. So here Bipin's putting the wire into the left duct.
Please show the
and
torque.
he's showing you.
Please show the torque properly.
Yeah, show torque.
Come back.
पीछे हटो, पीछे हटो.
Come back. Bring the wire back. Focus on hand. Your hand, please.
Yeah.
Focus.
So you can see Bipin's hand that.
It's all
Yeah,
green.
you can see Bipin's hand.
No. You keep it on the model. I can't see your hand. No. Please shift your thing on to the model. Green background. I can't see the wire. Bring it on the model, please.
On the model. इसके ऊपर डालो.
On the model. Bring your hand on. Yeah. Now I can see your hand and the wire. Now show the torquing movement with your thumb and the index finger. Torque it and show how it moves.
So most important is to make sure you have, it's a hydrophilic wire. So you need to make sure that you have a lot of water before you introduce a wire into the sphincterotome or your device. If there's no water, the wire is not going to move.
The torque is most important. Please concentrate on the torque. The tip, your thumb and your index finger moving and the tip of the wire moving along with that. Show that. That is very important. The torquing is extremely important if you are using a Terumo wire. So if you want to go to whichever radical, you have to torque so that the wire turns in the direction of that radical. So you withdraw a little more. Now go in, torque here, yeah, torque here, yes, torque here more, yeah, see? So that torque is extremely important. See that? By using appropriately the torque, and at what point to apply the torque is very important. So you have to understand the anatomy and apply torque at the right point so that the wire moves in the direction that it needs to go into. And with practice, you see, you can go into each of these radicals by utilizing torque. This you should practice. This model is very easy to make. You can make it with you. I think some companies also have these models. So practice torque. Practice torque. As Rahul said, water is very important. This is a hydrophilic wire. So if you do not wet it properly, it will not move properly. So you see this? So this is how you learn to rotate the wire into the duct. And this is very important in hilar blocks. So because you need a specific radical tight strictures, you have to understand where the stricture is, how far it is, and where to apply torque. The other way by which the VisiGlide works is to form a loop. So you can form a loop and push the loop through. That also can be done. So that's a simpler method. Use a loop. So tip of the wire forms a loop. That loop can then be pushed into across the stricture. There are some questions on this. Gaurav is asking a question. Have noticed difficulty burning the track for therapeutic interventions and hence resort to alternate wires. Yeah, I think it's a very valid concern, Gaurav. Some of the older lines were not very conducive to cautery and we had to change the wire. But now I think the new Visiglide, we do not have that problem of that is. And so I think the reason is because O25 is a thinner wire, so probably the contact is not so good. That is my feeling. But in the modern Visiglides, we haven't found that problem so much. Yeah, Rahul, what are you showing next?
So I'm going to, I mentioned about the Visiglide Dr. Dhir did. I'm not going to show it to you again. It's a
Yeah.
very nice visible wire. We're going to go on to cystotome. So the cystotome is a very important coaxial instrument. So as I said in my presentation that you want a coaxial cautery force which goes along the wire and does not cause trauma and bleeding during intervention. So we tend to use a 6 French cystotome. If you can focus, what we have is it's got a attachment to the cautery at the end of the tubing, and it's got a metal tip at the end, which helps us to form a tract between the stomach, for example, into the intrahepatic ducts. We should always flush any of the instruments that we do because all of these wires are hydrophilic, like the Visiglide or Terumo. So Bipin's just going to show you, we've introducing Visiglide 2 into the cystotome.
You
So
should
the Visiglide,
white
yeah.
background behind your hands. Bibin, your dress is blue, no? You can't see anything what you are doing.
So can
Right, right.
can you see over my shirt, which is a little light blue?
See better, but not great. Ah, now I can see the wire coming up.
Okay, so this is a Visiglide 2, which we put, which is the beauty of Visiglide that you can, it's very, very visible on the endoscopic ultrasound and fluoroscopy. It's got a soft hydrophilic tip and a stiffer shaft, which is about 40 centimeters in this thing length. And this really helps us to guide, as Dr. Dhir said, in a complex stricture, in high layers or in very tight strictures. So once we have the cystotome on the Visiglide, we attach it to a cautery device, which way you have Irby or similar. And once you get past the tip of the endoscope, then you use a auto cut or a pure cut coagulation or pure cut, sorry, to make a incision between the stomach and the desired location. So this is the system of 6 French. We don't tend to use 10 French because we find that there are higher chances of bleeding or bile leak in circumstances. So 6 French, if required, followed by a 6 millimeter biliary balloon dilator is what we use, which Bipin is going to show here. So
So
this is
basically, as Rahul said, a coaxial system. A coaxial system means the cautery, the cystotome goes in the axis of the wire. This is in contrast to pre-cut. We used to use pre-cut papillotomes when we started interventional EUS. And those of you who use pre-cut know that pre-cut papillotome is not a coaxial wire system because the needle goes in a direction different from the wire. And so it can cause perforations. So it is very important to use a coaxial cautery, which is aligned with the wire. It is not different, going in a different direction from the wire. So cystotome is the way to go. Yes, Rahul.
So then you have the 6 millimeter biliary balloon. It's got two advantages. We can inject contrast to the other port. So it helps us to outline where we are in certain circumstances, very important. And the balloon is a 6 millimeter controlled radial expansion balloon. So that can be injected either with contrast in the balloon or we can put saline depending on your preference. So you can see that once you put the water or contrast in the balloon, you can see it expand on my hand here. and that helps us to make a tract formation. For example, you have a difficult stricture or difficult place to go to. You want to have an easy access for your instruments, your stents to go over it. Then a biliary balloon is really helpful to dilate the tract, and then you can feed your stent over it.
So
Okay,
balloon
so
dilatation is not always required. You may require it if you are going through the stomach wall because stomach wall is thick. So from the stomach to the liver, we don't usually use it, but my Japanese friends use a balloon dilator to go from the stomach into the left system. Also, if you do not like cauterized dilatation. Some people don't like cauterized dilatation. They want non-cautery dilation. Then this balloon is very useful. We use it
uh,
always in PFC, pancreatic fluid collection, a 6 millimeter balloon, because then the stent passage becomes very, very easy. So if you use a 6 French cystotome, and then, for example, if you are placing a Nagi stent into a pancreatic fluid collection, sometimes there'll be a little resistance. So it is better to dilate with a 6 balloon after a 6 French cystotome, and then the stent passes very, very easily. So these dilators are essential. Yes, Rahul, go ahead.
yeah. So am I audible and visible again still? Okay. So as we mentioned before, um, we need US specific stents. In the past, until the 2000s, when we didn't have any stents specific to US, we had to borrow stents from ERCP. So the US specific stents have specific needs that we have. A, it does not necessarily traverse the stricture that we're passing. So we need to design them differently. Secondly, they tend to be a lumen opposing. They need to get two lumens or two normal lumens together. So then they need to have a lumen opposing force. They need to have different lengths depending on where we are inserting the stent. And they tend to have a covered, uncovered portion, again, to prevent complications. So I'm going to talk to you about what these US specific stents are and what their characteristics are. But in the past, we had a single, when we do a rendezvous procedure or we do an anti-gate procedure, we can quite easily use our traditional biliary stents, plastic, single pigtail, double pigtail, covered or uncovered metal. They are much cheaper and we have a lot of experience in using these stents. So they can be quite easily inserted by standard methods. There is a stent specifically made, plastic stent made for US gut interventions. It's called the IT stent, used for hepatogastrostomy and pancreatic ductal interventions. It's a 10 centimeter, 7 or 8 French stent. It's got a beautiful design where you have distal end has multiple apertures to drain the duct and two flanges at the distal end, which helps to secure and anchor the stent into the pancreatic duct or the intrahepatic ducts. At the proximal end, it's got a single pigtail, which prevents migration of the stent into the pancreatic duct or the intrahepatic ducts. And that too has a side hole, which helps to drain quite easily the bile or the pancreatic juice. So this is called the IT stent. It's made by Professor Choi in Japan, not easily available in India yet. So then we have three US specific designs. So there's lumen opposing stents, there are biflange metal stents, and the tubular stents. So tubular stents are specifically designed for hepatogastrostomy because you want a covered portion between the stomach and the liver capsule. The covered portion is either 70-30 or 60-40, depending on which stent you're buying. And the covered portion helps to prevent bile leak between the stomach and the liver capsule. Once you enter the liver capsule intrahepatic ducts, you want an uncovered portion to drain the bile, which is your intent. Then you have these lumen opposing stents, beautifully designed. They have either a dumbbell shape or an umbrella shape at the end. So they get two lumens together and they help to bring it together, and they have two characteristics. One, they have a radial force, which does not need to be too much. So if you have a high radial forces, they cause bleeding and necrosis of the lining of the stomach. Or if you have a stent which has got lumen opposing force, which is very high, it is helpful in gallbladder drainage and GJs. So different stents have different lumen opposing forces and different radial forces, and they help us to target different lesions. So as I said, you have the hot stents. It's got a ceramic tip at the end, like the Axios, which is a single step procedure. It's got a needle ceramic sheath at the end, which you can puncture the lesion like fluorocyst in one go and deploy the stent within a matter of minutes, which I'll explain live in a minute. So as I was saying, it's important that we have the right lumen opposing force in the right place to target the lesion. For example, Axios has got the highest lumen opposing force at 2.29 newtons compared to the Spaxis and Nagi, which is a much lower lumen opposing force. Hence, the Axios is suitable for GJ, gallbladder drainage, pancreatic fluid collections, but at the same time, Nagi may not be the perfect one to get lumen opposition in these places. They have a different delivery devices. 10.8 French is the catheter delivery device in Axios, and different things like Spax and Nagi have a 10 French delivery device. They come in different lengths. So Nagi comes in 2 and 3 centimeters with a flange of 16 millimeters, and the Axios comes in between 6 and 20 millimeters, 8 and 10 millimeters, sorry. So as I said about the two stents we available in India, the Geobor and the Hanaro stents, which we get in India, they are these US specific tubular stents for hepaticogastrostomy. And they have an uncovered and a covered portion, and they have an 8.5 French delivery device, which I'll show you again in a minute. So really, depending on what intervention, if you're doing an antegrade or a rendezvous, you can use the standard ARCP plastic or metal stents. But if you do go for US specific stents like the GJ, HGS, CDS, or in gallbladder drainages, it all depends on what's available to you, what is the cost. But if you go on a head-to-head comparison between the stents in the various indications, we don't have specific studies which tell us which stent to use when. So here in IDL Care, we tend to have a preference. So for pancreatic fluid collections, if it is pseudocyst, there's equal evidence using plastic and metal stents. The outcomes are exactly similar. So depending on where you are and the cost, plastic stents should suffice. If you have a walled-off necrosis, we personally tend to prefer metal stents, but a recent RCT showed that the plastic stents are non-inferior to metal stents. The advantage of using a metal stent in walled-off necrosis is that you can go ahead and do necrosectomy. You have access to the fluid collection. So it's very useful, in our opinion, to have a metal stent in these circumstances. Sometimes some studies have also said putting a plastic stent within the metal stent, and that tends to prevent the metal stent opposing the fluid collection wall and causing bleeding. So we do sometimes put a plastic stent within the metal stent to prevent complications like migration or bleeding. When it comes to biliary drainage, as I said to you, if it's a rendezvous procedure, you can use a traditional ERCP plastic or metal stents. But if you're doing a transluminal choledochoduostomy, depending on the size of the bile duct, if it's a large bile duct, you can use quite easily a LAMS or a covered metal. But if it's not a very dilated duct, then a covered metal is the best one to put. If you're doing HGS, HGS specific stents are preferred. The plastic stent, which I mentioned, IT stent, or the tubular Geobor or Hanaro stents are suitable because of the specific design. If it's antegrade, again, we can use a uncovered metal stent. When it comes to GJ and gallbladder drainage, I think the evidence is quite clear that you need to have a high lumen opposing force. You don't want the stents to migrate. You don't want stents to, and you want the stents to oppose the two lumens perfectly. So LAMS is a stent of choice in these circumstances. So I'm going to go back and show you these stents in a minute. So you'll understand how these are deployed.
So it is important that you have access to all types of stents. Of course, as Rahul said, you need to have those stents available. Some stents are available in some areas, some stents are not available in some areas. Yeah, Rahul, go ahead.
Okay, so this is the Geobor stent. Can we
Can you put
focus if it's
something
possible?
white behind the stent, Bivin? Put a gauze piece behind the stent. Put a gauze piece behind the stent. This is also okay. That is also okay.
Okay. So that's better if you can see this.
Yeah. Now magnify. Magnify, please. Zoom in, zoom in, zoom in. Focus. Focus. Okay, can't see it very well.
I think the blue. Okay, that's better.
Huh. Yeah,
Okay, I
yeah.
think you can see it now. Yeah. So what you can see, this is the geobor stent, which has got the covered portion. You can see the white uh, polyurethane covering that you have here, and this is the uncovered metal portion. So this one goes into the intrahepatic ducts, and you will make sure that the covered portion covers from the stomach to the liver capsule at least, so you prevent bile leak and complications. Then it's got a little flange at the end, which prevents distal migration of the stent. This is very important. So this is the geobor. It comes in either 70-30 or 60-40 covered, uncovered portions. So then you have the Nagi stent, which has got a lumen opposing force of 1.09 newtons and helps, is very useful in pancreatic fluid collections, and it's got a length, working length of 2 centimeters or 3 centimeters and a flange diameter of 20 to 26 millimeters. So really helps to anchor between the fluid collection and the stomach wall. And the good thing is you can access the fluid cavity with a standard gastroscope, and you can do a necrosectomy in these patients. It's got a thread at the end, which you can easily pull out when the job is done. Then you have the Spaxis stent. The Spaxis stent has got a higher lumen opposing force of 1.29 newtons, and it's got a umbrella thing. If you can see here at the edge, it's got a like an umbrella shape thing, and this really helps to prevent the stent migration and lumen opposition in these circumstances. It comes in a centimeter length and a flange of 26 millimeters. So again, you get standard Spaxis and you get the hot Spaxis. Hot Spaxis delivery device is quite similar to the Axios hot delivery system, which I'll show you in a minute. Then you have the Axios stent, which is the stent we've been using for gallbladder and GB drainages. It comes in 1 centimeter length with a dumbbell shape end, which really helps to get the lumens together. It's got a force of 2.2 newtons and really helps us to anchor the stent into place and does not prevent migration. So these are beautiful stents for GJ and GB drainage. So here we have an Axios device loaded. I'll just show the two. Okay. So again, you need to remove the cap of the scope. You insert the device as you normally do. And as you can see at the bottom, there's a black anchoring device. You put the needle in, you secure the Axios device. So the black thing anchors the thing onto your channel. So once you secure the Axios needle, it's a 4-step procedure, which I'll explain to you. So,
You have to fix the lower part, only the lower part that fixes onto the biopsy channel, and then you keep the markings in front of you. You have 2 locks and you have 4 steps, and then you have a cautery at the tip. So please explain the steps, Rahul.
yeah. So with the Axios device, as Dr. Dhir said, it's 4 steps and 2 locks. So the first lock was the yellow thing here, which you can see. I'll just turn the scope. Can you see the yellow lock? Sorry, bear with me.
Other way.
Other way,
Yeah.
yeah. So
The
the yellow
first
lock is
lock,
the first,
Rahul. That is
yeah,
the second lock. First
second
lock,
lock, yeah,
you can see on your white thing. That is the first lock.
over
So
here.
basically, it's the system is you have a cover, outside covering sheath, and then there is an inner stellate which also contains the cautery and which has the stent. So as you release the first lock, that unlocks the sheath, the outer sheath. So you see, Rahul has unlocked
Yeah.
it now. And then when he uses the handle, the black handle, and does step one, push the black part down, push the
So,
black part down.
so as you
Yeah,
can see, the
yeah.
needle
You
at
see
the
the
tip of
sheath
the scope
is
is coming
coming
out.
out along with the stem. Can you see that? The sheath is coming out. That's it. Then
Can you see that?
once you are in the cavity, you lock it back again. So the outer
We lock,
sheath, please lock it back again.
locked.
It is locked. Yeah.
So it's
Now
locked.
you have to move the uncover the stent. So you release the other lock.
So the yellow bit is what we remove next. So the
This
sheet is out into the cavity with the stent, as you can see, and the black marker helps us to guide how much the stent should come out. Then the next step is to unlock the other lock here, which you can see at the top, if you can focus there. So you
yeah.
unlock this particular lock. That will be a step 2. So with the lock unlocked, you need to open the stent, which, can you focus on the stent, please? Yeah, yeah, yeah. So Bipin is easier for Bipin to show. So I'm going to just focus on stent. Can you see the stent?
Yes, yes. Go ahead.
So, yeah,
You
so now we're
can
deploying the stent at the distal end of the lesion.
yes.
So can you see the stent opening? So
Yeah.
this can be seen beautifully on EUS and fluoroscopy that the distal stent is deployed. So once this distal stent is deployed, you want to check that the stent is in the right place. You pull the scope a little back, so it comes at the edge of the lumen, and this black marker will help us to guide. You should see this black marker on the endoscope by maybe say 2 millimeters. So you know that the stent is in perfect position. So pull the scope a little back, and on your endoscope, you can see this black marker if you wish. Or you can deploy the stent on pure endoscopy, a pure EUS and pure fluoroscopy. Then you need to unlock the sheath. Every time you have a lock, unlock, you must go back and do that. Then to deploy the proximal flange, Bipin is showing you, is that you pull this needle back, and you'll see that the stent deploys slowly. You can see, concentrate on the edge of,
This is a
yeah.
third step when we are pushing the stent back towards the wall of the stomach or the duodenum, as the case be. So this is the third step. Then the final step is the proximal flange withdrawal, where you have to release the other lock. Yeah, this
So
is
the
the final
last,
step.
yeah, the last lock which you unlock, and this will be a final step for deployment of the proximal flange. As you can see, Bipin is
The
pulling
stent
back
is
the
removing
gray
the.
bit into step 4, and you can see on the edge of the scope that the stent will be deployed.
So this is
So here
always
you can see,
in the scope, the last part, and then you push it out gently. You see this? Bibin is pushing it out gently so that the whole deployed stent comes out. See this? This is how it is deployed.
you can
I
see a
hope you
stent has
understand
been deployed.
steps. 1, 2, 3, 4. Very, very simple actually. And there'll be live procedures done by my friends today. They will again explain these processes to you. Is there anything else, Rahul?
No, I think we've done with the stent. Is there
Okay,
any
so
question?
there was one question. Um, some people insert a double pigtail plastic stent as well through the geobore stent. Yes, I know there are some people who place a double pigtail plastic stent through the geobore stent. That is primarily to prevent any leak. But we do not use a plastic stent through the geobore. We haven't encountered any leaks. So we only place a geobore alone. We do not put, because we have seen that sometimes that double pigtail stent can pull the geobore stent out. You have to remember that there is no tumor holding the stent. So it is freely mobile. So sometimes the pigtail in the stomach will force the stent out. So we do not put a plastic stent. KK Raval is asking, so the stent is opened inside the scope? Yes, it is a very good,
Yes.
whether you are doing a choledochoduodenostomy or hepaticogastrostomy or GJ, that you open the stent inside the scope, because that gives you control of the deployment of the flange. So if you open it and then push it out. So Gaurav Muktesh is asking how to deploy Axios in closed spaces such as narrower bile ducts while doing EUS CDS. So it's a good question. In the beginning, please don't do that. Use Axios only if CBD is massively dilated. So you have a 13, 14, 15 millimeter duct, then only use Axios, and that too use a small Axios, 8 millimeter Axios. If there is a narrower space, I personally prefer a fully covered metal stent and then place a plastic stent through it. I do not use Axios. For example, if the CBD length, CBD is only 10 millimeters or 11 millimeters. Some people use it. I feel for 11 millimeters, first of all, you don't need an Axios. A simple, fully covered stent would suffice. Nikhil is asking for HGS, what should be the cautery setting for cystotome? And do we follow up with balloon dilatation? So hepaticogastrostomy or choledochoduodenostomy, the cautery settings are same. They are the ERCP settings. Autocut 100 or 80. We do not change the setting depending on the procedure. Do we follow it up with the balloon dilatation? Again, it varies. I do not do balloon dilatation. But there are some people, as I said, some of my Japanese friends like to use a balloon after cautery. I do not use. For me, a 6 French dilation is enough to push the stent through. There is no need for any further dilatation. So I hope you enjoyed this beginning. We showed you what are the accessories that you need before you start the interventional EUS procedures. So thank you, Rahul. Thank you.
Thank you very much.
Great, fantastic. And I think we are in time for the next session. Priyanka?
Yes, sir. Thank you, Dr. Rahul, for the wonderful presentation. Thank you, sir. Thank you, Vipin. So now we are moving on to the next session. So there will be live cases from Medanta Hospital, Gurgaon, and Dr. Rajesh Puri, I would like to invite. He's director at Medanta, the Medicity, Gurgaon, and he is interventional US expert, we all know. So Professor Rajesh Puri, I would like to invite you for the next session. Thank you so much.
Am I audible?
Yes, Rajesh.
Yeah, good morning, Dr. Vinay and team.
Good morning, good morning, good morning.
And we have got 2 hours and we have planned to show the 5 to 6 cases depending upon the time.
Okay, good.
In Delhi today, there is a very heavy rain.
I know.
And many people are stuck up. So there might be some glitches because the consultant who is going to present the history is also in between. So that is not a problem. First case, we are presenting a 56-year-old female who presented with a massive upper GI bleed 8 days before. Her hemoglobin fallen from 11 to 4 with a postural hypotension. Outside in the nursing home, she has received 5 units of the blood along with the terlipressin injection, and the endoscopy was done outside, which shows grade 3 esophageal varices with the red color sign and a large fundal varix with the stigma of bleed. So patient was referred to us for further management. I did her upper GI endoscopy yesterday that shows grade 3 varices with the red color sign, large fundal varix with a stigma of bleed. So my plan is to do the EUS guided coil. We discussed with the patient regarding the BRTO versus EUS guided coil and glue, and she was keen for EUS guided coil and glue. So So our plan is to do the fundal varices obliteration, followed by doing the bending of the esophageal varices. So I've got my colleague, Dr. Suraj Bhagat, and he's the man who does all endoscopic ultrasound, because most of the time I am either out or doing some other things. So he's the man who is doing all endoscopic ultrasound, diagnostic and therapeutic. Bhagwan is the main assistant. I think you all know. Dr. Ramnik is our anesthesia. She is an excellent anesthesiologist and she is going to assist. And we have Ashwani, who is the second main technician. And there is a plethora of the nurses and the technicians are here. So what I have planned is to do the upper GI scopy to show you the varices and other things. The most important aspects come is even in the patient of active bleed. Am I audible, Dr. Vinay?
Yes, yes, we can hear you. Please go ahead, Rajesh.
Okay. So I'm going to demonstrate you the upper GI first.
Yeah.
And followed by I'm going to do the EUS. So you can see the large esophageal varices. So for any case of upper GI bleed, it is always better to assess the patient. Can you see the large varices?
Yes, yes.
So large esophageal varices with the cherry red spots.
Yeah.
And there is no recent stigma of bleed, and there was a bleed in the fundal varix shows evidence of the recent bleed. Because the question, question can come, how to decide that which should be done. Theoretically, you should always deal with the fundal varix. In this case, there is a stigma of bleed. So that's why I thought, can you see a large bunch of fundal GOV2?
Yes, yes, yes.
And you see here, this was the stigma of bleed. Can you observe this?
Yeah.
This is the stigma of bleed in this case. Here. No. So my plan is to do the coil and glue, and the rest of the stomach and the duodenum was examined. So I'm exchanging my scope with the linear echoendoscope. Now the most important thing while doing the EUS glue and coil examination is, before doing the procedure, you always discuss with the patient, because this patient might bleed from the esophageal varices while doing the procedure. There might be a failure of endotherapy. The risk of aspiration, your anesthesia colleague should be guided, and your technician should know the step by step. I always keep two 19G needle because of any reason, if the one needle get blocked, then I can immediately take the second needle. As you see, the large of the varix is large, so I use the different sizes of the coils, right from the 10 millimeter, 12 millimeter, 14, 16, 18, and 2 centimeter size coil, because the choice of coil will be depend upon the diameter of the varix. It should be 1.2 times larger than the diameter of the varix. This should be the choice of varix, the choice of the coil. I always use, because in India we have got a cyanoacrylate glue, and in the rest of the countries we got the N-octyl cyanoacrylate. So N-octyl has a longer polymerization, but we have a N-butyl, which is a 5 to 6 seconds of the polymerization time. So I always use lipid oil, and I'm going to show you under fluoroscopy how the glue moves. So I use in my practice, because risk of blockage of the needle is there. So I use 19G needle number 1. I remove the stellate and always prime the needle with either with the distilled water or 5% dextrose. Normal saline should not be used. That is very important, because it causes fast polymerization. So the needle should be primed in the beginning, number 1. You should focus the fundal varices in the position where your technician can work. I always use 1:1 dilution of the glue and the lipid oil, because we have got an N-butyl cyanoacrylate glue. I use different sizes of the coil. Patient is in the left lateral position and under propofol sedation. Now the most important thing is, as the EUS scope is bigger in size, it is very important while taking the scope in, it should be very slow and gentle. You should not damage you should not injure or you should not produce the damage to the esophageal varices and patient might have a torrential bleed. So the introduction of the scope will be very slow, and I inflate in the esophagus, so it should not produce any trauma to the esophageal varices. I'm going very slowly. This part is very important because once there was a injury to the esophageal varices and they bleeding during the time of procedure, I am in the stomach. Okay.
Yes.
Now the second aspect is how to focus the fundal varices. So what I'm going to do, I will instill around 100 ml of the water in the stomach, because it will give me the I will put around 100 ml of the water. That will help me for knowing the mucosal varices versus extra mucosal collaterals. Now I will focus on the endoscopic ultrasound view. Is the EUS image is visible there? Okay. So what I'm going to do is I'm withdrawing my scope. The marker is on this side. Now I'm rotating my scope, and can you see it here?
Yes.
Yeah. Can you give a little bit more water? Just wait. Yeah, put more water. I will be little extra careful in this case, as there is a large esophageal varices. So I should make sure that my scope should not come into the esophagus. Can you make the image bigger? Now, can you see the mucosal varices nicely?
Yeah. Multiple small ones, so far.
Yeah, but there are big varix. Can you see this? This is the large varix here. Is my cursor is there? Can you see this is the large varix?
Yeah.
And they are intercommunicating. If you notice, this part is intercommunicating, but there are septas. Okay?
Yeah.
And this is the large collaterals. Can you see the large collaterals? So I will tell Bhagwan to give me the little bit more water.
Yeah.
Now this is little bit tricky situation, Dr. Vinay. As you said, there are multiple small collaterals also. Yeah.
Yes.
So what will be my plan? My plan is to obliterate the bigger varix. If I focus, yes.
Yeah.
Can you see it?
Yeah.
So I will puncture, and I will, can you put the Doppler, please? Is that okay?
Yeah. This usually happens, Rajesh, when there have been prior sessions of esophageal.
Yeah. And if I measure the size of the varix, then it will be like this, roughly with the septation 12 millimeter. So I will use, and my plan is, Dr. Vinay, to use, because if you see the coil outside, tomorrow I have a lecture. So I'm going to plan the coil and try to give the one rotation in this, one rotation in this, and one rotation in this. I will show you while deploying the coil. So I need the 19G needle, which is already primed up. I need little bit more water, Bhagwan.
So Rajesh, there is a question for you from Dr. K.K. Rawal.
Yes.
How to decide whether only to use glue or glue plus coil?
Yeah, it's very good question, Dr. Rawal. How to decide? There is no guidelines, but the important thing is the fundamental of using the coil is it scaffold the glue. So risk of embolization of the glue will be very less. The concept of using the coil is minimize the amount of glue and avoid embolization of the glue. These are the two main reasons of using the coil. If the varix is single around 10 millimeter, this is my thought process, then I will try to use the glue. Otherwise, I always use the combination of glue and coil, because risk of polymerization of risk of embolization of the glue will be there. Are we below the diaphragm? Sure? Okay, give me the 19G needle. I always make sure, because there's the large, you see that grade 3 varices with the red color sign, so I avoid. And you see Bhagwan has already removed the stylet. Is my needle is visible?
Yes.
And the stylet is removed and he has flushed with the sterile water.
Okay.
Okay?
Yeah.
So I am going to load. I am using the Olympus needle. 19G Olympus needle we are using.
So Rajesh, give us some tips on how you position your scope, how you stabilize your scope in a proper position.
Yeah, so very important question, Dr. Vinay. Either I can focus, because these varices are on the greater curvature, either I can focus on the clockwise direction the way I am standing, or by rotating anti-clockwise in this.
Yes.
I prefer not to do anti-clockwise, because where my assistant is going to deal with the varices.
Correct.
Then he has to come here and his entire system has to shift. Anesthesia people are here, visualization is poor. So always you should be in the neutral position. Is that right? The way I am in the neutral, the way I am standing in the neutral position, that is in the clockwise. Patient is in the supine prone position, and on the greater curvature, that is on the extreme of the right, I am here. Is that right?
Yes.
So now the next step is puncturing the varix. Size, I will take 2 centimeter coil. 18 is okay, because this is. So I will take the stylet out. This is the stylet is out. And I am going to show you the step by step. So my plan is to puncture this part of the varix. Okay. My stylet is out. Okay.
Yes, you are in.
Then my assistant is going to suck the blood first. He is focusing here. So I ensure that my needle, can you see the blood?
Yes.
Can you see my syringe with the blood?
Yes.
Is visible?
Yeah, yeah, very well.
Yeah. Now he's going to flush it with the distilled water. Slowly he is going to flush. Can you see the flow of this? Now he's putting you see the coil is attached. He has used 18 millimeter size coil.
Yeah.
This is the hub. First he will introduce the coil with the stylet, and once he has pushed 8 to 10 centimeter, then he will remove the coil from the hub, and then he will he will again reintroduce the stylet. Fluoro, just see the fluoro also. Is the fluoro visible?
Not yet.
Just wait.
Now, now.
So you see the EUS view also?
Yes.
Both the views?
Yes.
Okay. So I will tell Bhagwan slowly he is injecting. Yeah, gradually. And you see in EUS as well as fluoro, both the view. Yeah, inject. Introduce
So,
in.
sound will come out, there will be a back pressure on your scope. How do you adjust for that?
Yeah, just keep your scope in the neutral position and firmly attach and firmly holding. So you see the coil has come. Are you observing in fluoro?
Not yet. Has it come?
Yeah, inject. Yeah, you see, just wait. You see the coil has come out?
Yes, yes.
Just wait. Yeah, mid. Yeah. Yes. You see the coil in?
Yes.
Yeah, more. Yeah. Okay. Yes. One more coil. I think is good. I think we can wait.
Give a big US picture, please.
Put the
Okay.
water. Put the water. Wait. Yeah. पहले suck करो. Suck it little bit. Yeah. Flush.
Now you are going to put glue.
Yeah. I will use the glue and coil both. I will use one more coil. What do you say?
I think this was a nice, probably everything will get blocked.
Yeah. I think also. I think we inject
Now
2
the
cc
people
of
are
glue.
going to do it.
Yeah. Glue and this is the glue and the lipid oil combined. And you hold the saline also in the hand. Yeah. Yeah. Now show the fluoro. Yeah. Inject. Yeah. Now he's injecting the inject. Can you see the fluoro, please?
Fluoro, please.
Go on.
Yes. Yes.
Can you see the slow? Yeah. Can you see now?
Very nice. Very nice.
Is visible?
Yes.
And he has flushed with this. That's all.
How much have you injected?
2 ml.
We are seeing a shunt. Huh?
Yeah. So actually, while injecting the distilled water has gone out. Now, can you put the fluoro Doppler, please? You see now?
Show the Doppler. Excellent. Very nice.
Okay. And can you see the fluoro also?
The fluoro, no.
Fluoro image. Can you see the fluoro image?
Beautiful. Beautiful.
Is that clear?
Yes. Yes. So there is a question for you, Rajesh.
Yeah.
Dr. Vaishali.
Yes.
How decide how many coils and glue quantity?
Yes, it's a very good question. Dr. Vaishali, the most important, I told few minutes before also, although there is no guidelines, but the size of the coil needs to be decided. It should be 1.2 times larger than the size of the varix, number one. Then you should see, like these varices generally has a septa. So please make sure that each block, there's no term like block, but each segment of the varices should block. So what I did is, like this, suppose this is, can my fingers are seen? Suppose this is a one blood column, this is a one blood column, and here is puncture. What I did is I puncture here, I release the part of the coil here, I pull back my needle here, I release here, then I will reintroduce, I put another coil and I pull back. That indicates that both the segments has been blocked by the EUS coil. And the reason of putting the glue is it is scaffold. Glue is not going to migrate. And the amount, you should just see that your entire segment of the varix has been completely solidified. So you have to just assess. There is no method by which you can assess. In this case, I am going to use one coil or two coil. It will be a clinical impression while doing the procedure.
So you keep multiple coils with you at one time.
I always keep the multiple coils of the multiple size.
And you preload the glue before.
I preload the glue. I generally load 1 ml glue with the 1 ml lipidoyl solution along with that. Always use distilled water or use the 5% dextrose. Don't use the normal saline.
Yeah.
Prime the needle with the flush with the distilled water. If you are using the coil less than 10 millimeter, then you can use 22G needle. If you are using the coil bigger than 10 millimeter, then it is better to use the 19G needle. And you see my needle has not got blocked.
No,
so needle has not blocked, I can use in the second case also.
So there is a question from Dr. Lee, Dr. Sun Liang Lee. Rajesh?
Yes.
May I know your choice of coil? Is it Nestor coil that you are
using?
Nestor
coil.
Okay.
Okay.
Good. Excellent.
Can we switch to the another case?
Fantastic demonstration, Rajesh.
ये चेंज करना होगा वहाँ? चेंज करना होगा? करो चेंज.
So you saw that this is this looks very easy as Rajesh did it. It is not. It is you need precise scope position. You need your assistant to be very good. You saw that the assistant exactly knew what he had to do, when he had to do, and there was absolutely no communication actually. Both of them knew, assistant and the endoscopist, what has to be done when. So a teamwork is essential. The decision making of how many coils to use, how much glue to use is fluid. It changes depending on what the situation is. And ultimately, normally we do not use X-ray for this. I think Rajesh used it only to show to us the flow of the glue. We normally use a Doppler just to see that the flow has stopped, and that is it. But for demonstration, he showed us, and he showed us a collateral also going, as you saw how the glue was flowing. So that is a very important message in that. Do not use too much glue because it can go anywhere. So use less amount of glue, and coils help us reducing the amount of glue that we have to place. So Rajesh, there is another question from Henry Liu to you.
Yes.
Can I ask, after glue injection, do we need to follow with water injection?
Yes, I generally inject because 1.5 ml of the lipid oil and the glue is inside 19G needle. So you please make sure not more than 2 ml. Don't over inject. Your intention is entire glue and the lipid oil should go to the varix. So only inject 2 cc of the distilled water or the saline.
So some of the people probably would like to know not the coil but the glue injection part. So what is your standard procedure for glue injection? Lots of people are from outside India. So what do you do for glue injection?
Yeah, so Dr. Vinay, as I said, in India, there is a N-butyl cyanoacrylate glue is available, and it has a polymerization time of 5 seconds. So it polymerizes very fast, and the EUS needle is long. So when you inject, there is a possibility it may got solidify inside the needle also. There is a possibility. Using the lipid oil is increasing the polymerization time. Then the people has a question, if you are increasing the polymerization time, the risk of embolization of the glue will be there. So the concept is you inject slowly, a drop by drop, not like a rapid flush as we are doing in upper GI endoscopy. If we have an octyl cyanoacrylate glue which has a polymerization time of 21 seconds, that can be injected without lipid oil. Second advantage of lipid oil is it is a radio opaque and it can be visible. That's why I use the fluoro, I can see it. But yes, over injection of the glue can causes the possibility of embolization, and in the literature it has shown that 47% of embolization with 0.5 to 1% life-threatening embolization may be there. So the glue should be used in a minimum quantity, should be used slowly. As you see, my glue was inside the varix, but as my technician was pushing the water, there is a possibility he might have pushed a little bit more fast, and the glue has migrated to the collaterals. It has not gone to the lungs, it has not gone to the spleen or so, but it is always better you should slowly inject, because your needle is not going to block because lipid oil is already there. But yes, I generally in my practice, if the varix is less than 2 centimeter, not more than 1 ml of the glue is required. The advantage of EUS, under your eye you are seeing the complete solidification. A food residue, you in endoscopy you only see the mucosal part of the varix. You don't know how big it is intramucosal. You don't know the glue which you have injected, does it solidify entire varix or not? But here you have seen that entire Doppler flow has gone.
Yes.
So these are the advantage. And if the varix is less than 1 centimeter, I generally don't use the coil because it increases the cost also. Each coil costs around 8 to 10,000 rupees. In that case, I always use the glue to make sure. And generally 1 centimeter varix, if it is there, it is a discretion. My all cases are not subjected to the EUS coil. Generally those patients who are either failed endoscopically, they are referred to me for this, or patient comes directly with a large bunch of varix. Like in this case, or I've got tomorrow I'm going to show the video, a 3 centimeter size varix. You are not very sure the amount of glue injected is sufficient or not. and there is a shunt. If the shunt is larger, your glue can keep on embolizing. I'm going to show you tomorrow a large duodenal varix, 6 cc of the glue was injected, no solidification, because the large shunt, there is a embolization of the glue. If you're putting a coil, because it is a titanium with the woven fibers, it produces a scaffold around the coil. So this is an advantage. A small amount of glue retain in the varix, risk of embolization is low. This is the point.
And one more question, Rajesh, very well explained. How much lipiodol do you mix with glue?
1:1.
Okay, great, fantastic. So what is the next case you're
So
showing?
Dr. Vinay, second case is a very tricky case little bit. Yes, people will have a lot of question. And yes, I do agree that this is to demonstrate in the conference, although we have got 8 cases lined up, we will not be able to show. But today I'm going to show the 19G flex needle, which was meant for the liver biopsy. He's a 32-year-old male having a endophytic growth in the stomach with a lot of slough material with the liver SOLs. The biopsy was tried twice. One was outside and one was at my place, and both the time shows necrotic material. We have taken from the everted edges. We make sure that the biopsy should come positive, but the biopsy is still negative. We have taken the liver biopsy, report is awaited, but from the primary site, now after the 2 biopsy failure, we have thought that we should take the core tissue to give the diagnosis to this patient. This patient might have a GIST, malignant GIST versus adenocarcinoma of the stomach. So endoscopy shows there is a large endophytic growth. So the purpose of this case is to show the 19G flex with the core tissue, how we will get the core tissue. Okay.
That's a very good indication for EUS guided biopsies. Often we see these cases where endoscopic biopsies are negative and they come to us for EUS guided biopsies. So it's a very
Dr. Vinay, I think, can you give me the water?
Yeah.
So you know that, can you see the liver lesion? I will show because of the short. Can you see the large liver lesion?
Not yet, not yet. Yeah.
This is a large liver lesion. So my purpose is to focus the endoscopic lesion which is there. Can you give the water, please? The purpose is to show the 19G flex and how the core tissue comes. The entire procedure is planned like this. So what I'm going to do is putting the water in the stomach. Can you give more water?
So you use water very frequently, Rajesh, huh?
Yeah, for the submucosal lesion as well as in the fundus, I use water in my day-to-day practice. So we can take from the liver also, but liver percutaneous was taken. The entire aim is to take from the, where is the growth in the endoscopy? Where is the growth in endoscopy? So I will try to focus in the stomach. Where is the growth?
Not yet seen.
Okay.
Go in, go in.
So now you see?
Yeah.
Can you see now?
Yeah.
So now most important part is Dr. Vinay, for the beginners, it is important to know from which layer it is originating. You should give Buscopan to the patient.
Can you increase the size so that we can see the layers?
Yes. Can you see now?
Excellent, excellent.
Can you see here now?
Yes.
This is a large growth.
Rajesh, if you could show the normal layers also first.
Yes.
Concentrate on the growth.
Can you give the Buscopan given?
Yeah, beautiful, beautiful.
We have given Buscopan. Okay. So we have just given Buscopan. Let the stomach fold to flatten a little bit. Now this is, these are the stomach fold. I think we can see it here. Can you see the stomach fold here?
Very well.
Okay.
Yeah.
I'm going in. So you see the large growth endoscopically also.
Yes.
This is the endoscopic growth which is visible.
Yeah. It's
And you see
something
the
like
slough material which has come. And this is the growth. And it has gone up to the serosa. Can you see it? Can we close the light ever? Can you see it has gone up to the serosa? I will put the Doppler. Can you give the 19G needle, flax needle?
Right. Could be a gist.
Yeah, it could be a malignant gist. Don't you think so?
Yeah. That's why.
So this is the, can you show the, hold this. So this is the 19G flex needle from the acquire from the Boston. Generally we use 22. I thought that for the conference I'm going to show the 19G and going to show the core tissue how it come.
Okay.
So the plan is to use the 19G needle and my lesion is focused. You see this is a nitinol needle.
So KK Raval is asking, are you intubating all patients? I don't think so, no?
No, Dr. Vinay, we always use propofol. Don't intubate the patient. If a large pseudocyst is there, then definitely we intubate.
Yeah.
So you see the visible? I take out my, this is important while taking FNA. I think that is also very important. So this is important. Can somebody focus here? My hand? Yes. So Dr. Vinay, once you focus the lesion, is my needle is visible?
Not yet.
Is visible now?
Yes.
Once it reaches to the hub, do a clockwise rotation like this. And please make sure that this is very tight. This is important, number one. This is for adjusting the sheath. You have to take out 1 to 1.5 centimeter, not more than that. That's number one. This is for the, can you focus above? Yeah. This is for the needle which comes out. You release it. And before that, you remove the stylet little bit out, a centimeter, to make the distal and sharpen. Now, few important points. Japanese, what they do, they measure the size of the lesion and then they focus 3 centimeter or 4 centimeter, which I do generally in the door knock technique. Because the purpose is you can take it out and you can do it to and fro movement. That is my day-to-day practice if I do a door knock technique. But yes, if I'm not doing the door knock technique and I'm using the EUS guided FNA, then my preference is to make it loose. Can you make my hand bigger? This is the way you should hold. Can you make it? Your palm should be on this shaft, holding the movable part with your thumb and the index finger like this and rotate like this. You understood? By that, you are not able to go more than 2 centimeters. You see, this is my restriction point. My middle finger will not allow me to go more than this.
Yes.
Is clear? Like this. So, first important point, focusing the lesion, bringing the lesion at 6 o'clock position. Once you are sure, put a Doppler. And once you know that there is no intervening vessel, make sure that your needle should be luer locked firmly. Take out the sheath outside. Sheath can be seen by 2 methods. I can see on EUS image here. If you focus, I will show you how the sheath will appear. So the 2 methods. This is my sheath out. Can you see my sheath out? Yes. Can you see my sheath out? Or you can see endoscopically also. You can see is the endoscopic image bigger? Yes, sir. Can you see the sheath out?
Yes.
Okay. But EUS view, I always in my day-to-day practice, I use EUS view rather than endoscopic view. Now I have taken the sheath out. I have locked this. I will release the needle safeguard button. I remove the stylet little bit. I will again focus it nicely. And I'm going to put the Doppler. I will tell my assistant to put the Doppler. Ashwani is my colleague who is assisting me from the last 20 years. We have got a relation from last 20 years of endoscopic ultrasound. You can see the Doppler. Now, what is my plan is, now, because this is a submucosal tumor, this is a stomach, which will move with your thrust of the needle. So the two important points. One is you have to jab it. Second, your assistant should hold the scope firmly at the mouth gag. So the scope should not get thrust and should not move the stomach wall. So I will again put the Doppler. Yes. Can you show my hand now? Can you show my hand bigger? Now look at, remove the Doppler. What I am going to do is, just look at here what I am going to, I will do a fast jab movement like this. You see here? Dr. Vinay, have you observed?
Can't see the US.
US image also, please show the US image. Doppler. And hand both. Doppler. Yes. Okay. Doppler remove. Can you see now needle?
Yes.
Just wait. Okay.
Yes.
Now I will reintroduce the stylet and I will use the technique of pull technique. 1, 2, 3, 4. Just wait. So I'm going to take the 10 passes in and out. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Okay. Now I'm going to show you what tissue has come. We have to focus this now. Focus here. You have to focus here. Can you enlarge the image? If the slides are visible. Focus on this. Dr. Suraj is visible. Yeah. Slowly. Yes. 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 You see the fantastic tissue. I will show you. Put. Now see the tissue which has come. The excellent tissue. Focus the slides. Can you see the tissue?
Yes.
You see the white tissue, enlarge it, clear. No, it's not clearly visible.
Focus. Yeah.
Now visible white tissue?
Yeah.
Needle. Is convinced?
Yeah, it's good tissue. I actually don't use 19 gauge needle because there is more trauma in my.
Yeah, but Dr. Vinay, can you see here the white tissue where my sheath is?
The other thing is, don't go into the same area again and again, because then more hemorrhage.
But you see the entire tissue is, I don't know, can you see it? It's very clearly visible, the entire core tissue with the white.
Right.
Is the whiteness visible or not?
It is visible.
So I will take one more pass. We put it in the formalin. I will show one more pass. Any question regarding the FNA, I am willing to answer.
Yeah, so there are lots of questions. Nikhil Santhalia is asking, if the needle bounces back in the stomach submucosal lesion, how to prevent that? Do you lock your controls? Rajesh?
Yeah, I will show you now. I will just show you, Dr. Vinay. I will show to Dr. Nikhil also. Dr. Nikhil, that is called as door knock technique. And I said, this is very important. You should firmly jab. Put the Doppler. Remove it. I will show you. Just see Doppler. Either you lock it here. Suppose if I measure the distance, and the distance from here to the main lesion comes here is 3 centimeter, 33 millimeter. Okay. So I will lock it up to the 3 millimeter, 3 centimeter, remove. And what I am going to do, I will use the avascular plane. Now I can use the door knock technique. Look at here. Can you see my needle?
Yes.
Is the needle visible?
Yes.
Okay. And what I'm going to do is, that is called as door knock technique. Yeah. Introduce in. Yes. Slowly. So what I'm going to do, this is called as door knock techniques. Can you hear the voice? Which is by the Japanese people. But I think if you are using between the two, there may not be any reason that you should not come. And I generally pass 8 to 10 passes in and out. This is the locking. If you focus here, my is blocked at 3 centimeter. This is done at 3 centimeter, and I'm doing like this. This is the door knock technique. Okay.
Yeah.
So I will again going to take the tissue, and I'm happy to answer, and then we can shift to the other case.
So, question from Dr. Hamid Raina. What is the role of EUS in staging of gastric cancer?
Yes, it's a very excellent question, Dr. Hamid. My feeling is in the era of contrast CT and MRI, I think these are the modality which is very good for the early gastric cancer where there is a doubt of involvement of the musculus propria. In that case, yes, you can do it, but in the day-to-day practice, I don't think you require, because for the getting the tissue from the metastatic side, it is useful. But purely for the staging, I think for the esophagus and for stomach, it is not mandatory. I think so.
Okay.
But what is your take-home message, Dr. Vinay, on this?
No, I agree with you completely.
Now you see the complete white tissue again.
Yeah.
So I think 19G flax, I'm not sure we are able to, is a complete line is of, there's a little bit of the blood, but entire string is whitish tissue. Can you show it below this background? Can you show it now? Zoom it. Zoom it more. Can you see the white core tissue?
Yes.
This is the entire white core tissue. This is the entire white core. This is the 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 white core. Here is the blood. But this is the entire white core tissue. Okay? Histopath. I think that's sufficient. So any question regarding that, or should we shift to the another case?
Rajesh, some differences between us, both of us. What I do is never use a 19 gauge.
Yeah, Dr. Vinay?
I said I never use a 19 gauge.
So, doctor, I also don't use 19G needle, frankly speaking, truthfully.
Yes.
I would have used 22G needle because the flex needle has not shown in the conference, and which is meant for the liver biopsy to get the core tissue. And this is a twice negative, but in my day-to-day life, because it's a costly needle, I always use 22G needle in all my cases except wound drainage, treating the fundal varices, or doing the biliary drainage. I use the 19G needle. In my day-to-day practice, none of the case I use now with the availability of Acquire or the Procore needle. I always use 22G needle that give the fantastic core tissue. I don't use it.
The second difference is I never go into the same position twice.
But I have not gone. I have done the fanning technique.
If you do 10 punctures, this is just for discussion. 10 means you will go into the same area 2 or 3 times because the lesion is not so big. So take it out to the edge of the lesion, use your up down, go in a different direction, 4 or 5 What happens is you have got excellent tissue, no doubt, but the blood becomes less. The blood that is seen becomes less. The thing is less hemorrhagic.
And always avoid suction. Don't use suction.
Never use them.
Never use suction.
It's so fantastic demonstration. Great tissue you have got. There are some more questions for you before you
Yes.
go to yes. Once the needle, this is Sorachat, Dr. Sorachat. Once the needle was introduced in the lesion, do you always reintroduce the stillet fully back into the original position before?
Yeah, it's a very good question, Doctor. The concept of reintroducing the needle was the tissue of the stomach tissue or the gut wall tissue which has gone inside the needle, you are declogging it. And that is the concept of reintroducing the needle. That's number one. But now the studies are available, you use the stylet or not, there's no difference. So I think even if you don't use reintroduce, it is not going, it is a practice which you have learned over a period of time. 20 years back when I learned EUS, the Peter Willman was doing like this and I learned, and this is in a practice.
Yes.
Otherwise, yes, you don't require it.
Yeah. And there is another question from Dr. Vivek Tang. What steps to follow before taking the needle out of the scope? So basically, once you have finished the FNA, what precautions you should take before taking the needle out so that it doesn't damage the scope and all?
So it should be while taking the needle in out means taking the sheath out, or while withdrawing the needle, or while introducing the needle. These are two different questions. And it's a very good question he has raised. Let me answer both the things.
Okay.
Many of the time, especially when you use 25G needle and your lock is locked, the needle gets bent inside. And you feel that you have taken out the sheath 2 centimeter out or 1.5 centimeter out, and sheath is not out and the needle has got bent. In that scenario, very high risk of chances of puncturing of the scope is there. So please make sure that when sheath is out, it should be visible endoscopically or it should be visible EUS wise. You should not see the mark, I have taken out 2 centimeter. No. You may take out 1.5 centimeter, but it should be visible either on EUS image or it should be visible on endoscopic image. That is mandatory. Otherwise, needle sometimes get bent and you feel that I have done 2 centimeter, I have locked it, and then you puncture it and you damage the scope. That's number one. Number second, it should not be too much out, because if it is too much out, there is a possibility needle can go, when you elevate a little bit, the needle can pierce the sheath of the needle. Pierce the sheath of the needle because your sheath is too much out, suppose. The needle will puncture it and you may damage the sheath and you may damage the scope. So the sheath should not be more than 0.5 to 1 centimeter out. That's the second thing. Now, while withdrawing the rather than sheath, you should make sure that your needle should have come out and it has reached up to the 0 point. That means the complete needle has come out inside the sheath. That is most important thing. Second important thing, while doing sometime rapidly, because a lot of secretions come. So always try to remove gently, or tell your assistant to keep a gauze piece at the point of the biopsy channel. So the secretion should not come and it should not spoil your face. It should not spoil your assistant face. So damaging the scope, make sure that the needle is completely at 0. It has come out inside the sheath. Your lock should be up, and then you remove it gradually, and the content should not spill over the assistant or so. This is my thing. Anything Dr. Vinay wants to add, I will be happy.
No, I think that is perfect, absolutely perfect. So always remember to bring the needle back to 0. Sometimes in our hurry to remove the needle, we don't bring it to 0. So bring it to 0 so that the needle is completely back inside. Lock it and bring it out.
Supine rakhna hai usko.
Perfect. So
Supine.
ready for the next case, Rajesh?
So should we go to the third case?
Yes, please.
So and we are doing the this will yahi chalega ma?
So this
ये इस रूम में चलेगा?
fantastic demonstration. See, most common interventional EUS procedure that you will start with is EUS guided biopsy. And practicing with 19 gauge is important. Although now I don't do it, but you have to know how the 19 gauge needle works. So in some cases, please use 19 gauge for biopsy, because before you start your interventional EUS procedures, you have to understand that the 19 gauge needle is different from 22 gauge needle. It is stiffer, it doesn't elevate so much, the angles are different. So to understand all those, do a few EUS guided biopsies with 19 gauge needle so that you get a hang of the 19 gauge needle. There are multiple methods. Rajesh beautifully described two different methods. So now let's go to the next case.
Dr. Vinay,
Yeah.
am I audible?
Yes, yes.
So the next case is 38-year-old female who presented with the obstructive jaundice with a bilirubin of 11 from the last 4 months. Now she has fever with a leukocytosis of 17,000. She underwent ultrasound and CT examination which shows there's a mass in the ampulla with the gross dilatation of the CBD and IHBRD. The mass is reaching up to the SMV. So now the purpose of doing the EUS guided drainage is this patient has a partial gastric outlet obstruction. The twice ERCP was failed. While putting the scope, you will see a lot of blood in the duodenum because of periampullary growth. And patient has cholangitis. Our plan is to decompress it and followed by she might require neoadjuvant chemotherapy. And if she is resectable, then she will go for a surgical intervention. She came to us today morning. Now, in this, I'm going to demonstrate which routes you are planning to do it. Because ERCP failed, you have got 3 routes. Either you do it from the liver, antegrade biliary stenting, or you do the hepaticogastrostomy, or you do the antegrade Rendovo, or you do the choledochodynostomy. So these are the methods which I'm going to demonstrate. What are the position of your scope? What should be? So first, my patient is again under propofol sedation in the left lateral position. Then I will make her to the supine position rather than prone. Okay, and fluoroscopy needs to be shown nicely. Okay, so I'm just going to demonstrate you. I will go to the G junction. My scope is facing anteriorly. Can we make it image bigger? Image bigger? Yes, that's. So this is the liver. Can you see it, liver?
Nice, nice dilated radicals.
And you see the dilated radicals?
Yes.
Okay. So can you show the fluoro, please? Can we make the patient supine? Please make the patient supine. Darshanji has not come yet. Can we make the patient supine? Yeah, just make it like this. Yes. One person should be here to make suction should be proper. Who is going to show the fluoro? You? Sister, इसको ठीक करो. So, is my fluoro? Can you show the fluoro, please?
Yes.
So, Dr. Vinay, what do you think? Which segment this is?
Beautiful. Both 2 and 3 are seen very nicely.
So, if I want to show the antigrade,
yeah,
I think this is the better position. Segment 2 is visible.
Yeah.
Is that right?
Yes.
And if I want to do the segment 3, I will push my scope a little bit in. Beautiful. And I will load. Can you show the fluoro, please? This is the segment 3. Is that right?
Yeah, beautiful. Beautiful.
This is the segment 3.
Yes.
Okay?
Yeah.
So, can you show the fluoro, please? This is the segment 3. Is that right?
Yes.
So, first and most important, under fluoroscope, patient should be in the supine position. That is the best way. Second is, you should look your scope position in the fluoroscopy. This is a segment 3, and if I pull my little bit scope where I can start seeing the diaphragm. Do you see my diaphragm is visible in EUS image?
Yes.
And this is the segment 2. Is that right, Dr. Vinay?
Absolutely. Beautiful.
So this is the best way for the segment 2 puncture and antegrade stenting. Yes. And segment 3 is for doing the hepaticogastrostomy. Is that right?
Yes.
Now I will go to the duodenum. Endoscopic view larger. So I will go to the first part of the duodenum. Can you see the blood coming out from the ampulla? Okay.
There are clots.
Yeah. So this is the, can you show the fluoro please? Yeah, this is the view and EUS image. EUS image. Now I will focus my bile duct. Is okay? This is the pancreas. This is, can you see the bile duct dilated?
Beautiful, beautiful.
Beautiful. And can you show the fluoro now? Now you see, my scope is directing towards the hilum.
Yes.
Is the fluoro visible?
Yeah.
Is the fluoro visible?
Yes.
Is this okay?
Yeah.
So this is the way you should do the choledochoduodenoscopy.
Yes. Wonderful. Wonderful.
What is your feeling, Dr. Vinay? Let us first show the EUS wise, the pancreatic anatomy, where is the mass? Is that right?
Yeah.
First we will show. So just I will keep my scope clockwise and I will try to shorten my scope. So I have reduced, this is the right kidney, can you see it?
Yes.
Can you see the dilated bile duct? Can you see the mass, periampullary mass now?
Not yet.
Now see. Yeah, here is the mass. Here the bile duct is blocked. Can you see the homogeneous mass here? Can you notice this?
Yeah.
Is this visible?
Yes.
Can you give, is that right?
Yes.
And this is the bile duct which is dilated. You see the bile duct is blocked by the mass?
Yeah.
Okay. So what do you feel, Dr. Vinay? What should be the plan? Should we do the choledochoduodenoscopy or should we try antegrade?
Is it a low cystic duct, Rajesh?
Yeah.
Low
Cystic duct is low inserted.
you can see the duct also.
So what is your point? What should we do?
So normally what we follow is if papilla can be approached, rendezvous.
Papilla is not approached. You have seen. Should I show it again?
No, it's okay. Papilla is not approachable.
No, not non-approachable.
Either CDS or HGS or antigrade is not good. If there is an ampullary tumor, antigrade is also out. So you decide CDS or HGS, whichever you want to, you feel is okay.
So I think should we do the choledochoduodenoscopy or
Sure.
should we do the HGS?
Both are good. Both are equally good.
So let's do the choledochoduodenoscopy, okay? Because this patient might go for the Whipple surgery after the neoadjuvant chemotherapy.
Right.
So HGS will not be the good alternative. Is that correct?
Yeah.
The patient has to go for the Whipples after the radio chemotherapy, then is not a good candidate. So what I'm going to do the can you show the EUS view? Is that right, Dr. Vinay? Is that okay?
Beautiful. Very nice.
And can you show me the Doppler?
So it's very important to first look at the bile duct and where the cystic duct is originating, because sometimes you may by mistake enter the cystic duct if the two are very close together. So separate the cystic duct and then go only into the bile duct. So he showed us, Rajesh showed us the cystic duct origin. So he is puncturing, I think it's a low cystic duct, so we can safely puncture.
Fully covered, 6 centimeters. So Dr. Vinay, site of puncture is okay. Is the EUS image visible?
Can we see the fluoro also once again to see your scope position?
Yeah.
Beautiful, beautiful, very nice.
Is
So
that correct?
the scope position is very nice, beautifully positioned.
Okay.
Yes.
There is a small blood vessel.
Oh, ठीक है. Doppler बंद कर दो.
Okay. My direction of puncture is good.
Very nice, very nice.
Okay. Just hold this scope. Hold this scope. So
You see, Rajesh, he comes from the left side. All of you.
can you show the fluoro, please? So Dr. Vinay, I'm puncturing and I'm inside.
Very nice, very nice.
He's going to, first I'm going to tell him to suck little bit of the bile.
Yes.
Just make it suck bile because I want to decompress the bile duct. I don't want to induce a cholangitis.
Yes.
Can you separate? Can you remove this out?
Uh,
We are just sucking the bile because the CBD is hugely dilated. I'm going to, there's no relevance of it, but I only feeling is if you increase the intraductal pressure, the risk of cholangitis is high.
Yes. You're
So
using
you see the white bile? Can you see the white bile? Can you focus this?
yeah.
Syringe is visible.
Yes.
So Bhagwan has already sucked 10 cc of the this. We will withdraw 10 more. We can take for culture sensitivity because she is running fever, although bile appears to be clear.
So it's a 19 gauge needle, Rajesh. Which
Yeah,
one?
this is I always use 19G needle.
Okay.
Any disparity in that?
No, perfect.
20. So we have withdrawn 20 cc just to, because my gut, now we are injecting the contrast. Fluoro. Patient should be nicely sedated. Okay.
Yes, you are just below the hilum.
Quite below the hilum. By hilum is quite higher up, na? Hilum is very high up. Is that right?
दोनों बड़ा करके दिखाओ ना अच्छा.
Can you show the fluoro, please?
Right.
Okay, you see the cystic duct which is going?
Yes.
Yeah. Now we are using the Visiglide. Visiglide 0.025, Visiglide 2. The 2 has advantage, it has an angle tip with a strength of 0.035 wire. Now this is very important because I'm not using the needle which has it has a sharp end 19G needle.
Right.
Fluoro, I will tell my Bhagwan to very gradually he should introduce. Where he has gone. Yeah, you are right, I suppose. Yeah, he might be in the cystic duct.
Fluoro बड़ा करो ना. Show the fluoro big, please. Yeah. Yes. I think that's the right. Yes. Beautiful.
Okay.
Very nice.
So we are deep and now I'm going to withdraw it. And
so, nowadays we don't inject contrast. I'm doing it without contrast.
Yeah, Dr. Vinay, if you see my wire was going to the cystic duct.
Yeah, but I think contrast nowadays, like in hilar blocks, we don't, even in choledochoduodenoscopy,
Fluoro.
ultrasound and X-ray.
Fluoro, please. Okay.
Excellent.
Now, my plan is to dilate with the 6 French cystotome. And the stent should be open 6 centimeter fully covered. I am thankful to Bona people because she's a poor patient and he has given free of cost this stent. So I'm really thankful to the Bona Paras, the company guy who has obliged because the patient was poor and she has come. She was in cholangitis. ERCP was failed twice. So, and stent should be loaded, primed. So now the track will be dilated with the 6 French cystotome and I'm using the cutting current. Is now, can you see my cystotome has come on the surface? Can you see on the EUS image? Is that right?
Yeah, we can see.
Now I will use the cutting current. Okay, I'm gone in. Is the fluoroscopic image visible? Is the fluoroscopy image visible? Yes. Fluoroscopy, can we make it bigger a little bit? Is the fluoroscopy image visible? Yes. Is that okay, Dr. Vinay? Dr. Vinay? Is Dr. Vinay audible? Dr. Vinay?
Sir, वो log out हो गए sir.
Huh?
Log out हो गए Dr. Vinay.
Okay, so we can wait for 1 or 2 minutes.
Okay.
Just talk to them, Dr. Suraj, call them.
Cystotome is nicely visible.
Pardon?
Cystotome is nicely visible.
Okay, you are from the IDL Care, you are from IDL Care?
No, Rajesh.
Okay, so should I continue with the procedure?
I think so.
Okay, so I am withdrawing the cystotome.
Rajesh, I'm there. Just
Okay.
wait, not break.
So I dilated with the cystotome.
I saw that, yes.
And the important point which I want to tell you, beginner, don't dilate with the hurricane balloon at this stage. People has a tendency, because the bile will spillage and it will go to the, can you see the small amount of bile spillage to the peritoneal cavity?
Yes.
So it is always better. Can you see the small amount of blood particle going to the bile duct? Can you suck? Please suck it. Please suction, sister. Now I am using the fully covered 6 centimeter stent. And our hilum is quite high. Is that right?
Yes. Good space you have.
Sister, please do proper suction. Can you set it? It's going to take 3-4 minutes more. Keep the traction on the wire. So 6 centimeter fully covered stent I'm using. Fluoro. Is this okay? Okay?
Yes. So what you have to see is Rajesh is keeping the scope in a wonderful position. I think that is the most important lesson that you have to learn. His position is stable. It doesn't change, because if it changes by 1 centimeter also, no, his accessories will not pass. There will be a problem. And how does he know he is in a good position? He has ensured that you see the wire at all times on ultrasound.
And your scope should be very stable position.
Yeah, and see the wire is always seen beautifully in his ultrasound image. That means his position is stable. If you lose that view, that means your position has changed. So keep the scope very, very stable and wonderfully demonstrated.
Now I'm going to deploy the stent. So Bhagwan is going to release the proximal flange.
X-ray बड़ा कर दो.
Darshan, can you just give the good? दाई से हटाओगे?
Nicely positioned stent.
Okay. Now do it. Just wait. Yeah.
No, ultrasound हटा दो यार, X-ray दिखाओ.
Just wait. Fluoro दिखाओ.
Yeah.
Fluoro is visible. Now I will endoscopic view. Can you make it bigger? Okay. Yes. Release.
So you see, last part is releasing in control in the scope. Very important. You have to see that the last part of the stent is in the scope when his final release is going. It's good. It's very good. Go ahead.
Yeah. कर दिया.
Very nice.
Okay, so I have done it. Now I am pushing the stent out.
Yes.
Okay,
Yeah, beautiful. Lovely drainage.
is that okay?
Yes, yes, very nice. Are you going to place a plastic stent in it or you leave it like that?
I will leave it like that. What is the opinion of house? I don't think we require to put the plastic stent.
Let us see the fluoro once again.
Can you show the fluoro, please? Can you make it bigger?
Yeah, very nice drainage.
Now, can you see it?
Yes.
Do you think there is need to put the plastic stent?
Not really. You can leave it. It's nicely open, beautiful. It'll drain well.
Huh?
Yeah, it'll drain well.
If you want, I can put the 7 French.
Now, see now how nicely draining it is. Beautiful.
Yeah, we'll just show the fluoro.
Yeah.
We'll just show you the fluoro. Now show the fluoro. Just see that stent has impinged. Why? Is that okay? Show the fluoro, please. Show the fluoro.
Yes, we can see the fluoro.
I think my stent was stuck. Now is okay. Now show the image, please. Dasani, can you just change the direction so gallbladder should be visible nicely? No, opposite direction. Can you see the stent now?
Yes.
Is absolutely clear below the hilum.
Beautiful, beautiful.
Okay.
Yes.
Any questions? I will be welcome to answer. Sister Gaston.
Lots of questions. How did you decide hepaticogastrostomy or choledochoduodenostomy? Dr. Vaishali is asking.
Yeah, very good question, Dr. Vaishali. As this case was partially operable, I thought that if I do the hepaticogastrostomy, this will not be a good option. So I thought, let's do the choledochoduodenostomy and the patient will be operable at that time. That's number one. Number second, of doing the hepaticogastrostomy versus choledochoduodenostomy, it will depend upon the infiltration of the D1. If the D1 is infiltrated and I cannot show a good segment of the common bile duct in the long length, in that case, I will do the hepaticogastrostomy. Number third, if patient has a complete gastric outlet obstruction, in that case, I will do the hepaticogastrostomy and try to do the gastric outlet obstruction separately tackle rather than putting both the stent together. Because in that case, there is a possibility that you might block the one stent or there is a regurgitation of the food. So these are the methods which decide me, and it will depend upon the how comfortable while focusing the stent. Either you are comfortable in the long loop in the D1 or your ducts are dilated. If your ducts are dilated from the hepatic side, you can do it. So dilatation of the duct intrahepatic radical is going to decide. The D1 infiltration is going to decide. Patient is going for the Whipples or not, that is going to decide. And your own expertise, which is going to decide. Anything else, Dr. Vinay, you want to add, you can tell.
No, that is perfect. I think that is a perfect answer. So both procedures are good. Studies have shown that both are equivalent, but there are individual cases where you have to decide.
उधर करना है, चलें? हाँ.
Is another question from Dr. Raval. What is the minimum biliary diameter for hepaticogastrostomy? Nowadays, with expertise, you can do it with very few, hardly 2 millimeters also. But normally, when you are beginning, you should see that it is more than 4 millimeters. Then you will be safe, there will be no problem. Later on, you will probably do with less dilated ducts also.
CKD with fever for 3 months.
Vaishali,
Dr. Vinay, I think 4 to 5 millimeter dilatation is my cutoff point for doing the hepaticogastrostomy.
yes.
What is yours?
I have done few with normal ones also. I mean, minimally dilated. We use a 22 gauge, fill it and then do it. So, the beginning 4 or 5 millimeter is a good idea. There is another question. Do you know how to do a balloon dilatation?
Yeah, Dr. Vinay, what is the question?
Question is, after a cystotome, do you use a balloon dilator for
So
CDI?
in choledochoduodenostomy, I don't do it.
Right.
In hepaticogastrostomy, I do the hurricane balloon dilatation of 4 millimeter.
Yeah. So the duodenal wall is thin. You probably do not need so much dilatation. It's a beautiful demonstration. Very, very nice. So you can see choledochoduodenostomy can be done in 10-15 minutes by experts. Very, very effective.
I think changing the scope, patient is on the same table on same sedation.
Yes.
From ERCP scope to the EUS scope and 10 minutes you are done.
Absolutely, absolutely. It's an extremely useful procedure. So, especially distal blocks, I think that there is practically no relevance of PTBD now. You can straight shift to EUS guided biliary drainage as if your ERCP has failed, and go and do a choledochoduodenostomy. So, what is your post-procedure care of this patient, Rajesh?
So Dr. Vinay, 2 days IV antibiotic followed by oral antibiotic.
Okay.
And I just observe the patient for 6 hours for any pain, because sometimes a small amount of bile leak can produce the severe pain. So I look for that, and after 48 hours do an ultrasound and do the liver function test to know about the pneumobilia and the liver, and knowing the fall in the bilirubin level. That's all this we have to examine, and first 6 hours you have to look for the possibility of bile leakage, or sometime you might produce a pneumoperitoneum that can produce the pain. So first 6 hours is important to look for those. Otherwise, usually, and as you are doing in ERCP, that's all. I think the shortage of the stent is not a problem. Once the stent is shortened at that time, it doesn't short later. Anything else you want to add?
No, I think that's it. Most of these procedures are very, very safe. And if there are any problems, they will happen, as Rajesh said, in the first 4 to 6 hours. So a 24-hour observation is what is required. And if patient is fine after that, antibiotics, yes, are needed. I think that's what it is. So if you compare this procedure to a ERCP procedure, this looks much easy, but it is not. You see, there are multiple fine things which Rajesh demonstrated, which are required for you.
के बाद यहाँ पे वो CA pancreas वाला लगाएंगे, सुनो, assessment CBD इसको बताऊंगा.
So there is a good question from Dr. Chow. Rajesh, last question before you go to the next case.
Yes.
How between a fully covered stent and a LAM in CDS?
Yeah, LAMS you are talking, LAMS versus fully covered stent?
For CDS.
Yeah, so very good question. Now the two things, first I am talking practically. The LAMS is going to cost me 2 lakhs rupees and this is going to cost me 50,000 rupees.
Right.
I do agree. And second thing is, for the LAM, at least you require your scope should be absolutely parallel to the CBD, because you require 2.5 to 3 centimeter long segment where you can puncture it. So you cannot puncture bile duct obliquely because it can go through the opposite wall. There's no wire over it. And at least 2.5 to 3 centimeter puncturing should go across the duodenal wall. So for that you require 2.2 to 2.5 to 3 centimeter segment where your LAMS can go first in. So either your scope should be parallel to the bile duct. If it is like this, then you require at least 3 centimeter dilated CBD. If it is only once, because you don't have a wire that your line is going over the wire. Yes, you can do it over the wire, that's possibility, but I'm talking for what the hot exhaust has been meant. You don't require putting the needle, exchanging with the wire and putting over it. You directly puncture it. Second is the cost, which I said. Number third, when the bile duct decompresses, the opposite wall will fall over it and it can produce a traumatic injury. This is my feeling. Now, when I put the 6 centimeter stent, the disadvantage is you make sure that you are punctured proximally just above the pancreatic parenchyma, the CBD, because you should not block one side of the hilum. Otherwise, the risk of cholangitis is there. In those situations, I use the partially covered CBD if I don't get the good segment of the bile duct, because while doing the endosono, I know that how much is the bile duct just above the pancreas. In that case, I use the partially covered stent. So even if it reaches up to the hilum, 0.5 to 1 centimeter uncovered segment is there. So these are the few things which I decided. Anything else Dr. Vinay wants to add? He has a lot of experience on the biliary. He can tell us.
No, it's perfect, perfect. So basically, bile duct diameter is what Rajesh has been telling, that if you are putting in LAMS and you are beginning, don't put LAMS in mildly dilated 10, 11, 12, 13 millimeters because lot more space is needed. So if you want to place a lens, place a shorter 8 millimeter lens, otherwise food will go into the bile duct. And you need to have a diameter of the bile duct above 15 millimeters at least.
और सूरज को बुलाओ.
Okay, what is the next case?
So Dr. Vinay, now I have got 5 cases, but my feeling is I'm going to demonstrate 2 more cases.
Okay.
One is a Vaughan, which is lying in the second room, and this is a mediastinal because I prepared the cases like one fluoro and one non-fluoro room. So this is a patient, 42-year-old male, chronic kidney failure on maintenance hemodialysis, having fever of 2-month duration. CT scan shows a large necrotic node in the hilum. And can you see a necrotic node in the hilum? Is it visible here?
Yes.
Mediastinal node. Hilum means I'm talking about the hilum of the mediastinum, not the hilum of the liver.
No.
Is visible?
Yes.
So this looks like a necrotic node.
Yeah.
Is tuberculosis in our country.
Hmm.
Is that right, Dr. Vinay?
Absolutely, absolutely.
So what is your feeling, Dr. Vinay? I've got a Vaughan also in the next room. Should I show the mediastinal anatomy or should I show the FNA technique? I think let's again show the FNA technique with the 22G needle, acquire needle. Is that right?
Good time for both the cases, so don't worry. So you show the mediastinal anatomy also and show the 22 gauge acquire also and show the Waldorf necrosis. We have good time for both the cases. Don't worry.
Okay. So first of all, let's focus on my hand. I'm going to show the mediastinal anatomy, how to take the FNA. First of all, I'm using the 22G needle, acquired needle. Now you remove the cork from here. Now introduce your needle inside it. And it is always better you should have 1-to-1 movement. Now the most important thing I said, you do an anti-clockwise movement and do the clockwise movement and make lure lock should be very firmly attached. There's a one step. Now your knob should be on the opposite side towards the knobs of your scope, because while losing it, it should be in that direction. So the needle should be attached in the way that the locks of the needle should facing outward. Now you are sure that you have firmly locked it. The second point is taking the sheath out. I release the sheath button. I take it out. Now you can see can you see the EUS image here? Look at here. You will see the sheath will come here. Sheath will come here. Look at here.
Yes.
Can you see the sheath?
Yes.
And I can show you in endoscopy also. Just to make the big knob away. Can you make the endoscopic view? Now you see the sheath out. Can you visibly see?
Yes.
Can you see the sheath out?
Yes.
So that is the one way of making that your sheath is completely out. Is that right? Now bring the lesion at 6 o'clock position, because can you see the sheath here? So needle will come here. So either use elevator or bring the lesion at 6 o'clock. The lesion is still between 6 to 8 o'clock position. I will pull my scope. I pulled my scope. Okay. And I will put the Doppler. You see the Doppler?
Yes.
Now I will remove the Doppler. I will remove the, can you focus it this? I will remove the little bit part of the sharp part of the needle out. So needle will be sharp. I will release the needle safety button down. I hold between my palm and between those two fingers, and the movement will be to and fro like this. So this finger is going to restrict more than 2 centimeters. So you don't require to lock it. Okay. So I will hold it like this. I've used little bit of the what is called as elevator down. Although elevator produce lot of resistance. So I will further withdraw my needle, scope, sorry. And I will puncture it now with this.
EUS, please.
Is the EUS visible?
Yes.
Is that okay?
Right.
And I puncture, I will just give me a minute. Okay. Is the needle visible?
Perfect. Perfect.
Yeah.
So you see how many fine adjustments Rajesh did before he punctured. It's very important to spend some time before puncturing.
So Dr. Vinay,
Yeah.
now another important, when you withdraw, don't take it outside the mucosa. You should be on the periphery of the lesion.
Yeah.
Puncture it like this. 1, 2. Make the big knob little bit away. So you can use the fanning like this. 1, 2, 1, 2. Further make the big knob away. And you will be in this trajectory. Okay?
Yes. Beautiful.
From periphery, you have puncture here. Further periphery. 1, 2. I use the big knob towards me like this. So you can scan the entire node. The purpose is you use the fanning technique and you make sure that you have punctured the node completely. Is that right?
Yes.
So I think that is more than sufficient. I've done fanning technique and I'm going to use I will see how the material is. And in the last puncture, I will use the anechoic portion so I can get out the pus out and we can see the AFB is more visible in this. Can we focus here? So Ashwani is going to reintroduce the stylet to expel the material on the glass slide. Now this is important just to focus. The glass slide has two portions. One is a radio opaque and one is a transparent. Here you write down the patient details and the material should be here. I'm going to show you. You enlarge and I'm going to show you how to make the slides. So Ashwani is going to spread the material. Okay. So Dr. Vinay, the two slides has been made. Now important is while making the slides, it should be 30° and you should make very gently like this. And you see the material in this. Can you see the material?
Yeah.
Okay.
Yes.
And the second slide should be like this. Again, like this. Okay.
Yes.
Now what I'm going to do this time, I'm going to use the suction, Dr. Vinay, or the pull back technique, so I can get a little bit more material. Okay.
Yeah.
But yes, as you said, if you don't do the suction, you don't get blood, and in this there was no blood. Is the EUS image? Will you focus the EUS image?
So the US, please. Yeah. Now you're going into the
Yeah. Now Ashwani is pull backing, and I'm using again the fanning technique. This is my needle. I will puncture in this. I will change the direction by the big wheel. And by the big wheel, I will change my direction. So that's how you change the direction and you do it. So necrotic node in a kidney failure patient, in the Indian scenario, the high possibility that you are dealing with the tuberculosis. Any question regarding the FNA technique, Dr. Vinay?
So you are taking this sample, you will send it for histology.
Dr. Vinay?
I said if you are taking the sample, you send it for what? Multiple things because you are.
Yeah. So we send for the cytology, number 1, gene expert, number 2,
Yeah.
TB culture, number 3, and sometime maybe a cell block. Otherwise, because sometime a necrotic material also come and you just get the necrosis. So for that, sometimes we take more material and we do it. But gene expert, we always take and we send the sent for TB culture.
Right.
So you see the material. Can you see the material, black and the white?
Very good material. Yeah.
It's clearly visible.
Yes.
No blood, and the smear should be made like this.
Nice course. Good course.
So any question, Dr. Vinay? So we can shift to the next room.
Yeah, I think we can go to the next room and have a last case. It's 12:30, half an hour.
Yes, I have more cases. If time permit, then I can show it.
No, no, it is a fantastic view of all the cases that multiple different varieties for interventional US. Very, very nice collection, Rajesh.
इसके
Excellent.
अच्छे FN ले लेना.
So US guided FNB, FNA, different things. I think the world is shifting to FNB.
Vinay,
Yeah,
am I audible?
yes, yes.
So any questions regarding the FNA technique? I will be very happy.
So there is one question from Lahore. Do we need to go in the middle of the lymph node every time or till the end? So do you go
So-
all the way till the end and come back, or you stop at the middle?
What is the question again? Should we go to the?
So when you are using your needle, do you go to the end of the lymph node or you stop at the middle?
No, generally my feeling is I should go up to the end of the lymph node, number one. I try to take the FNA from the periphery of the lesion rather than central, because central is necrotic. But I scan entire lymph node right from the one end to the another end, not up to the middle.
Absolutely, absolutely. So in the beginning, when you are starting your FNBs, maybe you're a little scared to go to the edge. As you become more experienced, you understand how your needle puncture works. So you can push just the exact amount to go all the way to the periphery. And as Rajesh said, to get tissue from the periphery, because the center sometimes may be necrotic. What is the next case?
So the next case is he's a 34-year-old male, alcoholic pancreatitis, presented with a 2-month back history of acute necrotizing pancreatitis with a acute lung injury and acute kidney injury, managed in the ICU. After 5 weeks, presented with a history of vomiting. Actually, our all slides, man, because of he has stuck up. I'm extremely sorry, Dr. Vinay, for this, but all CT scan and everything was there. All slide was prepared, but the gentleman is stuck in the traffic. So this patient has acute necrotizing pancreatitis 2 months before, and then managed in the ICU with the acute lung injury and acute kidney injury, recovered in around 25 days time. Then on 5th week, he presented with the vomiting. His CT scan shows basically there are the 2 collections or 3 collections. One was in the head of the pancreas causing gastric outlet obstruction. And there's another lesion which was in the body and tail, and that was not well matured. First, I talked to the relative, we put a cystoduodenostomy, and his vomiting is absolutely fine. I discussed with the family, there is a possibility that he is going to develop fever because there's another collection which is walled off, which is not walled off, and that's why we have not done it. We talked to the interventional radiologist, they feel that they have to go transpleural, they have no window. So that's why we leave at that time. He went back home. After around 10 to 12 days, again comes with a fever. And his CT scan, which was done 4 days before, which shows an air fluid level with a walled off necrosis in the body and tail of the pancreas. So he has one biliary stent because he was jaundice and the fever in the beginning. He has one cystoduodenostomy, which is completely collapsed on the repeat CT scan, which was done 5 days before. Now he is running fever. So that's why we are planning to do the cystogastrostomy, because he has a walled off collection in the body and tail of the pancreas.
Okay. And what is your plan? Are you putting plastic or?
No, I'm planning to put the metal stent, Dr. Vinay. I would have shown the lens. Now, in this case, My preference is putting the lamp because the advantage is here I'm going to puncture with the 19G needle. I will exchange with the wire. I will dilate the tract with the cystotome. Then I'm going to dilate with the hurricane balloon, and then I'm going to put the stent. So 5 steps. If I have got a hot axios, 2 minutes, my job is complete. But this patient already has paid a lot of money, and putting a 2 lakhs hot axios will be a problem. So I'm planning to put the, which stent we are planning to put? Hanaro plumbar stent in this case. So CT scan actually, Dr. Khaturi has not come yet. Can you show the EUS image? So Dr. Vinay, can you see the necrotic material?
Yeah.
Can you see the necrotic material?
Yes, yes.
Can you show the fluoro image of the cystoduodenostomy and the plastic stent? Can you see the fluoro image bigger?
Not yet, not yet.
Can you see the one plastic stent in the bile duct and one
Yes.
cystoduodenostomy stent?
Yes.
So my aim is to produce the cystogastroscopy. Is that okay?
Yeah.
Now there was lot of blood.
Wow. From the start, how you position your stent and scope and everything.
Yeah. So Dr. Vinay, I'm using the linear echoendoscope Olympus. Now first important thing is your scope should be in the straight position. Can you show the fluoro, please? You see my scope is in the straight position.
Yes.
This is very mandatory because this patient might require necrosectomy.
Yes.
And your scope should be in the straight position. That's number one.
Yeah.
Number second point is you should have, can you show the fluoro? On Doppler application, there should not be any vessel.
Hmm.
I hope there is no vessel.
Yeah, no major vessel, no.
Now I'm using the 19G needle and
How far, sorry, Rajesh, how far below the G junction? You are 2-3 centimeters below the G junction?
I think maybe 3-4 centimeters. You see the gas in the fundus?
Yes, yes.
So please show the, can you make it bigger? Because I have got a EUS image quite far away. So which is the point of entry will be better. Can you show the fluoro, please? So there are blood vessels. Can you see it?
Yeah, yeah, small blood vessels.
I want to avoid those blood vessels, Dr. Vinay.
No major vessel.
Huh?
No major vessels, small blood vessels.
Yeah. Because there's a thickness of the parenchyma is also there.
Ultrasound picture big, please.
Doppler. Is this okay? Cytopuncture?
Yes, perfect.
Okay.
Yeah.
Is this okay?
There are some complaints about the sound. Can you improve the sound little bit from your side?
क्या नाम है डॉक्टर उनको बोलो साउंड्स की प्रॉब्लम है विल यू फोकस दिस विल यू फोकस द कैमरा now you see such a thick material.
Yeah, it's
You see the pus?
Yes.
So we take the pus for culture. Okay, Dr. Vinay. This sample will be taken for culture. Now the Bhagwan is going to put the wire, Jaguar. He is using the 035 Jaguar. And this is the case where you can put the nasocystic drain actually. You see a lot of thick pus not going. Okay. Wait.
How much wire you have put in?
So this is a basically I saw this patient has actually you have not seen he has a lesion in the body and tail. The head has so I have made only 1 or 1.5 loops.
Okay.
Ideally you should make 2 loops,
Ah,
but in this case I have only able to made it. So now Bhagwan is exchanging the wire and we will use the 6 French cystotome.
okay.
My only very stomach is thickened in this case. That I'm little bit worried about. This stomach wall is thickened. 3 centimeters stand we are going to place. Dr. Katuria, can you show the CT scan? Dr. Katuria has come. Can you visualize the CT scan in between? The latest CT scan.
Show the CGP.
Yeah, he will just go. He has just come because there is a lot of traffic. Our radio technician has also come, just came. Otherwise, the other people were showing. But Darshan is a radio technographer. He also just came because of the lot of traffic. So I'm putting the 6 French cystotome. Now the important point which I want to tell, because many of the time we have seen that cystotome is not going across the lesion. So I always says focus the wire. You see this is my wire direction. Now this is the cystotome which has come. Okay.
Yeah.
And I'm going to use. Okay.
Yeah.
Fluoro. Is the fluoro visible?
हाँ बड़ा करो थोड़ा fluoro.
Can you make the bigger fluoro?
You see the wire? Yeah.
So I have dilated with the cystotome.
Yeah.
Now I'm using the hurricane of 6 millimeter, 6 millimeter hurricane, and then I'm going to put the stent. So this is like a Shyam Vardla Raju study. You are doing the multiple gateway. Although the gateway was not made on the day 1, but the tubular lesion is completely disappeared. Now I'm using the 6 millimeter hurricane balloon. Amen. Okay. Now Bhagwan is going to inflate. Will show both EUS and fluoro image both. Yes. Inflate. You see now EUS image?
Yes, sir.
Okay.
Yeah.
Will you change the gun? So there was a problem in the gun. Bhagwan is just going to, although we have already dilated. You want to see again dilated balloon or should I deploy?
No, enough.
It's shown? It's shown the balloon?
Yeah, go ahead. Deploy the stent.
Yeah, again, inflate. Now you see the EUS image and both?
Yeah.
Can you see the EUS image of the balloon?
Yes.
This is the EUS image and you see the fluoro image also. Okay, now he's deflating and I'm going to remove the wire out. Now the last point is deploying the stent. So we are using 3 centimeter Hanaro stent. So a lot of pus is coming out actually. So my technique is, Dr. Vinay, always be leave inside the scope and then push it. This is my technique. The second part I do is all depend how much room is with me. Sometimes when the stent is released at a higher up, then you may have to release inside the scope. Otherwise, you may do under endoscopic guidance also.
Correct.
So now my colleague is going to give the traction fluoro, traction on the wire. This is important. Your wire should not buckle. That is important. He is giving traction on the wire, and my stent is just coming out. You will see. You see the stent has come out.
Yes.
Now he is going to release the stent. So I'm going to show you both in the EUS image as well as in fluoroscopy.
This is a 3 centimeter or a 2 centimeter?
Yeah, deploy. Fluoroscopy is visible?
Yes. This
Yeah,
is
you
a
see-
3 or 2 centimeters, Rajesh.
Wait, this is the 3 centimeter. You
Okay.
see the proximal phalange has deployed?
Yes.
Now the important thing is for the beginner should know. This is, can you see the EUS image?
Make the US image big, please. Yeah.
You have seen fluoroscopically it has opened, and in EUS also. You have to produce the tenting. I am pulling. You see, I have produced the tenting.
Yeah.
I have produced the tenting. Now I will tell my colleague, Bhagwan, to release. And I am pulling my stand towards me. I am pulling towards me. I am pulling towards, and he has deployed.
Yeah.
Okay. I will pull the, can you show the endoscopic view bigger, please?
Fluoro endoscopy.
You see now?
Yes.
There was a pus coming out. That's why there's a visibility. But you show on fluoroscopy. Can you see the fluoroscopy also? Make the bigger fluoroscopy once.
Fluoro bada karo.
Fluoro bada karo.
Yeah.
You
Beautiful.
see the stent is lightly deployed.
Yeah, yeah.
Now I will show the endoscopic view because the pus was coming.
Yeah.
That's why your vision is not good. So if your vision is not good, it is always better. Can you see, Dr. Vinay?
Yeah, yeah. Frank pus coming out. Very good indication.
So should we put the NJ tube?
Yeah, yeah.
Okay, leave the wire. So I'm going to put the nasocystic drain in this. So that is one of the paper which Sandeep has published, putting the nasocystic drain and doing the lavage. So I think this is a good indication. In the first case only you can do the placement of the nasocystic drain. Is that right?
Yeah.
You see the frank pus in endoscopy? Can you show the endoscopic view now?
Yeah.
Frank pus is coming in endoscopic view.
Yeah.
This is the 8 French. 7 French nasobiliary catheter, that is nasocystic. Now we are labeling. There is no separate. It is the same which comes for bile duct drainage. Huh? So, Dr. Vinay, how much time we have?
You have 10 more minutes.
How much?
10 minutes.
Okay, I've got a one case which was referred for the staging of pancreatic cancer.
No. This will be your last case.
Fluoro? So now I'm putting the nasocystic catheter is going in. Give a traction on the wire, please. So catheter has gone deep inside. Have you observed?
Yeah.
Okay, now he's removing the wire. Can you see the catheter in the tail of the pancreas?
Yes.
Now we will exchange it. I think just see the endoscopic view. Give me a second. You see the stent is right position?
Beautiful. Beautiful.
I don't think stent is going to migrate.
No, no.
Okay. So I'm just taking out the scope. Remove the scope, please. Yeah. So this is under fluoroscopically. We are gradually removing the scope. keep the fluoro on, so your this should not loop remove. Please do the suction. Now this is important. If I will show the nasal conversion technique the last 2 minutes. Is okay, Dr. Vinay? Because this is also important for the beginners,
Yeah.
how to nasally convert nasocystic, because it has come out through the mouth.
Yeah.
So what we are going to do is we are removing the mouth guard and we are putting 10 ml of the syringe along the side of this. Open the mouth. Patient is sedated. Now he is not opening up the mouth. Let him little awake. He is not opening the mouth. Yeah. Can you put the syringe? So anesthesia colleague is putting, because he is partially sedated, so his mouth is closed.
So some questions for you, Rajesh. Before
Yeah.
we can I ask you some questions?
Yeah, please, please.
So Dr. K.K. Rawal is asking, how did you decide that the balloon is completely out of the scope channel? You dilated, no, with the balloon? How
Yeah,
did
yeah.
you know the balloon is out of the scope channel?
So the two maneuver, Dr. Vinay, one is once your balloon is inside the cavity, you switch on the endoscopic view. That is number one. And you pull the balloon again back. That's number one. Number second, in US image, you are getting the feel that your balloon is going in. And you are correlating with the fluoro. The first marker of the balloon is come in. And balloon is around 3 centimeter, 4 centimeter. So in that case, you just pull it out and you make sure that these are the only way that you make it, you can do it.
Because the gastric wall has to be dilated, no? If it goes completely inside, so that's a
Yes.
good.
सीधा कर दो.
What are the
Partially.
settings? Are they different in stomach and duodenum?
Of the stent, of the putting the stent,
Yeah.
again in the duodenum, you may not need to dilate, or you may dilate up to 4 millimeter.
Cautery. Cautery setting are different or
No, cautery settings are absolutely same.
Okay. And Nikhil is asking tips to prevent migration of lambs.
How to prevent?
Tips to prevent migration of lambs.
Yeah, so the tips to prevent the migration of the lambs is, once you deploy the proximal, that is inner side, then make sure that your proximal side, or what is called as, should be inside the scope. And you release inside the scope. Once you have released, then pull back your scope and push back your stent. That is the number one. Number second, if you have got a good endoscopic view, in that case, you see there is a yellow or green versus stent. You can see the division where the proximal end of the stent. That should be under your vision. That should be under your vision. That is important.
केस नहीं लगे हैं, एक सर्जरी का एक हमारा है, हमारा वाला यार लैप्रोस्कोपी वाला ऑपरेशन हो गया, नोट दे दिया उन्होंने.
There is one more question.
U100 का CBD क्लियरेंस ERCP का है, ERCP CBD क्लियरेंस, उसका भी ERCP रिपोर्ट होगा. हाँ रिपोर्ट है, रिपोर्ट है.
Rajesh,
फर्स्ट रिपोर्ट होगा, देखो
somebody is speaking. Ask him to be quiet.
लिखा होगा ERCP.
Not from our side.
नहीं ERCP होगा. You had a ERCP report.
Who is this?
It's not from our.
ERCP report दिया है.
Mute everyone else other than Rajesh and me. Okay, one more question. It's a very important question. Pseudocyst with extensions into paracolic areas. Would you drain it or no?
Yeah, either I use a dual method, the lateral extension through the percutaneous route, and the lesser sac is with the endoscopy.
Okay. So now you have 5 minutes to show what you want to show.
Yeah, so I am going to show you the how to convert the nasal tube. We'll show the fluoro and the endoscopic view. Can you show the camera here? Now you see here, I put the nasal converter from the nose and I bring it out. Why we remove this? 10 cc syringe. Where is the 10 cc syringe? Yeah. Okay.
Yeah.
Now from this end, I am going to introduce the nasocystic catheter. And I will pull it out. Okay.
Yeah.
Now the most important thing comes, it will coil, it will have a U shape in the neck. So the end which is going towards the esophagus needs to be pressed with your index finger. That's important. So this is the end which is going towards the esophagus. Darshanji, can you show the fluoro? Can you show the fluoro, please? Okay. My finger has blocked. Can you see my finger? Can you see my moving finger?
Yeah.
This has been blocked and now I will pull it.
Yeah.
You see, I've done it.
Yes.
This is how it is. Can you see now?
Yeah. Yeah. Okay.
Okay.
Yes. So, what do you do now that you have placed a nasocystic catheter? How do you flush the cavity?
Can you show below? So in my hospital, what I do is I placed, because there is already a stent.
Right.
So I don't do, there's a two method. One is I continuously, I do the diluted hydrogen peroxide or with the normal saline. I flush it with the 50 cc every 3 to 4 hour interval. That's the number one way. Number second, I attach the normal saline and inject 50 ml every hourly through the drip.
Continuous.
The thing is, it is a necrotic material. You have to agitate it. And to agitate it, you have to flush with the syringe rather than flush with the bottle. So in my practice, the instruction to the resident is clean the proximal side. This is important. Now look at here. This time always be clean before flushing. And once you have done, the 50 cc syringe, saline will be pushed. So this will agitate the necrotic material. Fix it, flush. That agitate and it will bring out, and it will not going to block the inner side of the stent.
How long do you keep the nasocystic drain?
So generally in my practice, I don't put the nasocystic drain, fix it first. I don't put the nasocystic drain. I think after a very long time I've done, because this was a frank pus was coming out of it.
Right.
And already patient was on antibiotics. And that's why I thought that a thick pus, so let's put it. Otherwise, after putting the Nagi or the Hanero stent, if patient has a new onset of fever, then while doing the necrosectomy, I put the nasocystic drain. Otherwise, I don't place the nasocystic drain in my day-to-day practice.
सैंपल आए हुए कितने पेशेंट्स के ये बता सकते हो?
Who's talking?
Fantastic. Rajesh,
कर दिया
thank you. I think we have.
So I would like to thank from my entire team, Dr. Suraj, Dr. Madam, please come. So again, I would like to thank everyone.
Thank you very much, all of you. Thank you. Thank you. Great show. Really great show. Really enjoyed all the cases. You taught us so much. Thank you
Thank
very
you,
much.
Dr. Vinay. Thank you. And all the best for your conference.
Thank you. Thank you very much.
Thank
I'll
you.
see you tomorrow for your lecture again.
Thank you. Thank you.
Priyanka?
Yes, sir. Thank you so much, Dr. Rajesh Puri. It was very excellent demonstrations. Almost we have seen all the cases. And now there will be lunch till 1:45 p.m. And after that, there will be lecture on PFC drainage by Dr. Sandeep Laktakia from Asian Institute of Gastroenterology. So we are all moving for the lunch now. So there is 45 minutes break. And then again we'll back to you. Thank you. Thank you, sir.
Thank you very much. We meet after 45 minutes. Don't go away anywhere. We have wonderful 7-8 cases coming from AIG hospitals in the afternoon also. Bye. See you after 45 minutes.
Lectures and followed by live demonstrations. So I would like to invite Dr. Sandeep Lattakia. He's the director at Asian Institute of Gastroenterologists, an interventional US expert. We all know about him. So before wasting the time, sir, kindly proceed with the lecture PFC drainage, how I do it, tips and tricks. Welcome, sir.
Thank you, Priyanka. Thank you, Vinay. Good afternoon from Hyderabad, India, and good evening and good morning to respective parts wherever the audience is located. Let me share my screen. What is that? You see my slide?
Yes. Yes, we can see, sir.
Yes, we can see, sir.
Thank you. So as the name suggests, EUS guided pancreatic fluid collection drainage, how I do it, and tips and tricks. So before we select a patient for drainage, we also have to keep in mind what stent we have to use, plastic and metal, and how we decide choosing this stent is what I will also be discussing in this talk. But first thing first, when you see a collection which has been referred to you for drainage, you'll have some imaging with you. It will be CT scan or MRI or an ultrasound, and the respective history should also be there, which suggests that the patient had pancreatitis in the recent past, which has now led to a formation of a pancreatic fluid collection. And which one of these two is there, whether it's pseudocyst and one. And you may have sometimes an images like this, where a large collection is seen in the pancreatic region with very small amount of debris, but large fluid to be precise. And this can be actually drained by a plastic stent as well. This has very small amount of debris. But on the right panel, you have a different collection, which has debris in the center. And this is little more than, I would say, about quarter of the volume in this view. And in that case, a metal stent is generally preferred by most people. CT scan, especially a plain scan, is not very useful. It may guide you to some amount of debris, but doesn't show you as well. As you can see, this two images of the same patient. You can see the debris very well on the EUS, but this is hardly seen on the CT scan. Whether you even do a contrast CT, the debris is not well seen. So ultrasound, be it transabdominal or endoscopic ultrasound, and MRI are the two best modalities to make an estimation of debris. And when you do EUS, you also see other things like blood vessels interposing between the gastric wall and the cavity and the collection. And you also see inside the collection how much the estimate of debris can be made. So the advantages that EUS offers for draining these pancreatic fluid collections is improves the localization. You know exactly where the cyst is and which is your likely point of entry, which means that most often it is stomach, but sometimes cysts located higher up in the upper abdominal cavity can have a better entrance point from the esophagus, and that one must be aware. So you should know where the G junction lies and then adjust your subsequent accessories and the stent selection based on where you enter. Same goes for duodenum. If the cyst is more prominent in the duodenum and also has some projection in the stomach, it's better to drain from the duodenum, but your accessories then will change and your point of entry will be a little more challenging, but nevertheless, it has lesser risk involved. Plus we see the visualize and avoid blood vessels which are interposing between the GI lumen and the collectant. You select the thinnest point of entry. Also, you check at the scope position, which will also allow you for easy access to the entry to the collection. And it also provides an ability to puncture non-bulging or even little distant collections. Having said that, about 1 centimeter thickness is taken as the cutoff of the wall of the collection, which can be drained safely by EUS. If it's more than that, it's better to wait or use alternate methods of drainage. The only drawback is if you plan to use the thicker stents, then the accessories or the stents may not pass as easily. For example, a 10 French stent will be snugly fitting into a channel, and you cannot have two wires beside and then pass this stent, unlike the duodenoscope, which has a thicker channel. So moving forward, the first thing first is how do you assess? And when you do an EUS, you see the wall is mature all around. You see the internal contents, it's mainly fluid with about quarter of the volume is by the debris. You measure the largest dimension and a perpendicular line to that. You see the wall thickness. You look at the interposing vessels. These are the few things that we look at very quickly to make an assessment, whether the wall is mature, the content of the collection, presence of debris. If yes, what is a rough estimate in context to the overall volume, interposing vessels, and which site you are puncturing. Having not decided to drain it now, this looks mature. So first step that we do is at this point, suppose we have decided to place plastic stent, and that has a series of steps which have to be followed. And also the same steps are sometimes required in the non-cautery enhanced stent, that is the cold metal stents, which I'll touch upon later. So the first thing is puncturing the cyst cavity with a needle, and it's always 19 gauge needle because it allows a 0.035 or a 0.025 guide wire to go down easily. You aspirate the fluid out, and this fluid is sent for two things. One is culture in case of patients who have sepsis and you want to change your antibiotics. So this is the purest form of infection which you have now got, which can then be subjected to culture sensitivity, and you can adjust your antibiotics later on if required. Second, you can also send this fluid for amylase. That is only for patients where the suspicion is not very strong and you have some other doubts in mind. Almost always this amylase is very, very high in most pancreatic fluid collections. And then you pass a guide wire after aspirating. You pass a guide wire which coils inside the wall of the collection, and it may look like this on X-ray. So you need to have an X-ray room available unless you're using a cautery enhanced system where it can be a one step or a one device can do the whole thing bedside as well. So the wire should coil at least 2 times in a moderate or a small size collection, but in a very large collection, one whole circumference is good enough. So these are the several needles which are available, and each one is quite good. A regular 19 gauge needle is good. Then you pass a guide wire, and which guide wire do we choose? I said 0.025 and 0.035 is okay, but my personal preference is to use an angle tip wire and not a straight wire. Why? The reason is that in case the other wall of the cyst is not mature, my guide wire will go a straight hit and go across into the peritoneum sometimes in a straight wire. So if you use an angled wire which doesn't hit as strongly or sharply at the opposite wall, it can bounce off. And that's why the lower wire is my preference than an upper wire. But if its cyst is mature, either wire is as good. Once the wire is coiled well, which you can see on EUS as well as on fluoroscopy is better. But one important thing I would like to mention here itself is that guide wire should be visible on your EUS screen all the time. This is your lifeline. If you miss this lifeline and you try to look at other things, endoscopy, fluoroscopy, and this wire, if it gets looped in the stomach between the scope and the point of entry, then the whole procedure can go haywire. So never lose your guide wire on your EUS screen. The next step is to dilate. So you punctured, aspirate the fluid, sent for analysis, pass the guide wire which is looped inside, and now you create a fistula between the stomach and the cyst cavity if you have entered via the stomach. And there are 2 ways to do it. Mechanical dilation is by bougies, which can be stiff dilators, or tapered catheters and a very thin wall can be used, or a stiffer balloon can be used. These are several accessories here. But my personal preference is to use an electrosurgical device, and cystotome is the most preferred one. So point number 2 here, which I would like you to take home, is to have a 6 French cystotome in your unit. If anybody wants to start an EUS guided drainage, cystotome is the most important device that you need to have. It easily goes over the guide wire. It is coaxial, so it doesn't go in any other direction. It burns the same path which the guide wire has followed. If you use a needle knife, which some of the centers or the countries which do not have cystotome are using, have a higher risk of complication because it's not coaxial. As you see in this picture, the guide wire is in one direction and the needle knife is in other direction. It can cause a separate path burn, and which can cause perforations and bleeding. So let's see the examples of this. On the left panel is a mechanical dilation where a stiff cannula is being passed over a guide wire. This is only works in cysts which are very thin wall, 2 millimeters, 3 millimeters, 4 millimeters, and your point of entry is straight, which means that the scope is straight on and your accessory will go straight. But in case you are deep in duodenum, sometimes this, even in thin walls, may not pass out easily. And that's why cystotome will work wherever you want to drain. As you see it here, it's passed out quite easily. It will cause few bubbles. You will get a feeling of loss of resistance when you cross the gastric and the cyst wall. That itself tells you that you have crossed it. You don't have to go all the way deep into the cyst cavity. Just crossing the wall is good enough. And then we dilate this fistulous path with a balloon. And if the intent is to place plastic stents or 2 plastic stents, which is often used, we dilate up to 15 millimeters. 10 to 15 millimeters is the standard diameter that we use for a CRE balloon from the stomach, which can be checked on endoscopy and fluoroscopy if you inject contrast within the balloon. But if the intent is or your point of entry is esophagus, then your balloon should never cross 4 or 6 millimeter. In duodenum, you can be slightly more liberal than esophagus, that is 6 and 8 millimeter. So this is a rule of thumb: 4 to 6 in esophagus, 6 to 8 in duodenum, and 10 to 15 in stomach. If it has infected, that means the first aspirate should pass. Then it is better to dilate more because you want the fluid to drain out as much as possible. On the contrary, if these steps are also required for the metal stent like Nagy stent and similar kind of stent like plumber, then the balloon diameter is very small, 4 to 6 millimeter, just enough to allow the assembly to go inside the cyst cavity. Okay, so you will decide upfront which stent I am going to use. Like for example, I showed in the assessment video, which had a lot of debris. My intent is to place metal stent, then I'll use this much. Moving forward, if plastic stents are required, then we place 2 guide wires, and then on each guide wire place 1 stent each, and these stents have to be double pigtail stent, short in length, that is 4 or 5 centimeters. My personal preference is to use size 7 French, but some people also prefer 8 French, 8 or 8.5, that's equally good. So both the guide wires have to be placed up front. And how do we do that? So this is the second stent of plastic going on. Just to complete this video first, and then we'll come back to the how to place 2 guide wires. So the first guide wire goes to the needle. After we dilate with the balloon, we pass another assembly over the first guide wire, which can be a double channel cannula or a Haber's ram or a thicker cannula, which is a stent pusher tube, or similar kind of devices which can accommodate more than 1 wire. And then once you have 2 wires inside, then you place 2 stents. Never try to place 1 stent and then try to recannulate and then place a second stent. It will always cause problem because the fluid is gushing out. It will obscure your point of entry. You will not be able to see well. You'll start distending stomach, and that causes risk of aspiration. Moving forward, so this is the plastic stent part. Now if you have to place metal stent, the initial steps remain same for the Nagy stent placement. You puncture, you pass a guide wire inside, see it under fluoroscopy. Always keep a view of the guide wire when you're doing cystotome. Pass passage over the guide wire. And then you dilate with a small caliber balloon like you see it here. This is a 4 millimeter balloon, which you can see both either on EUS or on fluoroscopy or on EUS or endoscopy, either of the 3 views. And then we pass the stent. So stent can be passed purely under endoscopic view or under EUS, endoscopy and view, or fluoro, EUS and endoscopy view. So all 3 views are available. You can select and choose whichever is better. So this is how a nicely placed stent would look like. A good flange opening in the stomach, little bit of length in the stomach. The stent on X-ray looks perfectly biflange with the thinnest part in the center of the stent. And sometimes you get this like a tie bow appearance on the EOS. And these are some of the other large caliber metal stents. The top one are called LAMS, or the lumen opposing metal stent, of which the classical variety is Axios and Spaxus. Both have good lumen opposition. That means risk of migration is much lesser. The biflange stent, the common variety is Nagi, BCF, and there are a few more like plumber stent also falls in this. They are just biflange, but they have a very less lumen opposing capabilities. Because they are softer stents, they're a little longer length in the shaft. Moving forward, then we have this new stent, which is the lumen opposing metal stent, and which has a cautery enhanced tip. And this is the one of the better stents which is currently available, although expensive in several countries. And it has 4 steps inbuilt into it, by which we first burn your way in, then you remove the yellow cannula, pull back the stent so the inner flange opens up, then you pull it back further so it hugs the target organ, which is a vault of collection here, and then you deploy the proximal stent after this black mark is visible on the GI side or the stomach side. So this is not a very intuitive way of placing, but having learned it once or a few times, then it becomes quite a natural way of delivering. Whereas the Nagi and the plumber stents are the intuitive stents, which are quite similar to our biliary stent and an enteral stents or colonic stents. They have the similar way of delivery mechanism. The only difference is they are short in length, so have a high degree of risk at placement, and sometimes malpositions can occur. But Axios has inbuilt safety mechanisms if you follow the steps correctly of locking and unlocking at different steps. So let's show an example of an Axios stent. I'm sorry, this video is not playing. Maybe we can show you in the live case today. So this is our publication which happened a few years ago, where index placement of a dedicated metal stent was good enough to drain most of the collections of vault of necrosis variety. And 75% actually improved just with placing of metal stent, and further interventions were needed only in rest 25%, which could be either just declogging the stent or putting a nasocystic tube to irrigate or doing necrosectomy. This is a very important slide I thought I'll share for the beginners or people who are doing this, is which imaging to use at which step of EOS drainage. So first thing is inspection of a cyst before drainage by EOS. Obviously this has to be done by EOS only. Next step is puncturing, which is done under EOS vision. You don't require endoscopy, you don't require fluoroscopy. The next step is passing the guide wire. Obviously we need an EOS because we need to see the guide wire going in, and it has to be cross-checked on fluoroscopy. Endoscopy is still not required. Then you create a fistula where you pass a cystotome over the guide wire. Again, you need EOS. Fluoroscopy, if it's seen, it's fine. But with experience, you don't require this. And endoscopy is still not required. So you don't have to switch to endoscopy mode. Just stay on your EOS mode, at least till the fistula step. Next step is of balloon dilatation, the penultimate step, where again, you can see the entire thing, the balloon as I showed in the video. Inflated balloon is seen very nicely inflated inside the cavity, in the wall, even in the GI lumen. You can also cross-check on fluoroscopy if you have inflated with contrast. And endoscopy, if you want to be 100% sure or you want to reposition, then you can do it. The last is then EOS. Again, for stent placement, the inner part of the stent is placed under EOS, whereas a gastric part is placed under endoscopy and fluoroscopy. Whereas sometimes, especially for metal stents, we're leaving the stent inside the channel of the scope, and even then the endoscopy is not required. Only at the point of final, when you've deployed the channel and then you push it out, then you require endoscopy to be seen. And this is how these most collections behave. The vault of necrosis quickly comes down. And this is what I meant by further intervention. A few days after drainage, the patient comes back with symptoms of fever, which was not there in the beginning. Then you have to inspect and see. And this is a large debris clogging the stent. Just teasing it out with a snare can clean the whole system and allows the fluid to drain out. But if the debris is quite adherent and deep inside, then placing a tube like this, nasocystic tube, would be useful, and which can be then externally irrigated with saline. And sometimes you can use hydrogen peroxide if that is not helping just with saline alone. Last step of further interventions is direct endoscopic necrosectomy, which we hope to show you today in the live cases. When a lot of debris is inside and the patient continues to have infection, so there you go inside the cavity using several devices, one after the other, with a regular upper GI endoscope, and using a snare or a forceps or basket, you can gently tease out and pull out these the debris. This is a very labor-intensive procedure. It will look good on a video or edited videos, but sometimes it can be half an hour to 1 hour of procedure, and has its flaws because blood vessels are quite deep inside, just below it, and that can sometimes bleed. So the major advantage which large caliber metal stents, that is both Nagi and Axios, offer is they're easy to deploy. They have larger diameter and hence provide efficient drainage. They are covered stents and prevents leaks and perforations. They're self-expandable and hence prevent any entry side bleed. The design is saddle shaped of biflange and hence reduce migration. Intervention can be done through these stents. Is it okay? I'm overshooting the time, or is it? Okay. We'll
You're
go.
out of time.
But there are some disadvantages also, which is sometimes malpositions can occur because these stents are very strong.
Sorry.
Skewed position of the stent can cause a little problem, and it can lead to migration and bleed. Bleed can happen from the bleed from the posterior wall of the collection. So as the cyst compresses, the posterior wall now comes and touches and rubs against the inner flange of the stent, and those blood vessels can bleed. That's why they have to be removed in a finite period of time, generally by 3 to maximum 4 weeks. Migrations can occur both at spontaneously or sometimes at direct endoscopic necrosectomy, more common with Nagi type of stents, and they can sometimes hinder with your direct endoscopic necrosectomy. For example, if a large amount of chunk of debris is kind of enveloping the inner flange and the space is less, you will not be able to catch it. And once you withdraw the stent out, then you have more room to play around, and then the wall or the fistulous path become more pliable to play around with, and then you can remove those debris. So our decision to require which stent, if any collection which has debris more than 10 to 30% or more, we prefer to place a metal stent. 30% or more, definitely metal stent. Between 10 and 30, it depends on several other factors as well, including cost, or if the collection is very, very large. But pure pseudocyst, that is no debris or debris which is less than 10%, we prefer to use plastic stent. And we hope to show both these varieties today in the live cases. Sometimes the timely removal does not happen and the patient comes later. This is a lucky feature where you can still see the stent and the thread there. It can be pulled out. But often this opening also gets sealed off, and then the stent is more out, almost out of the stomach wall. And then surgery or other methods are required to remove these stents. You can at times place with a plastic stent, but that is still debatable. Our personal preference is not to place plastic stent because we feel that the disconnected duct, which happens very often, is not very clinically relevant in the patient. Let me show you some other examples of necrosectomy. This is a large necroma sitting on the mouth of a Nagi stent, which is now being removed by the snare. My personal preference to use necrosectomy is a braided snare. A large braided snare is best because it grasps well. And once you pull it out, one can see that the stent also can migrate because it drags the stent out from the cavity. That's what happened in this patient also. And once we go inside the cavity through the same opening, which is still widely patent, you can see the pus gushing out. The stent is out. This has to be removed and can also be replaced. I'll show in the next video how we do that. And then carry on with necrosectomy further. So this is an inner view of the necrosectomy. And you see the wall is quite thin, but you see big vessels also behind. So one must be aware. So this is an interesting thing which I thought I'll share in this forum of how to replace an externally migrated stent. So now in the previous video, we saw that stent had come in the stomach. We pulled it out, cleaned it up with saline and kept it ready. So after doing the necrosectomy, use a regular upper GI endoscope and a foreign body forceps. This foreign body forceps is passed outside the patient now through the channel of the scope and brought out at the tip. So the stent is kept right in front. The forceps will come out from 7 o'clock view. It will now grasp the thread. And once you grasp the thread, use your fingers to crimple the stent, and generally the stent is now pulled in with the forceps itself. Just pull it inside the tip of the endoscope. So it's now loaded. So now the stent is loaded inside a forward wing regular upper GI endoscope. You take the scope inside, go inside the cavity. At the end of necrosectomy, now you place the stent inside, push it in by pushing the forceps and gradually withdrawing the endoscope. And you will get the exact position what you want to do as you place in a normal index drainage procedure. In fact, sometimes you can carry on with the procedure if you want to do. But it's a very easy way to replace the same stent in the patient without using any other device of the stent assembly. Occasionally, the stents can migrate deep down. So this is the stomach where it will place, but with such a huge cyst going almost to the pelvis, the stent actually went down, which we realized immediately at the time of placement. Since the guide wire was inside and the track was dilated, we placed another stent over here. So now we are doing a necrosectomy and salvaging of this stent to the second stent. So this is the second stent which is at the gastric end. Go inside that into the cavity. As we see it, we're going beside, not in through the lumen of this stent. See a lot of necrotic tissues there. This is the plastic which is just beside the metal stent. That's okay. And then we keep going deeper and deeper until we actually see the stent there, and then we pull it out. So one stent can also salvage the other one. This was how the position was. The wire was going deep. Oh, sorry. Sorry, I don't know why this happened. I'll just get back my slides back. Meanwhile, any questions and comments are all welcome here. I'm almost to the end of my presentation, and this was one of the images of the same patient with 2 stents inside. And sometimes the migrated stent can be salvaged if you realize soon after by placing a plastic immediately and come back few days later, use the plastic stent as a target area, and then go beside it, go inside the cavity by after dilating with a 15 mm balloon. You can take your foreign body forceps, catch the stent, any part of the stent is okay, and just gently tease it out. You can reposition the stent back to where you desire it to be placed up front. Here it is. This is the last slide, I think, of a patient who had a bleed at the time of placement of a stent. This has small amount of debris, but we saw very brisk bleed. I mean, our initial intent was to place plastic stent, but once we saw this brisk bleed happening, which is noticed immediately, we switched our strategy to place a metal stent, and we placed a Nagi stent. And the stent is self-expandable, and that tamponades the bleeding vessel from the entry site, and that was quite effective. So the complications we all know of pancreatic fluid collection drainage is bleeding, perforation, infection, and air embolism. Now the last is almost negligible because we use carbon dioxide. Perforations have come down with the use of fully covered metal stents. Bleeding, if it happens, can also be controlled. If it entry side, you can use a metal stent. In the end, I would like to conclude by saying that use pancreatic fluid for drainage of pancreatic fluid collections. Use a metal stent if it has significant debris, 30% or more. Plastic stents if it has less than 10% debris or it's pure pseudocyst. In between, I leave it to you to decide, and remove these stents by 3 to 4 weeks. Re-intervene only based on symptoms. And I would like to introduce my team. Some of them would be there in the workshop today, who have been instrumental in taking the group forward with their hard work. Thank you very much for your kind attention.
Thank you so much,
Sandeep.
sir.
Thank you very much.
Thank you for the wonderful presentation, interesting videos and practical learning point. So now we'll move to the next lecture. It is on USBD, the current status. I would like to invite Dr. Vinay Dhir for the lecture. Welcome, sir. Thank you, sir.
Thanks, Priyanka. Sandeep, there are lots of questions for you in the chat box. What I will do is you are showing you are showing the cases, no?
Okay.
At that time, I'm going to ask those questions to you. Yeah.
Perfect. Perfect.
Fantastic talk. Fantastic talk.
Thank you.
So thanks, Priyanka. Let me start with my presentation. EUS guided biliary drainage. So as you all know, EUS guided biliary drainage is now almost 2 decades old, and 2001 was the first biliary drainage reported, and since then the first 10 years were a little tough. There were very few people doing it. The accessories were not there. But now, in the last 1 decade, we have excellent data coming up, and it has established itself as an alternative biliary drainage procedure. So, over the next half an hour, I will discuss the EUS guided biliary drainage from a beginner's point of view. So when you're starting, what all do you need to succeed? It's not a single thing. You need to have the right indication. So what are the right indications? Basically, currently we are using it after failed ERCP in patients with duodenal stenosis or in patients with post-surgical anatomy. You should know which procedure to use in which case. So in the morning today, you saw Dr. Rajesh Puri demonstrate a fantastic corridor duodenostomy, and we discussed it, which procedure to do. So that understanding has to be learned. The right accessories, we had a large session in the morning on the right accessories. So you should always have the right accessories with you before you start. And then the right stent also we discussed in the morning. You should have the stents that are required, both the non-EUS and the EUS stents. And last but not the least, I consider it the most important, the right training. So, EUS BD cases are few at most of the centers. Even the big centers do not have enough EUS BD cases. So in that case, how do you train appropriately before you feel confident to perform EUS BD? So I told you the right indications, the failed ERCP, patients have a approachable papilla, but you cannot cannulate. ERCP has failed because of a variety of reasons. It usually does not happen in more than 3 to 5% of cases, but previously we used to send these cases for PTBD. Now you can just change the scope, convert to EUS scope, and try EUS guided biliary drainage. Duodenal stenosis and post-surgical anatomy also previously were indications for PTBD. No longer we can use EUS to perform endoscopic drainage right in the endoscopy room. So a variety of procedures are there for biliary interventions. As you all know, we have access procedures, which is rendezvous. Now, rendezvous is basically a hybrid where EUS is only used to pass a wire antegrade from the biliary system out of the papilla. And then we use ERCP to complete the thing. So this is only needed in patients in whom we have failed cannulation and the papilla is available. Then you have biliary drainage procedures, which can be transluminal. Transluminal means you are passing a stent across lumens, so between the stomach and the left intrahepatic biliary radicals, or between the duodenum and the bile duct. So transluminal procedures are choledochoduodenostomy, hepaticogastrostomy, and also gallbladder drainage. Or you have antegrade procedures, which are just like PTBD. So you go from the left side and then put the stent across the stricture, across the papilla into the duodenum. So these are a variety of procedures, and then you have to choose which is right procedure for which indication. I'll briefly show you these procedures, very brief. So hepaticogastrostomy is okay for any patient who has dilated intrahepatic biliary radical. Distal or proximal block, both are okay. As you saw in the morning, you need a 19 gauge needle. You should position your scope in a proper way. You can see the position, it is looking towards the papilla. Pass a wire and then dilate with a cystotome and place a partially covered stent. So a variety of partially covered stents are now available. What is important is that you should leave about 3 to 4 centimeters of the stent within the stomach, because there is no tumor to hold this stomach, this stent. So if you do it like ERCP and deploy it very close to the opening, it might migrate inside. So leave a little length of the stent inside the stomach. So it's a straightforward procedure, but you need a certain things. You should deploy the stent within the scope. Be careful that you do not make it very tight. I think in the afternoon, Sandeep is showing one hepaticogastrostomy, so he will show you further tips. Antegrade procedure, I told you, it is like hepaticogastrostomy. You go from the left lobe of the liver, but the difference is the stent doesn't come out in the stomach. The stent goes all the way inside the biliary tree and across.
ऊपर वाला खुल रहा है, एक और स्ट्रक्चर है उसको नीचे जहाँ से
procedure, a patient, you can see there is a stenosis here, there is a recurrence. So you can see the needle position passing the wire across into the jejunum in this case. This is a terumo wire that we are using, and after that you pass a 6 French cystotome all the way across, confirm that you are in the jejunum, and then put a stiff wire and put a stent. So this is our favored procedure in our unit, because we can use the stents that we commonly used for ERCP. The uncovered metallic stent is good here. It is cheaper compared to EUS specific stents. So antegrade procedure has the advantage of less cost. It is difficult to pass the wire across the hilum, across the stricture into the duodenum, but it can be learned. It is not very difficult. So this is the antegrade procedure. So unless there is a tumor in D2, large ampullary tumor or duodenal obstruction, antegrade procedure is a fairly good procedure. So for us, it is rendezvous and antegrade procedures. Both are transpapillary procedures. And then if they are not successful, then we go for hepaticogastrostomy or choledochostomy. You saw the choledochoduodenostomy in the morning, so I will not spend too much time. Long scope position, inject contrast, pass the guide wire, use a cystotome to dilate the tract, a 6 French cystotome, and place a stent. So this is a fairly straightforward procedure, good for distal CBD blocks. You cannot do it for hilar blocks. Rendezvous is, as I told you, when papilla is available to us, there is no duodenal stenosis, you are not able to cannulate. So what you do is you get a good scope position and puncture the bile duct with a 19 gauge needle. The position is very important because the wire has to go down. See this position? It has to go down across the papilla. Once the wire is gone out, you remove the EUS scope, put the ERCP scope by the side of the wire, and then cannulate either by the side of the wire which is coming out of the papilla, or you can pull this whole wire into the biopsy channel of the ERCP scope and complete the ERCP. So these are the basic procedures. Now, who should do these interventional EUS procedures? So we published this about 2-3 years back, how to manage interventional EUS procedures. And as you will see, what you need. So this is for pancreatic fluid, this is for biliary drainage, and for pancreatic duct drainage. Can I request people to mute their mics, please? I'm hearing some voices here. So if you see here, you need centers to have multidisciplinary support, interventional radiologist, surgeons, and anesthesiologists. So you have support, you need observation, followed by hands-on training in the patients. If you look at hello, can you please help me with these noises which are coming in between? Somebody's mic is not switched off. Thank you very much.
Yeah.
So training in EUSBD, again, ERCP is very important. So you should have training in ERCP. You should be experienced in EUSBD with 19 gauge needle. You should know the wire manipulation techniques, and you should learn on models, pig or ex vivo models, before you come on to the real EUSBD procedures. Same with pancreatic duct stenting. So if you are planning to do interventional EUS procedures, you should have a multidisciplinary team with you. You should have experience in ERCP preferably, and you should learn on models before you start the procedures yourselves.
यहाँ तक था ना, पहले हम यहाँ तक जा रहे थे.
So we need endoscopist, GI assistant, anesthetist. Olympus, can you please keep your thing mute, please? You are irritating me now. Olympus. Olympus.
I have mute that person already.
Mute everybody. Yeah, thank you very much.
Yes.
So you need a teamwork, you need an endoscopist, GI assistant, very important. You saw in the morning cases, the GI assistant's role is extremely important. He should know what we do. You should also have intervention radiology friends who are ready to help you in case you fail your EUS guided drainage procedures, good surgical colleagues, and of course, excellent ICU in case there is a complication. So all these things are needed before you do your EUSBD. Little bit about the basics of procedure. I told you in the morning, basically it's a modified Seldinger technique. Who was the radiologist? You all know Seldinger technique. He described this technique of passing this wire through a hollow needle. See this? Hollow needle, pass a wire through it, remove the needle, and then you can pass your dilators and stents and everything. So modified Seldinger technique. Of course, now we have the hot stents where all these things are not required, but for most others, you have to do with this modified Seldinger technique. So needle puncture, you saw in the morning, is enough only for injection. You don't need to do anything. You saw in the morning case with gastric varices. If you want to inject something, puncture is enough. But for other things, you need a wire passage, tract dilation, and stent placement. Equipments, again, you saw in the morning, we showed you therapeutic EUS scope, 19 gauge needle, guide wires, dilators, and stents. So these are the scopes. There is a forward viewing scope also available, but most of us use the side viewing, the linear scope, therapeutic scope. This is good sometimes to for pancreatic fluid collection drainage, the forward viewing scope. It's a good scope. For select cases, some people do choledochodeonostomy with the scope. Then, of course, you have the 19 gauge needles, wires. We told you in the morning, you use a Terimo wire or a 025 VisiGlide. A variety of dilators are available. Pre-cut, we don't use anymore. Cystotome, 6-pin cystotome and hurricane balloons are what we use most of the times. Then we have the stents which you saw in the morning, stents borrowed from the ERCP and EUS specific stents. We had a discussion in the morning. Hot stents, good addition, very good for PFC, GJ, gallbladder drainage. EUSBD, yes, you can use hot stents which are shorter, which are 8 millimeter wide, which are not very big. They can be used for EUSBD. Choice of stent, again, we discussed in the morning. So for rendezvous, you use the stents which are used for ERCP. For antegrade, so these are two transpapillary procedures. So you use the stents which are used for ERCP. They are cheaper. But if you go for CDS and HGS, you need to use special stents, which are, in case of CDS, a covered metal, or if the CBD is massively dilated, you can use a LAMS also. For HGS, you need tubular stents. And if you have access to ITOE stent, the IT stent, you can use a plastic stent also, particularly for patients who have benign strictures. There is a question about plastic stents for EUSBD. Initially, around 2003 and 2004, their experience with plastic stents was not very great. So there were perforations, migrations, and everything. Probably the technique was not very much evolved. In India, we have patients who cannot afford anything much, and there is no insurance. So some of these patients, we do use plastic stents, and I can tell you that they are pretty safe, both for choledochodeonostomy and hepaticogastrostomy. We do not have much data, about 30 odd patients, but we believe that probably we gave up on plastic stents too early, and there is not much complication with plastic stents. See here, this is a choledochodeonostomy we recently did. You can put a nice double pigtail stent and it drains well. And the leak, if at all, is not much because we are only using a 6-pin cystotome to dilate. There may be some minor leak with pain for 24 hours, but there is no major leak following plastic stents. I have been talking since morning about scope positions. It is the most important thing for us to learn for interventional EUS procedure, just like ERCP. So you have to practice the scope position. So if you want to puncture segment 2, in the morning we saw it, you have to do it just around the diaphragm, good for rendezvous. If you want to do HGS, go a little bit in and then tip up. This is hepaticogastrostomy, choledochodeonostomy. You saw in the morning, long scope position. Rendezvous, long scope or intermediate scope position so that the needle is looking down. So this is the most important thing. Get a good scope position and then keep that position. How do you know that you are keeping that position? Guide wire is helpful. You should always see your guide wire in your EUS picture. Then you know that your position has not changed because you do not have an endoscopic view. So if your position changes even by 2 centimeters, let us say you push the scope down, your accessories will not go properly. And then you will have to again find a new position. So get a good position, keep that position. If necessary, use your assistant's help to keep the scope in a good position. Some examples, if you are doing a needle puncture, segment 2, segment 3. Yeah, this is segment 2, this is segment 3. The needle is going to come from here. So you have to get a good segment 3 radical. So turn your scope clockwise from here, push the scope a little in, and then you will see a nice dilated radical here. This is our point of puncture. So it should come somewhere here. Do a Doppler, see that there are no major vessels here. Check your scope under X-ray. It should be in a good position. It should be looking towards the hilum, not the other way. Once you are sure of that, then use a 19 gauge needle, puncture here, aspirate bile, and you know that you are in place. Sometimes you will go across. Don't worry too much about that. Withdraw the needle. It's all right sometimes because if you push little hard, you will go across. So see, we inject contrast and we are in this position. This is the stricture, very faintly seen. This is the segment 3. This is the right side. It's a type 1 hilar block. So we have got this information. Now we have to pass a wire from here. So what do we do here? Same patient, we use a J-tip Terimo. See, it goes in the opposite direction. So pass small amount of wire so that you know where it is going. Gently withdraw it. In the morning, we taught you how to rotate the wire with your thumb and index finger. By rotating the wire will go in this direction. See this? It has gone up. Again, pass small quantity. Don't pass too much because then there can be wire shearing. So by using your finger and thumb, see this, how it is moving? By rotating the wire, you have reached the stricture. And then this angle is there. This can be straightened by pushing the scope a little, but I don't like to push the scope. Sometimes you will lose the point of entry. What we do is use a cystotome at this point, and that will straighten most of the things. There won't be much problem once the cystotome is passed. Now the cystotome will stabilize the wire and it can be passed beyond the stricture without much difficulty. See this wire has now gone across into the duodenum. All this needs a little practice. Your assistant has to learn these wire techniques. It's not difficult, only practice. So morning we taught you how to manipulate the wire on a model. So wire manipulation is extremely important. Now see here, in this case, you are in segment 2 here, dilated, and then we pass a needle here, 19 gauge needle. This is very close, so very easy. Aspirate bile. You see this? There is an anastomotic stricture, post hepatico-jejunostomy. Pass your wire across, pass your cystotome across, you are into it. Use a balloon to dilate this area, and then you can leave a plastic stent and keep coming back again and again. Because now you have an access, you can dilate further, you can put multiple plastic stents, just like we do for benign distal CVD strictures. So this also can, this is the IT stent, very, very good, very useful, not available everywhere. Using EUSBD for left duct drainage is a good concept which has recently gained ground. So you start a complex hilar block with an ERCP, place a stent in the right ducts, but if there is still a left duct dilated, you use EUSBD. So you see this position here. This is a dilated radical. This patient had fever. So we use a 19 gauge needle, then a wire. You can see the wire has come in the stricture. You coil the wire here, pass your cystotome here. Try to pass the wire across. If it doesn't go, do an HGS, hepatico-gastrostomy. You can see here, we are trying, the wire has actually gone, but it has gone through the mesh. So no need, you cannot push a stent here. So we did a HGS. See here, this is HGS being done. Put a stent. Again, remember to leave a good amount of stent in the stomach. See here, we are leaving good amount of stent in the stomach. Oh, sorry. Last part, I'll just show you. And this is a nice drainage. The patient recovers pretty fast. So Initially, all the reports have come for distal block, but now even for hilar blocks, USBD is playing an increasingly important role. If your patient has duodenal stenosis as well as bile duct stenosis because of large cancer head pancreas, this is one of my oldest videos, almost 12 years old. Take an FNA, look at the bile duct, do a choledochoduodenostomy, then do a, you can nowadays, of course, you can do a GJ also, but you can put an enteral stent. So double stenting can be done, palliating the patient in the same setting. So these are all the possibilities which are there with EUSBD. I touched upon training in the beginning. Training is extremely important, and I suggest that before you start, you should train on models. A variety of models are available. We will show you one of our models tomorrow. So we have been working for last 6-7 years on a variety of models for interventional EUS, including EUSBD. So this was one such model which we published a few days back. It looks very simple. So you have the stomach, duodenum, bile duct, pancreatic duct, and it has 2 openings, and you can do rendezvous, antegrade procedure, choledochoduodenostomy, hepaticogastrostomy. See, we can do CDS with it, we can do rendezvous. So it allows you to practice the movement, the wire manipulation, the stent placement before you do it in the actual patient. So please learn on the models. There are a variety of models. Professor Kida also has developed some beautiful models. Thailand group has developed a very nice model for EUSBD. Practice on those models. This is our EUS magic box. It is sent for publication. This is all in one. We can do multiple procedures: EUS guided biopsy, pseudocyst drainage, biliary drainage, hepaticogastrostomy. Okay, this is a papilla we have created, so you can go through the papilla, do rendezvous also, and also you can do a GJ, gastrojejunostomy. So all procedures in this one box. So training on models before you start your procedures would be very beneficial to you. How about routine clinical use of USBD in the beginning? Probably you should take the help of somebody who is expert, learn from him, observation, look at the videos that are available, and then learn on models. Only when you do a certain number of cases, you will know the real difficulties. The first 20-25 cases, be ready for issues, problems, but after that, USBD is an extremely useful procedure. And at our center, we are hardly using PTBD, and we have data that in the last 10 years, our PTBD use has declined by almost 90%. We hardly use PTBD only for complex hilar blocks. So endoscopists can drain the bile duct with ERCP and EUSBD in almost 99% of cases. You will probably need PTBD for about 1% of cases. You use EUS RV. If your cannulation failed, don't send the patient direct for PTBD. Use EUS rendezvous, it will be helpful. And of course, patients, if they have duodenal stenosis or post-surgical anatomy, you can start EUSBD first. Try with EUSBD first before sending the patients for other procedures. I think this should be my last slide. Thank you very much.
Thank you so much, sir. It's always enlightening to share your, to listen your presentations. And now we will move on to the next session. It will be live demonstrations of cases from Asian Institute of Gastroenterology. I would like to invite Dr. Sandeep Laktakia for the live cases demonstrations. Welcome, sir. Thank you, sir.
बोल Sandeep, are you ready? Okay, till Sandeep becomes ready, let me answer some questions. Dr. Ong has asked me, can we use plastic stent for EOS BD? Yes, Dr. Ong, you can use plastic stents. They are not as complication creating as has been, it is my personal experience. Uh, but you should be good with your procedure, and if you feel comfortable in doing an EUSBD, you can use plastic stents in cases where metal stents are not available or patient can't afford metal stents. Dr. Adil Rahman is asking, what are the tips and tricks to minimize bile leak? So I think bile leak is overhyped during EUSBD. I hardly encounter it. It's only if your hepaticogastrostomy stent migrates or it is not placed properly, you will have a bile leak. Or if your choledochoduodenostomy has migrated or not placed properly. So if you have placed a stent properly, bile leak is not going to happen. If you do encounter bile leak, that means something has happened to your stent. It is not well placed. For HGS, which segment is best? Chi Wong Chow is asking. For HGS, it's always segment 3. We never use segment 2 because if you use a segment 2, you will probably end up the stent being in the terminal esophagus, which we don't want. So segment 3 for HGS. What patient position do you prefer? So we start with left lateral, but once we are in position, we turn the patient supine and we do the entire procedure in supine. Soon Liang Li is asking for HGS after cystotomy tract creation, how long do you dilate the tract with 4 mm balloon? So I do not dilate the tract. I place the stent straight after a 6 mm cystotome placement. But if you have to dilate with a 4 mm, if you like it, you dilate it for probably 20-30 seconds. You don't need to dilate it for very long. We are waiting for Dr. Sandeep to start his live demonstrations. Sandeep there? Sandeep has lots of good cases today. He told me there are some 7-8 cases he has. Let us see what all we can see today in this time. So he has multiple pseudocysts, he has a hepaticogastrostomy, he has a necrosectomy, lots of great cases. So Sandeep, yes, I can see you now.
Okay. So good afternoon, everybody, and thank you for joining. Thank you, Vinay and Rajesh Puri and all the people who are joined from India and abroad. Let me introduce our team today before we move forward for this interactive live cases. On my right is Dr. Jahangir Basha, a very important person. You will see him more and more in the future. We have Dr. Mohan Ramchandani, a stalwart, and my very close friend and colleague here, Dr. Rajesh Gupta. Together, 4 of us, and Dr. Rakesh is outside. He'll be joining us in between. We are very ably supported by our anesthesia colleagues, Dr. Santosh, who is the senior most member of the team, Dr. Srinivas, Dr. Upinder God, and few others in the other room. And the rose in this group is, is Dr. Anuradha, our chief pathologist at Asian Institute of Gastroenterology. So we'll start with the first case without wasting any time. Jahangir, over to you, please.
Okay, Jahangir, what is the case?
Good afternoon. So she is an elderly lady presented to us with progressive jaundice and also weight loss for the past 1 month. So on evaluation, her lab parameters were showing she had obstructive jaundice, and CT abdomen showed there is a mass in the pancreatic head region with the joining of the CBD. So primarily we are dealing with a mass in the head of pancreas. which presented as obstructive jaundice. So here I am using a linear EUS scope so to evaluate the cause of jaundice and also to confirm the mass, and probably will take FNA also.
If anybody has any questions for Dr. Jahangir Basha or Dr. Sandeep, please post it on the chats and we will answer all of them.
So gently I had passed the scope. So you can see the endoscopic image. So the scope is already in the esophagus. I'm slowly going into the stomach. So there is some liquid residue here. So first we need to suck all the liquid. Otherwise there would be some aspiration issues. So first I will start examination at the GE junction and I evaluate the cause for jaundice, and I will show a little bit anatomy and the scope maneuver technical details, and after that we can go into the duodenum to take the FNA. So you can see here, so this is the endoscopy. I am at lower esophagus and now I just crossed GE junction. I kept my scope at the cardia. So when we keep the scope, linear US scope, in neutral position, it is almost in straight position. So when the scope is in the straight position, invariably the transducer faces anteriorly. So can we see the, yes, can you see here? So my scope is straight here in neutral position and the transducer is facing anteriorly. So anteriorly we have left lobe of the liver. So here also we can see this is the left lobe of the liver. Just behind it, this is the dome of the diaphragm. We can also see the cardiac pulsation. So heart, diaphragm and the left lobe of the liver. So that means the transducer is facing anteriorly. In this neutral position, if I give a clockwise or anti-clockwise movement, I can rotate the transducer towards the posterior side. Either clock or anti-clock, we need to give 180-degree torque. So here we are giving a 180 degrees clockwise movement towards the right side, and while doing this movement we will see two important landmarks. The first landmark is porta and the second landmark is IVC. After that we will reach the aorta. So let me show this movement. So we are facing, this is the left lobe of the liver. You can see the clearly segment 2 and this is the segment 3. And if I do a little clockwise movement here slowly, this is the hepatic vein, and on further little bit clockwise movement, you can see this is the porta. Can you see the porta here? So this is the porta. I'll freeze the scope here, picture here. So this is the porta and this is the portal vein. This is the CBD. CBD is looking very much dilated here. So this is the first landmark after seeing the left lobe of the liver while doing a clockwise movement. So I'll do a further clockwise movement. So this is the porta again, and you can see this is the IVC. Can you see the IVC? This is the IVC. So only a gentle clockwise movement from the porta, we can see the second important landmark, that is the IVC. So the arrow is looking towards the IVC. On further clockwise, we can turn the scope towards completely posterior aspect and we will see the aorta. So that means we are looking towards the posterior side. Here I'll show this movement again. So here now I'll show the anti-clockwise movement. Again, I come back to the anterior position. Aorta, you can see the IVC and you can see the porta. And again, we'll come back to the left lobe of the liver. So this is the movement that is very important at the G junction, where you can with clockwise movement can evaluate the entire liver, porta, IVC up to the aorta. Further examination can be done in two ways. We can trace from the porta station or from the aorta. So I feel from porta it is more convenient and more important. We can see many structures and we can demonstrate the anatomy very well here. So I'll focus the porta here and I will follow the portal vein. So once the porta is in, portal vein is in the picture, a slight push, we can come towards the pancreas. Yes. So this is the pancreas. The arrow is pointing towards the pancreas here. And you can see the small lymph nodes. And here we'll keep the portal vein again back into the picture. A gentle clock and anti-clockwise movements are important here to evaluate the complete anatomy. You can see the grossly dilated PD here. So this is the PD grossly dilated, and there is some echogenic material inside the PD due to obstruction. So this is the pancreatic duct. And you can see this is the, just behind it, this is the portal vein. Yes.
The portal vein and the PD.
Yes.
Taking a turn around.
At the level of genu, it is taking a turn and it is going towards the head region here. So at this position, you can also appreciate the pancreatic head behind the portal vein. You can see now this is the pancreatic head region, and we can also appreciate the mass here.
Yeah, that's the mass. That's the mass.
So this is the mass in the pancreatic head region. We can evaluate from the gastric station only by focusing the portal vein, and just behind the portal vein we can see the pancreatic head region also, and that is the mass. And in the same image we can appreciate, if I put a Doppler, you can see here this is ductular structure not taking Doppler, so this is the CBD. So this is a dilated part of the CBD which is actually going towards the head region, and in head region it is getting blocked. So from here we have evaluated the portal vein. Tracing the portal vein, we had seen the pancreas, we had seen the dilated pancreatic duct, portal vein, and also behind the portal vein we had seen the pancreatic mass, and the CBD is also getting blocked and dilated. Keeping the pancreas in focus, if we can do a clockwise movement, we can evaluate the rest of the pancreas, and we can go towards the, this is the kidney and this is the spleen. But if you see anterior to kidney and spleen, we could not see any pancreatic tissue. That means the pancreatic body and tail got atrophied here. And I am coming again doing anti-clockwise, and I am coming again towards the genu of the pancreas.
That's very nice demonstration. So would you like to go to that duodenum to take it from this mass?
Yeah, I feel the better would be it will come close to the first part of the duodenum. So from here I'll pass the scope into the duodenum, and from where we can see the tumor in detail, we can evaluate and we can take the FNS also.
That's a very important thing that you showed, Jahangir, that you can see the head of the pancreas and very vital structures from the stomach itself. Although for taking FNA, we would not like to go through these vital structures and take FNAC directly from the duodenum.
Yes. Now I passed the scope to the first part of the duodenum. You can see here, this is again the dilated PD, and it is completely filled with this sludge. Yes.
It may be tumor also. We saw the mass, or it's just a sludge because of chronic obstruction.
Yes. Or it can be, as said, infiltration also. And here you can see on gentle clockwise torque, you can see this is the, I'll freeze this image. This is the bile duct, and this is the mass.
What
So let's,
is this, something this behind? What is this?
I'll put a Doppler here.
Yeah.
I think this is the portal vein with some thrombus.
That's one possibility. Although since it is not taking a color here, but it is taking from the stomach, so this is possibly a very low insertion of cystic duct.
Yeah. This is most important. Another point, because this is something I need to trace it further.
Yeah.
And I need to reconfirm it.
It's coming here. It's entering in this part of the CBD.
Yeah. So in a single static image, it is difficult to comment, but we need to look at the course towards the proximal and distal side. Here it looking like it is joining the CBD. So maybe it is a cystic duct, as Dr. Sandeep sir said. And it is also not showing the Doppler. That is also one more point favoring that it is a cystic duct. And this is completely filled with this sludge.
So now you see the portal vein behind.
Yeah, on further evaluating, we can see the portal vein here, posterior. Yes, correct. So we can see the CBD, dilated CBD, the cystic duct filled with the sludge, and also the portal vein posterior to it. So let's concentrate on this mass. So you can see the CBD is completely narrowed and compressed by this mass here, and both CBD and cystic duct actually looking together blocked by this mass here. So we can put a Doppler here. Yes. So this is the mass looking relatively big in size. We can measure the size also.
So never go by one view of any EOS structure. I think it's best to have a cine view
Yes,
where you
yes.
can see different views of the same structure from different angles, which will give you a better interpretation of what you're seeing. Like the cystic duct, which is grossly dilated, has a low insertion, which Jahangir nicely picked up, is a little alteration in anatomy.
Yes. So that is atypical anatomy, but that also can be traced with the EUS and we can reconfirm it. So this is relatively a big mass, which is almost 45 mm in longitudinal and about 2 mm, 20 mm, 2 centimeters in.
So you're in long position now, Jahangir. Would you like to do FNA in this position, or you would like to shorten the position?
So
Whichever
here,
you're comfortable.
here it's looking straight.
On,
so
yeah.
I feel FNA doing from this long position also may not be a problem. And more importantly, scope is in stable position.
Correct.
So I'll try to do FNA from here.
Okay. Okay. So what is your preference now? You would prefer a needle or a core needle?
So what I'm thinking is we'll take a FN core needle,
Okay.
so that we can get a biopsy. So we'll take 22 needle
22
from
gauge.
22 gauge
The Boston
acquired
Scientific
from
acquired
Boston
needle. Okay.
Scientific.
But we'll also do a immediate cytology. We want to take advantage of Dr. Anuradha, who's here in the room, to give us an immediate cytology. So that's our routine practice of having the cytologist in the room, most often if possible, to get the immediate answer. Although these core needles are very efficient and give a good amount of tissue. And also you get architecture.
Scope is falling.
Scope is slipping back, yes. Sheath is more out. He's adjusting the sheath length.
Yes.
And then now that it's out, okay.
So this is again the pancreatic duct, and this is the CBD, and you can see this is the mass. So from here,
it's a very nice demonstration. Very nice. Picture is very clear. You want to hold it?
hold. Yeah, since it is getting slipped, I'll keep in the long position. We can check with the Doppler. There is some vessel here.
The one in the duodenal wall, which looks to be
It's like a
prominent,
small.
but you can avoid it, I think.
Yes, we can avoid it. First, let me check the trajectory of the needle. So needle is out. We can see the sheath here.
Yes, we can.
So this is the sheath just coming out of the scope, and it is close to the duodenal wall. So I'll adjust the sheath here.
I'll keep pointing you, just focus on the FNA.
Yes. So you can see this is the Doppler. We did not find any vessel. I'll lock at this position. Now I'll adjust the length of the needle. I kept at 3 centimeters. What I intend to do is I'll do a slow pull technique here. So you can see the needle.
Stop the Doppler.
Yes. Now you can see the needle nicely, and we can take the FNA. So you can see the needle has well into the mass. I can go a centimeter down also. Yes, this is the tip of the needle. We can go inside deeper also. Push the stiletto inside. Okay, now we'll start taking the passes.
Come here, I think maybe a little deeper, maybe better.
Jahangir, if I may suggest, push a little more. You are just
Yeah. You can see this is
large tumor. Yeah, perfect.
Yes.
So arrow is my target. Yeah, that's right.
I think we are deep inside.
Duodenal wall is getting pushed. You can see there, the duodenal wall is getting pushed. So,
yes, you can see now the needle is deep. So we need to exert pressure here because the duodenal wall is getting pushed. And I'll ask the assistant to hold the scope tightly so
Very,
that,
very important. Yeah.
yes, push. Yes. So now I think we can take FNACs. Yes.
Generally 4 to 6 movements with a core needle is good enough.
Yes.
Excellent. Very nice.
So I'll try to do some fanning, though it's a long position, but still fanning is possible here. Yes.
It's a re-entry.
Yes, almost.
Okay. We'll also show you how to stain and handle the tissue soon after taking a tissue during FNA. So Dr. Anuradha will show that part as soon as we get the pass gets over.
Yes, you can see this is.
Should be okay.
Yes.
Should be okay.
I'll take 1, 2 more.
He's used to Anuradha's request of getting more tissue. So always pathologists want as much as they can. So, okay.
Yeah.
Right.
Okay. So I think that should be fine.
If need be, we can come back again.
Yeah, we can show one more pass also.
So with that we can take a decision.
Okay. So that is the first pass, and we'll try
so if the cameraman can now focus on the slides on the table where Dr. Anuradha is.
So we'll make the slides and we'll see.
Come closer to Dr. Anuradha's table. Yes. And although majority would go to cell block also, core biopsy, but you're putting a drop on each, right? Yeah. And it is a big thread there. Wow, it looks white here. Yes. Come closer, okay. Just make the next slide and put it on against your gown. So then yes, with a long fragment also there. So white tissue is a pure tissue. Whenever you see that one pass is generally good enough.
And we can see the core material in the bottle also.
Yeah,
can you see the bottle?
The cell block material.
Put against your dress.
Yeah. So, yes, we can.
Can you see?
No, just focus that. Focus, please. Focus.
Camera focus.
Focus.
Every pass, it is advisable that we make 2 slides and deposit the rest in the cell block. So the first 2 slides would be the best to evaluate for cytology because it would have less amount of blood material. And the rest, even if it is surrounded by blood material, once you deposit in the formalin and it settles down, we can get a good biopsy. It's almost equivalent to a good core biopsy.
Thank you, Anuradha. So you'll stain the slide.
Yes, I will stain with the quick stain.
So what we will do now is move to the other room where Dr. Rajesh Gupta is ready with the second case. If the first slide pass does not give an answer, which I don't think so, Anuradha has good white tissue, we should get that answer.
Yes.
And Jahangir meanwhile will hold the scope here and see how and based on the first pass results, we'll take a decision on the second pass. Over to the next room, Dr. Rajesh Gupta.
Thank you.
Good afternoon, everybody. Can you hear me? Can I have the slides, please? Dr. Dhir, can you hear me?
Nikal do, sir.
So we have this gentleman who is 45 years old.
Clearly.
Okay, sir. Can you hear me, Dr. Dhir?
Yes, we can hear you clearly.
Okay. So good afternoon, everybody. And so this second case is another interesting case. So Dr. Jahangir has nicely described the anatomy of how to assess the landmarks and basic technique of FNA. So now we move on to the next indication, and that is very commonly practiced indication that is drainage, pancreatic fluid drainage. So that's here is a gentleman who is 45-year-old male who has acute pancreatitis. He's symptomatic for last 3-4 months, and he has a large collection and is symptomatic. So obviously he needs drainage. So now there are plenty of data. So the US guided drainage is the best technique for drainage these kind of collections.
Hi Rajesh.
Hi, good afternoon, sir.
Good afternoon. Hi, Mohan. Nice to see you guys.
It's a pleasure, always a pleasure to hear your voice, sir.
Okay.
So we were late. It is always a advantage with an expert like Dhir being around, so he will continue to guide us through this procedure. With me is Dr. Mohan, my another very competent colleague, and he does these kind of procedures. So we'll discuss and keep asking questions and doing this thing. So what we see is, first thing is when we know this patient needs drainage because it's a large collection, is symptomatic, and any patient who has a large collection it needs drainage. So what technique we use? We use US guided. You can do direct puncture. Earlier we used to do direct endoscopic drainage.
Yeah.
For these kind of bulging cysts, you could have very well argued that this could have been done directly endoscopy guided. But now we have ample of data which suggests that US guided drainage is the safest technique, because you can choose the point of puncture, because earlier when you are seeing a bulging cyst, you don't know where you are puncturing, whether you are avoiding the vessels. That's another concern. Second important thing is, so you can decide, you can see simultaneously what is the quantum of the debris. That is another concern, because when the bulging cyst is there, that could be clear cyst also, it could have a lot of debris also. But when we are doing US guided drainage, we know how much debris we are dealing with, whether the patient is going to require subsequent necrosectomy or not, because these are important questions we should answer, and endosono guided drainage is the best technique. So before starting, so I'm using a Olympus scope, which is a 180 series linear scope. And obviously any drainage procedures is essentially a 4-step procedure. Now with the new hot devices, we can use single device also, but that is not cost effective for our setting. So we still practice needle, we use needle, puncture the track with a needle, that dilate the track, and then graded dilatation, and then deploy the stent. So these are essential 4 steps: puncturing with the needle, putting a wire deep inside the cyst cavity, making a big coil, preferably 2 or 3, and then you dilate, graded dilatation, and they deploy. These are essential 4 steps. So now what I am seeing is there's a huge collection. I am into the stomach, and you can see, appreciate this is a large collection. The problem with these large collection is another, we cannot freely manipulate the scope inside the cavity. That is a big challenge. So the problem with these kind of collection is sometimes we can underestimate the quantum of the debris. One, secondly, and we cannot see all around, but try to go around and have a quick look how it looks like. So I'm going under vision, and we have seen there is a large collection. Now I'm going towards the duodenal bulb. So now I'm in the duodenum, and now we'll start seeing the visualizing the anatomy from duodenal bulb. You can see the right kidney right there, and it is occupying the whole screen. Now we'll slowly go down, further down, and just like our ERCP, I'm going to have a quick look how the head of the pancreas looks like, to see how. So slowly, this technique is essentially just like doing ERCP. I'm manipulating my scope under vision slowly, and then start pulling back.
Yeah.
So the structure you here.
After nikal do yaar.
After I'll remove.
Yeah.
Now beautifully seen.
Yeah.
So now we can see this is the head of pancreas, and now you see the little bit of pancreas is visible now slowly, and now you see this collection starts appearing right here from the head itself, and you can see a little bit of debris, and it's compressing and going towards the body area.
Yeah.
And the CBD is compressed because the collection is so large. I cannot, visualize all the structures very clearly because it's causing compression. Now slowly, I'm pulling back. Now we see this collection has started appearing, which is almost obscuring the whole of the head of the pancreas and even the body of the pancreas. And this same collection looks like, or whether it is communicating with the previous collection or it's separate, it looks like it's the same collection. What do you think, Mohan?
It is same collection, but let me check.
Now you see, now you come out in the stomach, and now almost this thing this is going further down.
Yes.
I think it's the same collection. Now we are almost at the same position where we started, and now we go a little clockwise to evaluate how the other things are with the tail because this is very, very likely. This is the spleen we are seeing. You can see the fluid also.
Subdiaphragmatic.
Yeah, subdiaphragmatic collection also. So it's a fairly large collection. I feel it's the same collection, which is too large and it giving a false appearance of double collection also. And in addition, there is a ascites also. And since there is I can see the PCD catheter inside here. So it means that it has already been done. We must have significant ascites. So the question now here is, we start dilatation, we have to drain it. So as first, we see that it looks a very clear kind of cyst.
It looks like clear.
It looks like a clear kind of cyst. We can use plastic stent also. But as I said, sometimes there could be an underestimation of the necrotic tissue. In that situation, it is better. I would like to use a metal stent so that I can do subsequent procedures also. The other problem what I anticipate is an alcoholic. He has lot of alcohol consumption. I don't know because what is residual pancreas looks like. Because that other problem, it is possible that this gentleman might have some varices also, some kind of, then it is a long-standing compression. So there could be some collateral.
Yeah.
So the other advantage of putting metal stent is if I puncture the wall accidentally, any collateral, it can cause tamponade.
We saw some collateral while you were entering.
Yes, yes.
So what is, so you got a very good window at G junction, very good window in the mid gastric body. So where will you puncture? What is the best? Do you keep in mind that subsequent entry into the stent should be okay, so that you choose appropriate point of entry, or you just do puncture anywhere you want?
No, that's very important question. Before deciding the puncture, I had two considerations in mind. One is my scope position should be as straight as possible so that I can do the exchanges easily.
Yes.
That is one. But the problem is sometimes we end up deploying the stent a little higher up, which may subsequent
entry is difficult,
but it is manageable.
Yeah.
The second important thing is avoiding the vessel. That is the biggest advantage what we use with the endosono technique. So I feel this is the advantage of fluoro also. How the scope position looks,
so very straight position. So
and I think this looks like a good point to puncture more.
And do you check for the G junction whether you are below G junction?
Yeah, you can.
Obviously, we are seeing on fluoro.
We are seeing on fluoro.
Do you see endoscopic image anytime, or you?
No, generally I don't want to see endoscopic image because it distorts the anatomy if I put too much of air. Here in this patient, it is because it is too large, it is causing compression. So sometimes, the manipulating the scope is a little challenging in this situation.
And do you put Doppler to see the wall?
Yes.
So we'll put the Doppler and see the wall where is the most avascular zone.
So the first step we are going to start, I have selected, I am going to start this, I think this.
Okay,
so I am going to use a 19G needle, because for all therapeutic procedure we use 19G needle. This is a Cook needle, and it has the advantage because any needle can be used as such. There is no specific like this, you have to use only this needle only, but this is the needle which is commonly used, so we continue to use this needle. We find it extremely usle.
Sometimes there is a fear that you may do a double puncture, like a cyst cavity which is in the duodenum, attached very close to duodenum, and if you puncture from antrum, you made a double puncture and it caused perforation. So how do you avoid that?
So that is what we have to see. We have to withdraw, do the maneuver. So we should not see the double wall over here.
Yes.
Because if you are able to, you are seeing the double wall, means then you should not puncture.
Yeah, sometimes the cyst is so big that double wall, even it looks like a single wall.
Yes.
It happens.
So
one has to be very, very careful.
This is another important trick.
Satya, hello, Rajesh, just hold on for a second.
Sure.
Anuradha is ready with a slide. Before you start the puncture, can we come back to the same room one where FNAC was done? Hello? Anuradha?
Yeah. Yes.
Okay. So, Vinay, can you see the slide on the screen?
Yes, wonderful.
Yeah. So,
Anuradha, please go
yeah. So this is the low power image of the cellular smears that we have received. I will just go on to the next magnification. So can you see that there is increased cellularity of these cells and they are in disordered sheets and small clusters. I will still go to the next higher magnification of these images. So here you can see that there is loss of the normal monolayered sheets of the pancreatic ductal cells and there is anisonucleosis. And as we still go on to other areas, you can see there's a lot of cellularity and you have single cells as well. And I will just go to this in still higher magnification and you can see that there's marked anisonucleosis. Just a second.
Vinay, the beauty of this microscope is this is in the EUS room, and this is actually a remote controlled microscope, which I'll show you close up later on, which Anuradha can operate sitting in the other building from our room.
Yes, I have seen it. I was there. It's wonderful.
So if you can see here, so these are very large bizarre cells. It fits into a positive for malignancy. So Dr. Jahangir gave us very good material in the first slide itself. And you can see that there's a lot of material. Once we have stained, you can see how cellular it is. Yeah. Thank you. Thank you.
Anuradha, thank you very much. That was great work. Thank you.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you.
Fantastic presentation. Very, very nice show.
Go back to the previous other room, Rajesh.
Welcome back.
So before you start, Rajesh, there is a question here.
Yes, sir.
Frequency of pseudoaneurysm, and do you do CT angio before?
Generally, we don't do, Dr. Vinay, until unless if the patient has bled before. Say, for example, somebody comes with melena or upper GI bleed, then we ask for CT angio. Otherwise, we don't. We ask for cross-sectional imaging, and we definitely do US screening before drainage, whether the this patient collection is good enough for drainage, mature enough for drainage. So these are the precautions we take. But we generally do after drainage sometimes. But if the patient are definitely bleeding, then we definitely do that. Okay. So now I'm ready with the needle. So as I said, I'm using a 19G needle from Cook, and this I think is a relatively avascular area. It's a clear bulge, and my scope position is also very straight. So I feel this is a good site to puncture. So you can see the needle popping out. So just can you appreciate the needle?
Yeah.
Beautiful. Very nice.
So this is the first step, and now we'll make big coil of guide wire inside this cavity, and we aspirate first to confirm what kind of collection it is. It is a dirty black. Can you focus it on the collection? It's aspirate the cells. It's a standard like what we see in the pancreatic collections, the dirty brown. So this is the wire I'm using a VisiGlide wire. You can use any good wire, but we use VisiGlide. So this wire has to be coiled. At least you make two big coils inside the cavity so that you don't lose access. The other important trick is you have to always try to keep the needle track in focus, wire in focus. Don't try to move it too much. Sometimes it doesn't, try to control it that way, it doesn't move. Fortunately, in these patients, we don't have to worry too much because it is a very large collection. But sometimes if the collection is not so large, it may create problem. So this is the first step. My needle is there. And now I have the second step. I'm heading toward the second step. That is third step, basically, to dilate this tract. So what we use is we use cystotome. And then because we are trying to deploy a metal stent, so there is not large dilation is not required. If we are using plastic stent, we have to dilate bigger, 12 to 15 mm. But here we just, because we have to deploy the metal stent, which has a 10 French delivery system. So 6 is enough. So I'm going to use a cystotome, 6 French cystotome.
Rajesh, I don't see the wire on the ultrasound image.
Okay, you can't see, sir. Okay, because it is there.
I think it is drowned in the volume of the
because
pancreas.
it's a bit
very large cyst. Okay,
Very
I get
large.
it.
it's a very large.
We can see now, Dr. Vinay, we can see a bit. Then it disappears in the cyst.
Because it is wall is also because of compression.
You can see on fluoro also.
Can you give the fluoro simultaneously, please?
Yeah, if you can give fluoro, oh, beautiful.
So now you can see the cystotome coming out.
Yes.
So,
You are in?
Yeah.
No,
No,
not
no,
yet,
no, still
not yet.
not in.
Now the wire is in beautifully.
Keep it pressed.
Beautifully. Yeah.
So you can see the cystotome has gone, though I thought it is very thick, easy to punch, but the dilatation was a little tricky because it was pushing the wall a little away. So anyway, I have punctured it. I have done 2-3 times so that it doesn't. Now I will definitely do a small dilatation with the balloon also.
So Rajesh, do you intubate in such patients who have very large collection?
No, no, sir. I am not intubated. It is just propofol sedation. And generally we don't intubate these patients in our unit. But suppose if you feel that the patient has a risk of aspiration in some centers where the expert anesthesiologists are available, because it is a little challenging to intubate these patients.
Yes.
So now I'm going, because I had a little difficulty in passing this cystotome over the wire. I will like to dilate with a balloon, and I'm using a 6 mm balloon.
So there is a question again for you, Rajesh. What cautery settings did you use for the cystotome?
One, can you show the cautery?
Yeah, so we always used pulse cut fast, but you can use pure cut also, as we do for any puncture. Depending on, because there is no much vascularity here, we have used pulse cut fast. You can also use endocut I on this because this is a needle type of accessory. So always use endocut I or pulse cut fast, depending on the cautery you are using.
Okay. There is another question. So if you use plastic stents, Mohan,
yes,
how many plastic stents do you put in this kind of fluorescence? That is the question.
So the plastic stent, we usually dilate up till 1.5 centimeter, then put a accessory which can accommodate 2 wires, either 10 French pushers, or use a loop wire from Wilson Cook to pass the the 2 wires, and then put 2 stents. We don't put more than 2 stents
Other
usually.
technique is you can use a large cannula after dilatation, and then you can put it.
Yes.
So now you can see that, Dr. Vinay, that balloon, you can see that across the gastric wall, it has caused dilatation.
Very nicely seen. Yes.
Yeah. So deflate, please. So because at this step, basically, I don't want to change my position, because the problem is there may be a little bit of gush of fluid, and it will be, the view will be obscured if I go away from this area.
So, Dr. Ragesh, when will you switch between endoscopy view and
at the final deployment, Mohan, at the final stage of deployment. The initial step I do all under endosono guidance, so that I don't move my position, because I don't want to lose this position which I am holding.
And as you see, Dr. Rajesh has just rotated the scope to bring the wire in his picture. That wire is our lifeline. You can see now right under the arrow, there is a wire there.
Because that is very crucial. That is very crucial.
If this is under your probe, you will never lose the access. So always keep a position such that this is the marker, and this is a very beautiful image where it says that we are totally under control.
So now I am doing the final step, that is for the deployment of the stent. The same step, wire should be here under vision, and you have to, and I've already dilated, so I don't anticipate any problem here. But the problem is the position and keeping the scope steady over there. That's a big challenge, because it's a very large cyst. So it has gone inside.
Rajesh, 2 or 3?
Yes, sir.
Is it a 2 centimeter or a 3 centimeter stent?
2 centimeters, sir. 2 centimeters. So you can appreciate the stent is visible in endoscopically also.
Yeah, we can
and
see.
you can see in the endosono image also.
Yes.
So you please deploy.
Yeah.
Deploy, please.
So
You can see the inner flange opening nicely. So now the technique is I will pull against the back wall because this is short stent. Pull. Yeah, yes.
More.
So now we'll switch on what you were saying.
Yes. So we'll switch to the endoscopy picture
image.
now.
You can see.
Okay.
So slightly, I'll go a little away.
So what is the technique now? You're
Yeah,
just
so
pulling and
pulling
rotating
through,
your
yeah,
body
yes.
to the
Okay.
anti-clockwise position.
pull,
You can see now. Very nice.
Beautiful. Very nice.
So you see, anticipate the big gush of the fluid because it's a very large cyst. So the other thing what I'm going to do is I'm going to deploy a plastic stent, sir. So here the advantage of putting a plastic stent, it will avoid the clogging of the stents. And sometimes what we have observed, it leads to clogging of the stent.
Yes.
And also the back wall usually is kept away from the sharp edges of, that is a theoretical thing that.
So the bleeding risk,
yeah.
what with theoretical risk of bleeding that is there, that will not be here.
And also when in the situation of ductal disconnection, you can selectively remove the metal stent, keeping the plastic stent in situ. That can happen if you are doing MRCP after complete drainage of wall of necrosis. And then by the time you remove the metal stent, if there is no plastic stent in situ, you may not get the cavity. But if you have a plastic stent in situ that can be kept there and using a double channel scope, you can easily remove the metal stent, keeping the plastic stent there, which can be like a conduit for drainage of the
You see
disconnected.
now there's a huge gush. And
Yeah, we can
almost
see.
now it is hardly the view is getting obscured. And what the point you, Dr. Vinay, you raised that these patients can aspirate. So generally sometimes we put a nasogastric tube to aspirate, or we suck a little fluid, wait while after we drawing the scope, or we can wait for some time.
You can see now the plastic stent is being deployed. It has gone in, and the marker is very important here.
Where
You
is
can
the
see
marker?
under limited vision, you can see now under fluoro, the tail has formed into the cavity.
Yes.
And then you'll just slightly push slightly more. Yeah. Now you can see he's removing the wire. Pigtail is formed inside the stent, and now he'll push it out. No, it is there. It is there.
No, it is nice. Very nice.
Yeah, it is.
So it is too large actually, Dr. Vinay, because it causes comfort also. It's a cause of concern also, because sometimes the gush of fluid which causes it is difficult to see.
Yeah,
So
an anesthesiologist is having palpitation now.
So my anesthesia colleague is, but he is very calm. He's not even asked me to stop or saying, thank you, friend. So it is because that's the advantage of having anesthesiologist bedside, and you need not bother and you can focus on the procedure directly.
Yes.
So with that, I think, Mohan, I don't think it is a double. Dr. Sandeep was thinking that we should demonstrate a double multi-gate technique. I don't think we
I don't think so. Yeah, it's a single large.
So because once it doesn't collapse, or if we find that another, because that's possible, then maybe we can consider after 48 to 72 hours.
And we did not find many debris also.
Yeah. So far.
So
but
multi-channel.
this what we have seen quite often, that once these large collections are there, the debris may be adherent and which may unmask once this liquefied content comes out.
So Dr. Vinay, when do you consider multi-gated drainage?
I have hardly used it, probably twice in my life. It is rare. Most of the times, as you saw today, the cysts are communicating.
Yeah.
I normally place one, and then if there is a evidence that there is an ongoing infection, I put a second. So never two in the same setting.
The only problem is that once you are doing in two different sessions, by the time you do one decompression, whole of the fluid is gone. So either you have to plan it on the day one, or you may not get the opportunity to do the.
But generally, I agree with Dr. Vinay, with you, because these collections, those are large, they appear to be separate, but in fact, they are communicating at some point, because sometimes we are not able to demonstrate very clearly.
What happens is sometimes the communication is small, not very big. So there is one last question for you. When will you remove this stent?
So we remove this stent after 3 to 4 weeks as a policy. And if suppose this patient, fortunately, he should not have any issue as such, because it doesn't, debris is not too much as per our assessment, but we'll keep it under observation for 48 hours. If this is asymptomatic and the collection size decreases significantly, I mean less than 50%, we'll send him home, get him back after 3 weeks and remove this metal stent. The other thing is, if suppose the patient starts getting symptoms or he doesn't settle down, he doesn't continues to have fever, discomfort, probably there is a stent dysfunction, then we go in and put necrocystic drains across this stent. Or second thing is, if still there is a problem, what we call the step-up approach, we do necrosectomy. And we can do the advantage of these fully covered stents or the dedicated lamps is that you can go in easily with the scope and do necrosectomy quite easily. That is the biggest advantage of these stents these days we have. And the third thing is, once we have to complete the necrosectomy, we remove the stent. And lastly, as you said, if the patient has any GI bleed or any loss, drop in hemoglobin, then we do CT angio and to see whether aneurysm formation is there or not. But fortunately, with these kind of stents, with Nagi stent, our experience, more than 500-600 cases we have done in our unit now. So we have not experienced a stent-related aneurysm formation in these patients. Unlike which has been reported with hot axios, maybe the flanges are very soft or their flanges are very sharp. Probably they are causing injury, but we don't know exactly. But fortunately, we are not.
Moreover, the stents are movable. This stent is movable.
It's very soft.
Do you do MRCP routinely for looking for PD disruption? One question.
Not routinely, Dr. Vinay. We don't do routinely this MRCP. We at the time we do cannulation, pancreatic duct cannulation.
Hello.
But sometimes if we feel that it's not, we don't do. But we don't, as a policy, we don't do a routine.
Yeah. So one more question. Are you ready with the next? Okay, go ahead.
Okay. So thank you, Dr. Vinay.
Thanks, Rajesh. Fantastic demonstration. Thanks, Mohan. Very, very nice.
So Vinay, hi.
Hi.
Welcome. So we move on to the third case. Before I move on, I will introduce some of the other team members which were not in the morning. We have Dr. Azim, a young colleague, a very active US enthusiast. We have Mr. Srinivas, a very important person who handles a lot of wires. And another important person, Dr. Upinder Gaur and Dr. Srinivas, they are the anesthetists. They are taking care of sedation. If the cameraman can focus on the patient. So this patient is on, as you see the history, this patient has obstructive jaundice and it has proven to be carcinoma gallbladder with type 1 block, and ERCP has failed because of difficulty in cannulating, not duodenal infiltration, but difficulty in cannulating. So this is the dilated IHBRD, and plan is to do EOS guided biliary drainage, probably hepatogastrostomy, or we'll take on how it goes forward. So let's have the room view, and can you focus on the patient? He's on a prone position, and can you make the head low? So this machine has a facility to have a head tilt low, and that's an advantage of all EOS interventions because the fluid gushes out, as you saw in the previous case, and keeping the patient head low, all the fluid, even if it vomits out, will come out of the mouth into the kidney tray kept next to it. Can you make it flat now? So we hardly ever intubate our patients, unlike some of the Western country where they always intubate. It saves our time in a busy unit because intubation and extubation also takes time away, during which I think 1 or 2 cases can get done. So you have the EOS image there, Vinay?
Yeah.
So this is a left lobe of the liver, as Jhangi showed in the first case, IHBRD, dilated segments. So this is the lower or the left half of the screen is segment 3. And if I turn a little bit, you can see the segment 3 is dilating up, going up. towards the left hepatic duct, almost like this. And segment 2 was on the top, towards the diaphragm. So always we punctured segment 3 for EUS guided hepatogastrostomy bar other interventions. Unless you are only planning to do an antegrade roundabout procedure, then segment 2 may be okay. But otherwise, it's always better to have a segment 3 where you have several options available depending on how your guide wire moves. And this is segment 3 going into the left hepatic duct. Let's turn around, we'll stop the Doppler and get the anatomy in focus. This is the aorta. And if I move down the aorta, you see several lymph nodes coming up. One of the this is the celiac artery. And this patient had few lymph nodes around this area, which we had FNA'd, and that came as positive for malignancy. So the highest stage lesion we had FNA'd, this is the node. Yeah. Below that. Okay. And let's go further up into the duodenum now and see, or maybe let's see the portal vein from here. That's another way of looking at. As Jahangir was showing, to look at the liver, then the portal vein by clockwise turn. Sometimes I move my scope very fast and I overshoot the lead. That's adrenal gland. Adrenal gland, and again back to the left lobe. Let's move little forward. Let's go forward a little bit more. No problem. And come back from there. Okay.
Come back further.
Yeah. This is the porta.
Yeah.
So now we see below.
We can see the porta now.
More clockwise.
Torquing me more.
Yes. Now this is the porta. Yes.
That's the portal vein below. But I am in a very awkward position.
Yes.
And I don't want to stay in that long before I get a cramp or something.
Patient is flat, no, that's why 90 degrees more.
I would have turned myself upside down and had a. So now I've got in the duodenum now.
Okay.
See a little bulge there, but as this is the right lobe lower part, segment 6 now. So this is a segment 6 duct, just from the duodenal top we are looking at. And if I turn around, I will see the CBD and other things, structures from here. That's the, okay, so that's a CBD, uppermost part of the CBD, and the tumor is here.
Yeah.
You can see the tumor inside. Portal vein is behind. And if I turn around here, in fact, the portal vein also looks to have a thrombus inside, looks like something inside it. And that's a cystic duct area, which also has a tumor inside. Or it can look like a node. So now this patient has a type 1 block, and that's an advantage. The confluence is patent. If I see the lower end of the CBD, that's the lowermost part of the CBD. Even there we see some kind of sludge inside. That's the PD over there.
Yeah.
So we will do a hepatogastrostomy. So let's come back to the procedure proper. And for that, let me decompress the stomach. Lean. Left lobe. So this is the left lobe. Can I have the fluoro image ready? Make it a little bigger. So you see the scope is looking at the fundus, which I don't want. I want the scope tip to look at the screen.
We have fluoro now.
Fluoro again. Continue fluoro. So I have turned to this side.
This is good. Yeah.
So this is what I want. So the tip of the scope is looking towards the hilum. And that's why my guide wire is going to go. It's going to puncture this duct, and the guide wire is going to go up and then turn down towards the CBD. So this is a very juicy, nice bile duct, intrahepatic bile duct. I'll get a Doppler there to rule out any interposing bigger vessels. So Vinay, you happy with this? And the audience is?
Very, very nice.
And I also want some liver parenchyma in between the, so if this is my point of last point and the needle comes from here. So this duct is about 9, that's quite good. And another 3 centimeters of liver parenchyma. So that's quite a good cushion I have. We should not be hitting a very peripheral duct because sometimes that can lead to bile duct and unnecessary pain during the post procedure.
So what needle we are using here?
So I'm using an Olympus 19G needle. This is 19G
Easy shot.
Easy Shot 3. Come back. Once we load the needle, the scope becomes a little stiffer. It's a spine added to the flexible scope. Can I have the fluoro once again? Okay. And my needle is removed. The salad has been removed. It's primed with contrast, dilute contrast. Little bit more.
Yes, a little bit more. Little bit more. Little bit more.
It's tenting over there, so I'll just
Yeah.
pull back a little bit and see. Maybe
Still
it's in.
tenting. Maybe one slow jab. There is some vessel just in front
Opposite-
of it. So we
opposite
are
vessel.
just taking a gentle jab here.
I think it looks okay. But I'll turn around and see. Yes.
Some
You have
more.
to puncture a little more.
Yes, little more is needed. I think.
I have pulled back a little bit. And
Yeah, I
see.
think we are in, sir.
It's okay. It's
Yeah,
okay.
We are in.
When I want more.
Yeah, perfect. Now it is good.
Okay. I'll turn around and see. It looks okay now.
Now
It's fine.
good. Aspirate.
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 This is the good.
Yes. Maybe we can. We could not see the bile.
Now
so
something is coming.
Bile will come. It will come.
It sometimes white bile also may not be visible because
yeah,
it's caused contrast. So let's inject some contrast and see. It's turbulence inside, so it's duct only.
Yes.
Okay.
Excellent. Very nice. Good position, huh, Sandeep? Very nice position.
Now let's see the guide wire and then only I'll say it was nice position.
No, see, beautifully it is going.
So we remove the contrast syringe and pass a guide wire. I'm using an 025 guide wire angle tip. Jag wire.
Yes. So here we are using directly stiff wire, but the tip is
hydrophilic
and angle tip and
If
025.
fluoro can become maximized a little bit more, magnify. Stop.
I think we can pull back
No,
and
pull back.
and again reorient. Pull back. Yes.
Pull back.
Pull back, Srinivas.
Purandalilla.
Yes. Rotate now.
Now I try.
Yes.
That's better.
Yes. That's
So this was the direction that we saw it. Took an upward trend. Can you push down if it goes across? I think it will stay there. So we'll now exchange the needle, leaving the guide wire inside and use a cystotome on top of this.
So we can see the nice segment 3 duct and the guide wire is going up at the joining of 2 and 3 towards the left hepatic duct.
So I'll keep the guide wire in my view. I will not lose the guide wire, which is here.
I think the guide wire has reached almost up to the stricture level.
The top of the tumor, it's
Yes,
there.
yes, top of the tumor.
Okay, so higher. As Vinay was mentioning in the previous case, always keep the guide wire in view, and that's the most important lifeline that we have. The moment you stop seeing the guide wire, something is wrong. I'm passing a coaxial 6-French cystotome, which is going through the cap of the scope. Because for needle, we have to remove the cap, but we re-put the cap, which goes through the guide wire. The guide wire goes through the cap, sorry, it's the other way around. Anyway, now the cystotome is passing over it. And we use the same setting as we use for ERCP for the burning the fistula, for creating a fistula between the stomach and the liver and the bile duct. So here comes the cystotome. Cystotome is here. You can also check on the fluoroscope, it's visible there. All set. Current setting ready. So I'll now burn my way in.
Yeah.
Little bit wire.
Yeah, white taut.
Keep it tight, right? I'll just push little bit more. I think it's in now. Yes, it's gone up. That's good. And let me take that turn down so that I can then manipulate the wire down.
Yes.
See,
If
the
it
role
goes-
of the assistant is extremely important. See how the two are coordinating. Then only it functions well. It's extremely
Okay, here it can take a downward trend. Tight wire, tight. Yes. So so that's a very good now.
very nice. Very nice.
Now I'm looking at the top of the stricture.
Now you can inject and see
We
what-
can inject and some contrast and see. Just for demonstration, although it's not very essential since we have the anatomy from other imaging as well as the previous years. So this is top of the common hepatic. You got the air going in and the duct.
Beautiful, beautiful.
Stricture. So this is the type 1 stricture. Right and the left are getting filled up. So if my wire goes across the stricture, then I have a two more options available. Either I can do an anti-grade stenting or I can do a roundable also. So just try once. But that's more of academic interest. Where is the tip of the symptom? I'll pull back a little bit. Now you try.
From
Try
here
some-
we can try
Try.
the guide wire manipulation.
You can take a termo now. A termo. It's a tight stricture, nothing went across.
Yeah, not a drop.
Not a drop of contrast went in. But I won't give a very, I'll just give a gentle try, 1 or 2 attempts. If it goes through, fine. Otherwise, I'll do hepatogastrostomy. Because the bile keeps leaking from the point of entry, and that's the cause for post-procedure pain. Although the hole is very small, it's a very small, tiny bile which will come out, but nevertheless, bile is bile and it's very irritant to the peritoneum and to the patient.
No, there is
Cross-
contrast in the catheter. It will not move, I think.
That exchange is causing a little bit of time, but it's worth it. One gentle try. It's coming to the side hole. So he'll now coil and torque and take it across. So it's going now. Fluoro, please. The wire will now come. This is a pure thermo wire, which is now going to the right side. But we'll see if it can go across. I'll just station to the top of the stricture.
Yeah, there.
Torque there only. I think torquing will help rather than pushing because it'll bounce off the stricture from top. Fluoro. Leave it. Jahangir is saying leave it. Srinivas says continue.
Okay. For
What
me,
was
this
the audience?
is the exciting part.
Ah,
sir. For
just
me,
one. Okay.
here, yeah.
Yeah, यहाँ पे stricture इधर है.
Direction.
I am at the top of. Withdraw the wire and then try now. Yeah.
Other direction. Towards the papilla, you rotate the wire.
Yes, yes,
Yes,
yes.
yes, yes,
Yeah,
yes,
yeah,
yes.
You are in. You are in. You are in. Fantastic. Push the.
Push. Fantastic. So I have
Perfect,
now,
perfect.
I'll
There
push my sphinctotome down. It's not crossing very easily. It's very long from the scope tip. It's actually across the papilla now. And now I think I have come across the papilla in the duodenum now. Contrast dale? You can put a little bit of contrast to just see where the papilla is. So that opens now 3 options, as we said.
Yes.
2 more options, that is antegrade or the rendezvous. Little contrast. So what do the audience want? We can do audience poll meanwhile.
It saves money for the patient also.
So that's
Yes.
a duodenum.
Yes.
Okay, just rotate the wire towards the other side. Screen. So that's the third part. Now it goes down. Now try kar. Either done.
Other
Towards
way.
the third DJ flexure side. Yes,
Yeah,
yes.
Beautiful.
Fantastic. So that's what we want.
Great job.
We can identify the papilla site also, so that.
So papilla, if I pull back, I think this should be the tip of my.
Yes.
Now the tip of the cystotome is the tip of the papilla. So what do people want?
I don't have a way to do audience poll.
Okay. I think we'll do a hepatogastrostomy because there is some duodenal deformity. This patient can have a enteral obstruction. So
Okay.
let's change the wire. Okay, I'll take a long wire, stiff wire. My personal preference is to stay away from the tumor area because
No, I agree.
because eventually that will cause the blockage of this biliary stent, and reoccurrence of jaundice then becomes more common. Although that's not the physiological way, but since the outward obstruction is not very obvious except for mild infiltration, but that is going to expand with time to come. So now I'm exchanging the termo wire, keeping the cystotome in the third part of duodenum with a long stiff wire, and then hepatogastrostomy stent, which will use a geobore stent. You can
Lot
open
of
the
people are
geobore.
asking for HGS, Sandeep.
So HGS only will do. So we will follow as requested and demanded by the audience. And you can see on the EOS image, if you have, you can see the guide wire now. This is the path that we are following, little curved cystotome path. This is how it looks like. It's never straight, it's little curved. Cystotome is a flexible device. Okay, कोई बात नहीं. Take your time. There's some little technical challenge.
We can use
A different wire, straight wire will be better.
Sandeep.
Yes.
There is a question from Dr. Gyasul Hassan from Pakistan.
Yeah.
If you don't have geobore or other specialized stents, can they use partially covered biliary metal stents?
So I'm using a partially biliary covered stent. The uncovered part is towards the liver side, and the covered part is in the liver parenchyma and the bridge between the liver parenchyma and the stomach. So I'll show the stent before I deploy. First, I'm doing the exchange, pulling back the cystotome, leaving the guide wire inside. So Gas, I'll just answer your question in a minute. Let me do this exchange first. I'm always looking at my EOS image so that and the fluoro simultaneously, almost simultaneously, I would say. Okay, so here it is. Can I show the stent, please? The cover of that. So that has an image there, which may I request Jahangir to just hold it and show that.
see this stent here. So this is the stent. Here we are taking a 10 centimeters length stent, and the proximal part is uncovered. This goes into the liver and the duct, liver parenchyma.
So this is the
covered part comes into the liver parenchyma, the bridge area, and also into the stomach.
And we will leave a long length in the stomach.
So, Sandeep, the question Gyas is asking is, suppose they don't have this stent, can they use partially covered biliary stents?
So you can use a partially covered biliary stent, which has uncovered segment at both the ends of about 1.5 centimeter or so. So the 1.5 centimeter will be in segment 3. Little bit covering would be in the biliary duct as well as the liver parenchyma. The entire covering will be in the liver parenchyma and the bridge and the stomach. And the gastric end will have some uncovering. That's okay.
Yeah.
Fluoro, please. Fluoro. So now I'm passing the stent.
Are you locking any of your wheels right now? That is one question.
Nothing is locked. Nothing is locked. So the stent has gone in. I don't dilate further after the fistula. The assembly has gone in. I'll take the turn down a little bit and then deploy and then pull back to readjust. Not the other way around. So you can start deploying now. Magnified view, please. Yes. So you see this stent has a, can you please a picture? And there is a mark between the uncovered and the covered segment. You see this mark?
Yes.
And that's a very important mark. So distal to that is uncovered and towards the scope is the fully covered part. I will keep this point at this spine level only. I will not change it. So that's my major point of focus now. Release, please start releasing, start deploying. It will try to go in. I'll pull back a little bit. Okay, deploy. As it gets deployed, it goes sucked in. Yeah. I'll pull back and keep it here. Keep it here. Okay. So I am only looking at that transition mark. Open. Go, keep going. Good. So now I've come inside the channel. So I have two options now. Either I can deploy the scope channel or I can see it endoscopically. What do you like, Jayagir?
Endoscopic visualization is better.
Okay, that's the drama is there. Okay, so let's do the endoscopy view. I'll keep seeing that fluoro image also.
Yeah, it is most important. While we are shifting to endoscopy, have a complete vision of fluoro.
So
And
release. A long segment will be there. Don't get worried about it. This is expected and we want that to happen. At least 3 to 5 centimeters can be left like that. Thank you, Srinivas. Oh, okay. The wire is still in. So you can remove the wire. Nothing.
Fantastic. Very nice drainage.
So as I pull back. It's got entangled with the elevator.
we can push with the 10 French catheter.
No, it's got disentangled. I turned the scope other way around.
Yeah.
So that's a small trick. Jahangir and the technician picked it up. So that's a very important. Thank you, Jahangir.
I can be sufficient length of stent is in stomach, so there is no worry.
So this stent will generally shorten with passage of time. And because it shortens, it can go a little bit inside. So if you leave only 2 centimeters in the stomach, 2 days later, this stent will go into peritoneum. So leave a long length. If you check it again by endoscopy, you'll see that of the 5 centimeter in the stomach has actually become 3 centimeters. It's still in safe zone. I think we'll move to the next room now, where Mohan is ready with a very interesting case and for endoscopic necrosectomy.
Fantastic. Great show. Sandeep, very, very nice.
Thank you.
Yes, Mohan, I can see.
Hi, Vinay, and with me, Dr. Rajesh.
Hi, Rajesh.
Hi.
So this is a 40-year-old male, has acute necrotizing pancreatitis, underwent drainage with Spaxer stent. Post-procedure, even after 48 hours, patient developed fever spikes, and CT has shown a lot of residual necrotic debris over there. So we need to go in and do some of the necrosectomy. But the problem here is that we use most of the time the snare, but the snares, is a very cumbersome technique, and most of the time we end up doing partial macrosectomy. But now we have some of the innovative device coming up. This is from OTS. This is the OVESCO device, and this is known as OTSG, over the scope grasper, and it is an excavator. It has got a very large plastic forceps-like mechanism which grabs a very big chunk of necrotic debris, and you can remove these necrotic debris very easily. So we'll be showing this installment first of all. So it has got the cap which can be controlled with this handle, and you can see we can open and close. See that is open and this is closed, and this cap can be mounted on the distal end of the conventional endoscope. So we will mount it first and show you. It has got a plastic sleeve also. So the first of all, the scope shaft need to go through this plastic sheath, and through this sheath, this is mounted there. So I'm just, it's like a normal cap which we mount. That's how. And you can see, only thing is we have to open and check whether the therapeutic channel, the good thing about this is the therapeutic channel is still free. So you can use this therapeutic channel even with this OTSC device mounted. That means I can pass a snare, I can pass a rat tooth forceps, even through the therapeutic channel. It is still open.
Use both devices. You can use
both the devices. Yes. So that's it. So we are ready now. So the first thing which it comes also with many adhesive tapes. So can you open these adhesive tape? So now this the shaft of this device will run parallelly onto the shaft of the scope. So you need to cover this. To cover this, you have to open this. This is nothing but a polythene sheath which will act as an additional security. There should not be a air gap, or it should snugly fit the scope. So Madhu will help me in getting it taped properly. So we are just taping it. And you can see it is nicely taped. The distal end of the sheath, the sleeve, it is like a sleeve. So I'm just keeping opening. You can see now. I will apply 2-3 sleeves. And then once it, then we have to remove this plastic sheath by just detaching it like this, and this will be thrown away. Meanwhile, we'll attach this sheath on the proximal end of the scope also. Like this, and we'll apply 1 or 2 tapes in between also, just equidistant, so that the sheath is snugly fitting the shaft of the scope also. So we have created a sort of additional channel which is lying outside the scope, and our therapeutic channel of the scope is free. So that channel which operates the tip of this excavator is running outside the scope. So that's how we create this, and you can see now open. See that now the scope tip is equipped with an excavator which is a transparent thing. So you can see close. So you can simultaneously see through this. And then there is a channel for the guide wire also. If you want to proceed on a guide wire, it's also okay. So we'll go ahead, and now we are ready for the insertion. Patient is in the left lateral position. So this patient, as has been narrated in the history, that the Spaxus stent is already in place. This patient is in sepsis. Patient has large necrotic cavity residual. So so now you can see can we apply some jelly over there, please? KY jelly. Okay. We'll go ahead now. We can see through the scope. You can see the cavity of the esophagus, lumen of the esophagus. I'm going down. And now I have entered into the stomach. So we have to find out the stent now. Can you open and see? Open. So sometimes you may have to use, I will just suck out this water. There's a lot of bilious fluid in the stomach. Will suck out so that our vision become much better. And then I'll locate the stent first. Where is our stent? Screen. Screen.
Do you feel any maneuverability issue, Mohan, with this device?
No, it is detached, I think. We'll come back and reattach it. Maybe slightly, we have to snugly fit it. I'll just reattach it and come back. After attach properly. You fix it properly. You have to apply cap on this. So the problem is that we did not apply the cap on the yes. So we will reattach the cap. That sometime happens. Plaster has to be applied not only on the sleeve but also on the cap so that it does not detach.
I think it needs to be these adhesive tape provided are not strong enough.
You have to apply. Put it fast. And then that open should not be on the therapeutic channel. Open. Open. Yeah. Open. Open and locate. So here is our stent closed. Okay, so we'll go into this stent now, like this. So the angulation of the stent is slightly in. I'm trying to get into this. You can see now with this, we have gone into the cyst cavity. Can you see the fluoroscopy, please? You can see now we are entering into this necrotic cavity. Sometimes you may remove the stent and do by dilatation also. And in our previous experience, we have done that.
So what is the advantage of you see with this device with the freehand necrosectomy versus?
No, this very large chunk comes out. Unfortunately, this is not going into this stent.
How do you make sure you're not catching the underneath vessel in that?
Yeah. So that's a atraumatic, almost atraumatic. And previously we have done in two of our cases where we did not use. Can you open? See that open? It's opening. No, it is not yet gone into the cavity. And because of the angulation, that's why we were talking about what is the perfect position.
Yes.
But here, can you see that screen?
Because
see that there is some angulation there. That is why it is not going. But probably we'll remove the stent and show. But usually it screen. So see that it's not going through the stent because the stent, this Spaxa stent may not be the ideal one because it went through Nagi stent, but Spaxa stent is slightly maybe
because of it, the flanges are turned upwards.
Yeah. So we came out. Again, we'll try to get in. Screen. Do you think balloon dilatation will help?
Balloon dilatation, I don't think is going to help on. The thing is because you rightly said it's the angle actually.
Yeah. So we used it without stent also. What we will do is we'll come out, we'll go to the another case. Meanwhile, I'll just remove the stent and do open. See that now it's open and then wash. And this is the excavator. One more time we'll try. Okay. Close. So we'll see where is the stent. Flush. See that the channel is still working. So this is a new device. It's a very important device. I thought this was given the innovation of the year by ESGE. So the open. So we are not. Problem is that this is not going through the narrow opening of the scope. So the only option is we remove this stent and dilate that stoma and go again. Can you give me the scope? I'll just remove the stent.
No, don't remove the stent. Don't remove the stent. Arre.
Huh? Scope. Will so this device still is very, very important. There are certain,
Hello?
Yes.
Satya, can you hear me? Mohan?
Yes.
Can you hear me?
Yeah, I can hear you.
I'm in the other room, but my suggestion is not to remove the stent and use a separate device. I think this is a very angulated entry into the stent, into the cavity.
Yeah.
And that's why your device is not going. I think instead of removing the device, use a snare or something.
We can do that, but
once you remove the stent, this may not be able to replace like Nagi. That's the reason I'm suggesting. So you can just show once with a regular endoscope and see if you can remove the necroma with that. If you want, we can come back to the other room and then come to you later on. Or what is?
Okay, you can do that.
Okay. So can we come to the other room, please? Hi, welcome back. So can we have the slides? So this is a 50-year-old male with recurrent vomiting because of gastric outlet obstruction, and this is due to a duodenal carcinoma in the third part of duodenum. The biopsy has come as positive, and it shows some liver metastasis. So it's an inoperable disease. And today we will be doing a US-guided GJ. And to do this GJ, take it out. I have loaded. Can the room camera? This is a CT which shows the tumor. So if the room camera can show me, I have used a forward wing endoscope with an over tube. This is the over tube which is actually used for enteroscopy, single balloon enteroscopy, a short one. And through this device, through the endoscope, we will pass a guide wire across the stricture and pass a double balloon, E-pass balloon which will help in anchoring the adjacent jejunal lumen or small ball, proximal small ball lumen. And we will inflate the two balloons with contrast fully so that it anchors well, and then intervening area we will fill with saline and contrast and the coloring agent. And once we distend the intervening lumen, we will then pass a hot axios at 20 mm to create a gastrojejunostomy. So once Mohan is ready, we can switch back, but I will start the procedure because this is also a little long procedure in the sense that it is several steps. The reason we use this EPAS balloon is to create safety. It can be done freehand and expert hand, but GJ, it may look similar or simpler, but sometimes it can be can cause challenges. So the stomach is clear, reasonably clear. He had a Ryle's tube or a nasogastric tube for decompressing. I am passing my endoscope towards the pylorus with the overtube inside. Through the overtube, the scope has gone in. It's a regular upper GI endoscope. You see some blood there because the tumor is a friable tumor. This is the first part, and you see the tumor there. Then you have a catheter now, which is completely occluding the lumen. Whenever Mohan is ready, we can switch back and then come back to this case. But meanwhile, I'll continue with the procedure using a ball tip cannula and a hydrophilic guide wire. The fluoroscopy is important. You can see the little bit of lumen in the center through which I will try to go across here. Can you pass the guide wire? So fluoroscopy image now, yeah, the guide wire has gone in. And now you can pull back the wire. You can go deep down. Yes, very nice. Keep going down. Withdraw the wire, please. Withdraw the wire. You can put little contrast if you want. To see where the small amount of contrast to see the path of the small bowel, because sometimes there can be malrotation or anomalous anatomy which is not visible. Okay, no. Okay, saline, little bit saline. Green. No, it's coming back. It has to go distally. No, we didn't get the outline. Little more contrast. Okay. I think it's gone down. Yeah. Okay. Saline. So it's taken a U-turn there. This is a little bit of anomalous. Okay. So the contrast went like that. Okay, the arrow was pointing towards that. Yes. Okay. Try again. Yes. Little bit. Okay. Now we draw the wire. Now try. It's taking a loop there. So this is another anatomy. It's not a straight DJ flexion. So can we go on that? So Vinay, you can see it here. It's a very anomalous third part of duodenum.
Yeah. It's going round and round.
Round and round, yeah. Anyway, we'll keep the wire as deep as possible, and then we can. So that's fine. I think that should be okay. Can you go take the wire deeper there? Yes. Okay. Yeah. Okay. But I finished the length of the catheter here. So let us exchange now. You can just a minute. Let me go deeper, little deeper. Okay, nikalo. Take out the wire and then put a longer wire. So this was a short hydrophilic wire that we used. Meanwhile, if Mohan is ready, you can continue that side. Mohan, you ready with the necrosectomy part? Because people must have been very keen to listen to that view that view device.
यार वो उसको
Okay,
अच्छे से
okay.
लगाओ ना.
Anyway, so whenever they're ready, we'll go there. Fluoro. The guide wire is long guide wire is going in. This is a jag wire, which is going through the catheter. The deeper, the better. Properly, so addition. Okay, और जाएगा?
I am dilating the stent. Otherwise, I have to remove the stent. Otherwise, it will not go. Just tell him if
Okay. I'll pull back. You keep pushing the guide wire in. So people must be thinking why you're doing all these things, but I think it to add to the safety of the procedure. The double balloon, we've created a heart-shaped structure on the screen. If you can have the floor screen, take a picture. Vinay, you see the heart there?
Beautiful. So you are going to leave the overtube there, Sandeep?
Yeah, I will keep. First, I'll take out the cannula, leaving the guide wire, and then I will remove the overtube after passing the e-pass balloon.
Yeah.
There are several steps. Push the wire, push. I am pulling the catheter. Okay. I am withdrawing the cannula. He is pushing the guide wire, Srinivas. Let me just push it a little bit more. Okay, now. No. Okay. So my cannula is now in the scope. I'm pulling back more and more and leaving the guide wire at its place. Once the guide wire is okay, then I'll push the overtube to the pylorus. And the whole purpose of the overtube is to prevent any looping in the stomach. Because this overtube is very flop. This e-pass balloon or double balloon catheter is very floppy. You have the fluoro image there, Vinay?
Yeah. Nicely seen.
Okay. I'll overtube. Hold the overtube. I'm pulling back the scope now, leaving the guide wire in. Okay. So now the guide wire is out, and over this guide wire, we will pass the long e-pass balloon, which I want to show to the audience. This is a balloon which is made by Takao Itoi. So this is it's a Japanese language written here. It's called L-type balloon. And it's a very long system, almost like a double of an NJ tube. And this goes over the guide wire. This has several parts to it. It is a 4-channel device. The 2 channels are meant to inflate the distal and the proximal balloon. One lumen takes the guide wire on which I'm passing, and the last channel allows us to fill the intervening area between the 2 balloons. So now I will pass this. The guide wire has come out. So a lot of length is inside, and A 460 guide wire we are using. Okay, we'll pass it like this and see how it goes. So keep the wire tight and I'll push it in. I am now passing the E-pass balloon. You can see the lead balls which are going through the over tube over the guide wire. The tip of the over tube is in the D1 and they cross the stricture now. This is the stricturous area. And now we have gone deep down. It's moving forward. So lead ball is leading the way. There's a marker just behind it. The cameraman can focus that. So the fluorotechnician can focus on the marker of the balloon. Yeah, that's the front balloon. And as I push it forward, the second marker will be seen now. That's the second marker on the arrow. Yeah, that's right. So we'll keep moving it forward as much as I can. So both the markers are also moving. The intervening area between the two markers, that is two balloons, is 20 centimeters. So now we have the balloon deep as much as we can. Pulling back is always easy. Pushing is the more difficult part. What do you say, Jahangir? You can leave it here. I think it's okay. So we will target this loop here in the center. And okay. So maybe we can pull back a little bit. That means. Anyway, leave it here and see. If Mohan is ready with that case, we can do till we exchange this. Okay. We can go to the other room.
Yeah.
Where Mohan is doing the necrosectomy. Mohan?
Yeah.
You're on.
Yeah, okay. So what we did was the spexus was slightly constricted at the shaft level. So we went ahead and did balloon dilatation of the spexus. And can you see the fluoro, please? You can see that the stent has gone. Now this close, you can close now. This is closed position. So I'll go to the necrotic cavity, open, and then suction, do suction, and then you close. And you can see there is a, still we'll open please. So we'll go to the necrotic material there. That's the shaft of the scope. And this is the necrotic material there. We'll try to go open, close. Open. Yeah. Close. Yeah. So you got some necrotic there. So we'll now pull back screen. So you can see that the big chunk has come inside. And I'm pulling this by doing some jiggling maneuver. And then you bring it out and leave it outside. Open. Yeah. So open. Flush. So again, we'll see that the use of the therapeutic channel scope. You flush out everything, close again, and then again we'll go. This looks cumbersome, but as we gain the practice, we'll be able to use it more easily. I prefer it to use without stent because the shaft of the stent sometimes pose a resistance to this device. Can you open and see? So sometimes if you want to see where is the stent, you have to open and see through it because most of the debris will be stuck on this. Again, I'll just suck out everything. This patient is not intubated. We have done a lot of flushing and removal of debris. And you can see here again, there is some issue, which is the device is not snugly fitting. Because of this to and fro motion through the stent, this tape is coming out. So my personal opinion is to remove the stent and do the necrosectomy because in one go you can do most of the necrosectomy because the stent is causing some issues because of the wires and the longish shaft of the stent, this stiff device may not be a good option. So what I will do is I'll remove the stent and then replace the stent. Otherwise, we'll not be able to do the necrosectomy in this case. Can we remove the stent, please?
Okay. So we have come back to the other room again for GJ. I pulled back a little bit of the balloon. Can you have the fluoro again? Fluoroscopy and the US image. Yes. So as you can see, now we will inflate both the balloons. Can you inflate now with contrast? And you can see on the fluoroscopy.
Make the fluoro big.
Fluoro has to be biggest. Yeah, so that's a front balloon.
Yes, yes.
And the back balloon also is getting inflated. So we will fill it with about 40 cc of contrast and saline solution. The purpose is to inflate it in such a way that it hugs the jejunal limb or the small bowel loops. And once it is tightly fitting that jejunal loop, it anchors this loop and then it doesn't move. This allows the interposing area between the two balloons to be filled with saline, contrast, and coloring agent, which will then allow us to drain it just like the US pseudocyst drainage using a hot axial stent. Meanwhile, in the US, you can see this is a small bowel which is coming and going, which is peristalsis there. So at some point, we'll also use antiperistaltic agent. Maybe we can give it now.
बहुत लंबा stent है.
So the balloon is how much heavy? In 20 cc in the front balloon, and the back balloon, Sridhar? 10. So we want to go to 40. Keep going, keep going. I can also sometimes look on the US at the balloon. Fluoro? I'll try to come closer to the balloon. Some of the one balloon we can see somewhere there. Maybe here. So maybe the balloon is somewhere here. This is the tube which you are seeing. Okay, so this may be the target area to some extent. The balloon is here. Here the balloon is. This area of the balloon. I can see that you can see some swirling movement inside. How much? 40? 40 over in the front balloon. So you see the shape of that balloon is like a cylinder. That's the balloon, you see it there. So both balloons are now decently inflated, and you can see the balloon inflated on the US image also. Vinay, you can see. Okay, now fill the intervening area. Fill the intervening area with the contrast first. So this is the limb which will start filling. I'll make some readjustments when the loop gets distended. Now, please go ahead. Go ahead.
So you're filling the water between the two balloons now?
Yeah, we're just about to fill contrast first. And yeah, that's the contrast which is coming up. And then we'll follow with some saline.
Achha, do you use methylene blue?
And a methylene blue. So we'll fill it about 100 to 120 cc. And I will try to keep looking at a perfect site of where the puncture can be made. Fluoro, please. Fluoro. Fluoro.
I find this procedure, this e-pass tube very cumbersome, Sandeep, my personal opinion.
Yeah, it's cumbersome, but adds to the safety. I think ultimate thing is safety. I think this loop looks quite good to me. It's a long length which is taking me there. This should get filled up now. How much has gone in? 50 cc gone in. Some contrast is leaking forward also. You can see that. So it's still not hugging in spite of almost the maximum inflation. I should be aware of that.
The balloons, no? It doesn't. Some goes.
So some goes beside the balloon too. Okay.
Yeah.
The stent ready? How much has you filled here? 80. Because something has gone.
Need the water.
I want to fill this. This limb has to get filled up now, which is my target.
Yeah. Can you make the EUS image big?
A US image big now? US image big? 100, okay. About 20 has already gone beyond. So can you
Yeah,
build the
that's
forward balloon 10 cc more?
not a
Forward balloon.
full.
I'm just filling the forward balloon little more because some of the contrast is leaking forward. So, हाँ डालो 5 cc 10 cc डाल दो 5 डाल दो okay, but it should not burst then the whole thing. Okay, now I fill the intervening area now quickly. Stent, give me the stent. I'll keep it ready, everything. I'm using a hot Axios. The moment I get that opportunity, I will go in. 120 हो गया, उसमें से 20 आगे चला गया. So that 120 is not 120, it's only 100. Keep putting more, keep filling more because it's leaking forward also.
You have to put all 200 to 300 cc's. नहीं तो मजा नहीं
Put some more, put more. Continue, sir. Continue. This is my limb which has to be filled in.
Yeah, 300 cc's डाल दो.
You can see the fluid. Okay, don't worry about that 140. So this is a nice limb which is coming up, but still not fully distended.
Yeah. Now better. करते जाओ. 300 cc's तक डाल दो.
I'm keeping it ready. As soon as it comes up, I'll probably do something. So I've got my stent ready. I've got the little bit of, yeah, that's nice. I'll go in. Okay.
Yeah.
I'll remove that. So I have burnt my way in. Little bit more I can go. Okay, stop filling now. Remove the lock. So deploy the inner flange. So that's in. Pull back little more to deform it. That should be okay, Jahangir?
Yes, that is perfectly fine.
Okay,
We'll
so lock it
here.
again. And let's do it endoscopically. No?
Channel is
Channel is always better. Okay, Jahangir wants channel this time. Okay, so let's do it here. I'll deploy the channel, deployed here, and then we have the endoscopy big.
Yes, now we can come
Now
and
we
push
can-
the scope stand.
I'll pull back the scope little bit and move away, and you can see the stent there, and that's it.
Beautiful. Lovely.
So now the blue color in the stomach confirms that our position is accurate. I will remove the assembly, suck out all the fluid because I don't want aspiration to happen. This stent will actually expand on its own in next 3 to 4 days time. We can start clear liquids by late evening today after 6 hours or so. But before we remove the assembly, I need to deflate both the balloons. So can you deflate it now? We can go back to other room where Mohan is ready. Meanwhile, I'll keep sucking this fluid out.
Nice, Sandeep. Excellent.
We are still struggling with this new device because of the position of the stoma. Because the position of our cystogastric stoma is in such a way that I have to create a right angle to go inside. See that? Now we have gone in, but again, I am doing the necrosectomy. Can you open? We are inside the cavity now. Can you open, please? Yes. So there's a lot of muck inside. We are removing it one by one. And you can see there is almost it is cleared. But this device may not be good in all the situation. You can see now I am catching this big close. You can see now it has come again inside, and then we'll see
How
that.
do you know, Mohan, that there is no blood vessel in what you are catching?
Yeah, so that's what the Rajesh question was there. Open. So I give a gentle close. Okay, so yeah. Screen.
Dr. Vinay, I think this is always a valid concern.
Open.
The only thing is
Open.
we should loosen up the tissue
Flush.
first and then try to catch it up. That's the way, only way you can try to avoid the
I agree.
I came out. I'm in the stomach. So I caught and came out. See that? So then that is that.
See, the two problems I can straight away see is one is the visibility. It hampers the visibility. And second is, if you're catching something, you have to be sure that there is no vessel there.
Yes, that's the biggest concern. Yeah.
Close. Okay. So
maybe in the next couple of months, we will have a improvised version of this device.
Good version, yeah. And maybe Mohan, as Mohan says, probably Spexus, it doesn't work so well in Spexus, works well with Axios and Nagi. That also is something which we need to know.
But most important thing, Dr. Vinay, what we are doing is basically the angle, which is most important to get into the cavity.
Yeah.
Usually when you put
and also sometimes you have to come back again, remount it.
Okay, Mohan, I have only 1 minute for you now.
Yeah. Okay, I have done enough, I think. We'll use, we'll go to the another case. I think this is just to show you that there is a device coming up and we need to do more innovations because we are not happy with the stents. Are you happy with the snares? I think it takes very big time. So we need to have some device, and of course this is the one device which came. So we thought we'll use, and our first use was very good. So we were very much enthusiastic about it. In the second case, we are struggling because of the angulation of the approach. And as we were doing initial drainage, we were talking about that how easy is to go back again into the stoma. So that point also we have to discuss while doing initial drainage, because screen, can you show the screen please? See that my scope is in very long position now. And then we have to angulate and get in. Had this been in the cardia, I would have easily gone with the straight scope. Now I have to go into the antrum, angulate, and then because of the limited visibility, there are some issues.
Yes, and I think it makes the scope tip also stiff, like any.
Yes. So that travel through a long, like a Spaxus channel, the shaft of the Spaxus, and that is the issue. So I think we'll move out to the next case and we'll work on this by the different device which we have.
Some time, Dr. Vinay? Do we have some more time, Dr. Vinay, for next case?
No, we are done, Rajesh. It's done for the 4:45.
Okay, thank you very much for giving us this opportunity, Vinay.
Thank you very much. It was great. So many fantastic cases you guys have shown, new techniques. The GJ, the HGS, this necrosectomy, fantastic. And US biopsy from Jahangir, Anuradha, all of you guys have been too good. Fantastic. As usual, nothing new in that. So thank you very much, Srinivas. Thank you.
Thank you, Vinay. On behalf of AIG and all my colleagues here and friends here, I would like to thank Vinay, AEG, EUS, TTT, and all the friends in the Asian and other countries of the world. Thank you very much for your attention.
Fantastic.
Bye-bye.
Very, very nice demonstration. Congratulations. Very good.
Thank you.
So now, Priyanka, I think it's the last part where I summarize everything, right?
Yes, sir.
So we had a fantastic day with a lot of interesting cases, very, very difficult and interesting and challenging cases, plus some basic cases also. I think we saw pseudocyst drainage, we saw Nagi stent placement, we saw a choledochoduodenostomy, we saw a hepaticogastrostomy, we saw a GJ, we saw necrosectomy, we saw variceal coil embolization. I think it has been a very, very fruitful day, and all the faculty, the entire faculty demonstrated the cases proficiently and taught us a lot of finer points which we all need to learn before we start interventional EUS. So I would like to have feedback from you guys, how things are, how did you like all this? Did you like this method that we followed? So we kept very few lectures. Most of it was to teach you practical tips, how to do the procedures, what accessories to use, what is the procedure, what are the detailed technical points, what are the difficulties that can arise. So it was a great learning experience for me at least, and I hope you guys also enjoyed the proceedings. Um, Tomorrow morning, I think we have seen practically all the interventional EUS cases. Maybe I will show you one or two. I will during my live, I will not show too many things because everything has been done. I don't think there is anything that is left. What I will do is I will show you the model that I have created. This model, as I told you, is a magic box. How to make that model. If you want to make it yourself, you can make it. It's not difficult. And then how to train on this model. So that would be during my live. I may show you one basic case. That's all. Just how to do anatomy and all those things with some FNA. Because everything else has been shown. I don't want to repeat things again and again. So I will show you how we teach on models, because that's a very, very important part of learning interventional EUS procedures. So we have this model where we will do all these procedures: EUS biopsy, pseudocyst drainage, antegrade stenting, rendezvous, EUS GJ, so multiple pancreatic duct drainage. We will show you all those cases on the model, how we do it. And in addition, we have some fantastic lectures planned for you. Professor Kida will join us tomorrow to tell us about pancreatic duct drainage. Rajesh will be back to talk to you about vascular therapy, and Dr. Matthew Philip will be with us to talk about EUS GJ. So we have an interesting half day tomorrow, 10 to 1. So please join us and give us feedbacks, how we can improve these things. What more do you need? What more do you think we should put into these TTT courses? So thank you very much. Thank you. I see you tomorrow morning sharp at 10 in the morning. We start with lecture of Professor Kida. So don't miss it. Be there on time. Professor Kida starts the session tomorrow. So I also at this point would like to thank Flora. Flora, thank you very much for all the help. Asian EUS Group, Olympus. Olympus has been great. I'm thankful to Olympus for providing all these facilities and the help. And tomorrow we will again assemble. Is there anything else, Flora? Anything you would like to say?
No, just be on time. We'll shop at 10 Indian time. Hope to see everyone.
Yes. Okay. Thank you very much. So goodbye from Mumbai, from Hong Kong. See you tomorrow.
Thank you, Dr. Vinay. See you tomorrow.
Yeah, thank you. Bye-bye.
Bye.
Bye.